Piyush sir is going to join when? Piyush,
9:45. 9:45 inauguration त्याला join होतील. So
खूपचंदानी सर काय पे नाही उचलत फोन. ठीक आहे, मेसेज करून ठेवलाय.
पाहिलं का त्याने?
नाही, मेसेज पण त्यांना हे नाही झालं.
Piyush, are we live?
Yes, ma'am. You can start.
Okay. Good morning. Good morning, everyone. Good morning, all the delegates. Good morning, panelists. Good morning, all our faculty. Today, we start the second session of our midterm CME on infectious diseases. It's a lovely morning. Monsoon has already started almost at all places in India. And we promise you to have an excellent academic session today. The first session, we start today with two most eminent personalities in Indian pediatrics. First is a talk by Dr. Tanu Singhal, and second we will be listening to Dr. Khubchandani sir. The session will be led by Dr. Ramesh Kumar and Dr. Parag Gaikwad and Dr. Pramod Kulkarni. Dr. Ramesh Kumar is the President-elect Indian Academy of Pediatrics for the year 2021. Honorary Secretary General IAP, he has been in the year 2018 and 2019. He is a senior consultant and HOD Pediatrics, Apollo Adlux Hospital, Cochin. Next. Dr. Parag Gaikwad, a well-known senior pediatrician from Pune, Katras area, is a pediatric nutritionist, Olive Clinic at Katras, honorary pediatrician, Bharati Vidyapith, Pune, with special interest in nutrition and infectious diseases. He is Secretary, Nutritional Chapter, Central IAP, Master Trainer, Nutrition and Infectious Diseases, Faculty in Pedicon, Mahapedicon, and President-elect IAP Pune for the year 2021. Next. Dr. Tanu Singhal needs no introduction to any pediatrician in India. She is a very well-known entity, consultant pediatrics and infectious diseases, Kokilaben Dhirubhai Ambani Hospital, Mumbai. National Convener, IAP Committee on Immunization in year 2007-2008. Executive Board Member, Fungal Infection Study Forum. Member of National Technical Expert Group for Pediatric Tuberculosis. Advisor to ICMR for Antimicrobial Stewardships. She has more than 75 national and international publications in all the index journals. She has 2 books and 20 book chapters to her credit. Next, Dr. Raju Khubchandani, another stalwart in Indian pediatrics, Senior Consultant Pediatrics and Sectional Head, Pediatric Rheumatology, SRCC Hospital, Children's Hospital, Mumbai. Consultant Pediatrician at Jaslok Hospital and Research Center and Breach Candy Hospital, Mumbai.
Okay.
Next. I'm sorry, Sanjay, I cannot see this slide properly. Can you please read out? It's absolutely blur for me.
Yeah, I'll do that. So I'll just read out the slide for Dr. Kulkarni, sir.
Yeah.
So Dr. Kulkarni is MBBS, MD and MRCPCH from UK. He's done a PG diploma in pediatric infectious disease from Oxford. Currently is a consultant pediatrician at the pediatric infectious diseases at KEM Hospital Research Center and Smile Clinic, Pune. Areas of interest are of course infectious diseases, and is the convener of the infectious diseases chapter of the Indian Academy of Pediatrics Pune branch. Back to you, Manisha.
Yeah. Oh, thank you, Sanjay. So we will start with a symposium talk by Dr. Tanu Singhal, and the topic is antimicrobial expanding options. The time limit is 20 minutes, which will be followed by a dialogue between Dr. Pramod Kulkarni and Dr. Raju Khubchandani. And the heading is Diagnostics for Infectious Mimics. So, the time limit for this as well is 20 minutes. Over to you, Dr. Parag and Dr. Ramesh Kumar, to start with the first talk by Dr. Tanu Singhal.
Thank you, ma'am.
Can I get
Yes,
going?
yes. Yes, sir. Go ahead.
Thank you, Parag. My co-chairpersons, Dr. Parag, as well as Dr. Pramod Kulkarni. Congratulations at the outset to the organizers, especially Dr. Sanjay Nathu and team IAP Pune, and thank you, Dr. Manisha, for that sweet introduction of the faculty. And it's a great day here. Another second day of the midterm CME, where we have got almost everything infectious disease being covered by the stalwarts only taking up wonderful topics and exciting day here. And the first session is by this on the newer antibiotics. I mean the newer options on antibiotics. And as we have all learned that there is a discovery void in the last maybe from in the late 1980s, where we had the original class of antibiotics discovered first, and then maybe for 30 years we don't have something very much a class of antibiotics, as you say. So that's called as a discovery void. And certainly the research and industry is not much focused on newer antibiotics also, in the sense they it doesn't fetch them much. They have got other molecules. So, but then we need to live with it, and the antimicrobial resistance being tied up to a certain level by the antimicrobial stewardship. I think in the Academy of Pediatrics, heralded by none other than our Dr. Evalis sir. So, so that's on one way helping us, but then we look at and explore options. Maybe we need to be we equipped with the newer drugs or whatever is coming in the pipeline, and the pipeline data also should be there with us. I am sure Dr. Tanu, he's here, he certainly will be disseminating more information on this, what exactly is in the offering on the newer options in the antimicrobial horizon. So over to, it's to your time, Dr. Tanu now, please.
Hello.
Yes, ma'am. You can start.
Yes. So is my screen visible?
Yes, ma'am. Yes, ma'am.
Yes. So I would first like to thank Pune IAP for calling me to give this lecture. And I'm going to be talking about expanding options in antimicrobials. Now, new pathogens and rising resistance in pre-existing pathogens is the trigger for new development. And, classic example is COVID-19, that suddenly, we can, there can be a pandemic and we don't have options to treat. And that is what's happening with COVID-19. So while there are thousands of agents in clinical trials, I'm going to restrict my talk on those agents which are approved globally and may reach us in some time, as well as some of the agents which are now available in India as well. And mostly the adult data is from adults, because most new approaches, they usually go for adults first before they trickle down in children. So these drugs which I will be discussing are mainly used in adults, but are being used off-label in children also in very serious circumstances. And I'm going to highlight some of my own experiences with these agents. Now, in this talk, as was requested by the organizers, I'm going to not only talk about antibacterials, but I will talk about anti-tubercular, antifungal, antiviral, and antiparasitic drugs, which are new on the horizon. Now, the most important is the rise in gram-negative resistance, and in children, it is an emerging problem in PICU and NICU. And the carbapenem resistant rates are high in India, and in fact, in some units, it may be as high as 50%. And this carbapenem resistance is mainly mediated by the carbapenemases like the NDM and OXA, and also sometimes by other mechanisms like porin and efflux mechanisms. So when we are dealing with these carbapenem resistant organisms, we have limited options for treatment. And these options include either polymyxin B or colistin. And you can't use these drugs alone. So you have to use other drugs along with that. And the companion drugs, which we commonly use, like tigecycline, phosphomycin, etc., are also, again, not really approved in children, and the outcomes are poor. So if I would say, then the most important drugs we need now in our country are basically new drugs to combat carbapenem resistant pathogens. And besides, what we are also seeing is a rise in colistin resistance. So therefore, we need new drugs as well. So this is just a kind of, the drugs for gram-negative bacteria. And I'm just trying to focus on the pre-existing drugs and the new drugs. So for example, you know that the most common reasons for resistance in gram-negative is ESBL, which destroy the cephalosporins, AMC, which destroys the cephalosporins plus the BLBLIs. And these three are the carbapenemases, NDM, OXA, and KPC. And of course, there are other mechanisms like porin channels and efflux. So when we talk about the conventional BLBLI agents like piptaz or cefoperazone sulbactam or cefepime tazobactam, they are mainly effective against the ESBL producing organisms, but not against the others. Carbapenems are effective against ESBL and AMC, but again, they are not effective against pathogens which produce the carbapenemases. So now you have a new drugs which have come in, where you have new beta-lactamase inhibitors. So the parent drugs are the old ones, but the beta-lactamase inhibitors are different. And globally, there are many available like meropenem, vaborobactam. But again, the main issue with this drug is that it is not effective against NDM or OXA, which are our main problem. So actually, this drug is really not useful for us. When we look at imipenem and relibactam, again, it is not useful for us because it doesn't cover NDM and OXA, which are our main pathogens. So therefore, we can look at these three drugs, which is basically ceftazidime, avibactam, because this drug covers ESBL, covers AMC, covers OXA, KPC, etc., but again doesn't cover NDM. Whereas aztreonam avibactam covers even NDM and OXA, but it does not, take care of resistance by other mechanisms like porin and efflux. And you have a new drug globally called cefiderocol, which actually takes care of all these resistance mechanisms. So we will discuss these three agents in greater detail because they are relevant to our kind of resistance in India. So therefore, this drug ceftazidime avibactam has been around now for almost a year in India. And it is a new beta-lactamase inhibitor. As I said, it inhibits ESBL, AMC, and certain carbapenemases, but not NDM. And the good point about avibactam is that it is not a suicide inhibitor of the beta-lactamases. So when it inhibits a beta-lactamase, it inhibits it, dissociates from it, and then goes and inhibits another molecule. Therefore, it is more effective. And it is approved in adults for management of ESBL and carbapenem-resistant infections. And it is important to remember that while it covers E. coli, Klebsiella, and Pseudomonas, it does not have any activity against anaerobes, gram-positive agents, and Acinetobacter. And the adult dose is 2.5 grams 8 and it is a well-tolerated drug with no major adverse effects. Now, in Coquilabane, we have been using this drug quite a bit in adults and now also in children. And I just want to highlight one case where we used it for this is a 2-month-old baby who underwent complex cardiac surgery and had post-operative sepsis. So blood cultures were sent and the patient was given colistin and meropenem empirically because that is our antimicrobial regimen for ICU-acquired sepsis. And the blood culture grew Klebsiella that was colistin resistant and sensitive only to ceftazidime, avibactam, and fosfomycin. So therefore, in this patient, we treated him with a combination of these two drugs, that is Cas-Avi and fosfomycin, and the child got better. And we used it in a dose of 30 mg per kg given 8 hourly as extrapolated from the adult dose. So you may have these unique situations in your PICU and NICU where you may have to use these drugs which are currently available in India and when you have no other therapeutic options, because we couldn't have treated this pathogen with just fosfomycin alone because resistance rapidly develops to fosfomycin. Now, the other drug is aztreonam avibactam, which is actually a good drug because it works for both NDM and OXA. It is not available yet. But we know that aztreonam separately is available and ceftazidime avibactam is available. So if we combine these two drugs, theoretically, we will get aztreonam avibactam. So this can be used to treat gram-negative isolates that are NDM producing if there are no other treatment options. And in fact, in the current COVID-19 pandemic, we are using this combination in adult patients because sometimes we have no other options. So this is actually the case of an 8-year-old who underwent a transplant for beta thal major, and he developed post-transplant febrile neutropenia. And empirically, this child was put on colistin, meropenem, and high-dose tigecycline. Again, he was not improving with this regime, which is partly because of the severe neutropenia. And his blood culture grew Klebsiella that was resistant to everything except colistin. So this is a case different from the previous case because there the isolate was resistant to colistin. Here it was it was resistant to everything else except colistin. So we can't use colistin alone, especially in a patient who is so sick and with such severe neutropenia. So we needed a companion drug for this patient, and this was even ceftazidime avibactam resistant. So we did an expert carba, and in the expert carba we came to know that he has both NDM and OXA48. So this patient, what we did is we treated with colistin, ceftazidime avibactam and aztreonam, and we were able to achieve microbiologic clearance. So this is just one off-label use of the drug when we didn't have any therapeutic options. I must tell you that these drugs should not be used routinely, and you should use them only in specific circumstances where there's enough scientific basis to use the drugs. Then you have this cefiderocol, which is like a Trojan horse. Why I'm calling it a Trojan horse? Because it enters the gram-negative bacterium through channels which the organism uses to transport iron. And once it enters into the cell, it interrupts the cell's metabolic processes. And it is effective against all gram-negative bacteria, whatever be the mechanism of resistance. So it works for the top 4 gram-negative bacteria, E. coli, Klebsiella, Acinetobacter, and Pseudomonas. And it penetrates most sites except the CNS. It is approved for adults in USA and other countries, and doses 2 grams every 6 to 8 hours, cannot be given as monotherapy combined with the polymyxins. It is not currently available in India, but we have sourced it for some patients from abroad, and also susceptibility testing is not available. And so it is basically a drug to use when you have no other options. And we did use it in one patient. We had a preterm neonate who had a PDA and jejunal atresia, who underwent bedside ligation of PDA and also surgery for jejunal atresia in the NICU because he was so sick that he couldn't be transported to the OT. He developed Klebsiella sepsis in the post-op period, which was only sensitive to colistin. So like the previous patient, we put this patient on colistin and then poly B along with ceftazidime, avibactam, and aztreonam. But despite this regime, the patient did not get better. And therefore, the parents were doctors. So we spoke to them. We had an adult patient who was being treated with cefiderocol in our hospital. And they gave we gave this drug off label, and the child improved and actually went home. And this is probably the first case of use of cefiderocol in newborn. So again, this was a situation where we had access to the drug, so we could use it. And it was life-saving for this patient. So coming to gram-positive resistance. So I've talked about 3 new drugs for gram-negative, but for gram-positive resistance, we know we are dealing with drug-resistant pneumococcus, MRSA, and VRE, and Dr. Yevle, I think, has a talk on these agents later in the day. And we have a lot of drugs available for gram-positive, but each has limitations. So if you look at the drugs carefully, if you look at vancomycin, the problem is that one, it is having rising MICs, it is nephrotoxic, it has infusion-related side effects, does not go into the lung, etc. well. Teicoplanin, again, not useful for endocarditis. Linezolid is bacteriostatic, so not good for endocarditis and bacteremia. Daptomycin is available, approved for adults, but we also use in children, but it is not for any infection where you have pneumonia, CNS infection, or a urinary tract infection. Besides, availability is erratic. Clindamycin and cotrimoxazole are available, but they don't work for all MRSA, and besides, they have their own limitations. Tigecycline, which is good gram-positive activity, it has poor blood levels and not approved for children. And fosfomycin, remember, is another drug which you can use for MRSA and MSSA, but the problem is that it has a high sodium load, etc. So though we have so many gram-positive agents, they all have their limitations. So we have now a lot of gram-positive drugs also being available. Ceftaroline has recently become available in India by the name of Zinforo from Pfizer, and it works for DRSP, MSSA, MRSA, and non-ESBL gram-negative pathogens. So it will work. So it's a 5th generation cephalosporin. It will work for your E. coli, Klebsiella if they're non-ESBL. And its main indication is for community-acquired pneumonia and soft tissue infections. So for example, you have a patient coming into the community-acquired pneumonia where you think it could be pneumococcus or MRSA or something. Instead of using like ceftriaxone and vancomycin, you can use only ceftaroline because it works for all these pathogens. But it cannot be used for resistant meningitis, pneumococcal meningitis, because it does not go well into the brain. So we have used this drug in adults, one in a case of refractory MRSA bacteremia where we couldn't use the other drugs, and also in a patient who had drug-resistant pneumococcal meningitis along with vancomycin. So because instead of using ceftriaxone, because the patient was failing on ceftriaxone and vancomycin, we shifted to ceftaroline. Then you have levonadifloxacin, which is again a new quinolone approved for adults. And this is actually a drug which has been developed by Indian company. It is not abroad. There is a drug called dilafloxacin, which works like levonadifloxacin. And it has a very broad spectrum of activity. It has added MRSA cover along with all the agents which are covered by levo and moxi. And it is available in adults for management of community-acquired pneumonia and skin and soft tissue infection. Oral switchover options are also available. So it can initially be given IV and then oral. It's an expensive drug. So really, there's not much scope of use in children, but the only situation where I think one may have to use this drug is, for example, a child who has MRSA where you need to treat orally, but you can't use linezolid because of toxicity, and none of the other drugs like cotrimoxazole or clindamycin are sensitive. But again, you don't have pediatric dose for this. Then you have these lipoglycopeptides like telavancin, oritavancin, and dalbavancin. And one Indian company is actually going to bring them in India soon. And it works for MSSA, MRSA, Visa, VRSA, VRE. And dalbavancin is particularly unique because it can be dosed once a week. So that means if you have a patient who has MRSA, endocarditis, bone and joint, and bacteremia, instead of using daily vancomycin or teicoplanin, you can use this once a week, and that actually can be very useful for treatment. So I think these lipoglycopeptides will be very useful in children because there are lots of studies in children. The pediatric doses have also been determined. And then you have tedizolid, which is approved in adults, and it is available in the US, and it works for some linezolid resistant strains, which is now creeping up in India. It's given once a day. And the main advantage of tedizolid is that it has fewer GI and hematologic side effects like myelosuppression, and the duration of therapy is short. So with that, I close my discussion on antibacterial agents and I move towards MDR and XDR TB. So now actually these drugs, new drugs are also available for children, and you have these two agents called bedaquiline and delaminid. Bedaquiline, though it is approved for more than 18, but now we are using it in children between the ages of 12 to 18. And sometimes there are ongoing trials even above the age of 5 years. Whereas
Last 5 minutes, ma'am.
Yeah. Whereas delaminid is approved for 6 years and above. And there are ongoing trials below 5. And now these drugs are increasingly available through the public sector. So all the cases of MDR TB, which we have seen in this past year, in 2021, we are referring them to the public sector for an all-oral regime. So now you don't need to give aminoglycosides. So these children are given an all-oral regime, which can be used for pulmonary and non-CNS MDR or XDR TB with either bedaquiline or delaminid. So in children above the age of 5, you can use delaminid. In children above 12, you can use bedaquiline, and sometimes even both of them are used together, along with levoflox, linezolid, cycloserine, and clofazimine. So only the children below the age of 5, you have to use the earlier regimes where you used to use aminoglycosides along with these other drugs. Otherwise, in children above 5, these drugs, you can refer your kids to the public sector and they get these drugs free of cost. New drugs for fungal infections. So I just want to talk about two drugs, that is posaconazole and isavuconazole. So posaconazole is not a new drug because it was earlier available as a suspension, but now the oral tablets are available. And these tablets are 100 milligram in strength. It has very good bioavailability, especially the oral tablets, works for both aspergillus and mucorales. And though it is approved for children above the age of 13, you can use it in off-label in children below 13 because you can dose them as 5 mg per kg in children, and you can do a therapeutic drug level after 5 days of therapy. So that even if you have a level which is lower, you can increase the dose. So that is a good option because these tablet forms can be used and they are much better than the suspension form. And isavuconazole, again, a third generation azole, is now available in India. It works against both aspergillus and mucorales, and it is non-inferior to voriconazole for aspergillosis and is also approved for mucormycosis. It has good oral bioavailability. You don't need to do TDM, and it is approved in adults. So far, there are not pediatric studies with isavuconazole, And both these drugs, POSA and isavuconazole, we have used extensively in the current epidemic of post-COVID mucormycosis because amphotericin B was in serious short supply. When we talk about antiviral drugs, two drugs are important. One is baloxavir, which is anti-influenza, and it has a different mechanism of action. It works by inhibiting the viral polymerase, whereas the previous drugs like oseltamivir, zanamivir, peramivir were all inhibiting the neuraminidase. And it is approved in the US, and studies show that it is non-inferior to oseltamivir in reducing duration of symptoms and is more effective than oseltamivir in viral clearance. So it cleared the virus in 1 day as against 3 days with oseltamivir. It is approved in patients above the age of 12. And the good thing is that it is a single dose therapy. Unlike oseltamivir, which has to be given for 5 days and will work against neuraminidase inhibitor resistant strains, but it is not available in India so far. And the other is letermovir, which is an anti-CMV drug approved for primary prophylaxis for CMV following transplant. So remember, earlier we wouldn't give primary prophylaxis because ganciclovir or valganciclovir were myelotoxic and would prevent engraftment of the marrow. So, but now this drug is available, which works in a different mechanism as compared to ganciclovir, and it is not myelotoxic. So it is commonly used as primary prophylaxis after transplant. It is available abroad, not in India, but it is also being used off-label in children who have ganciclovir-resistant virus or who have not tolerated ganciclovir. And no talk is going to be complete without new drugs for COVID-19. There's a massive thrust to develop oral therapy, and the investigational agents are molnupiravir, which you must have read about, which is made by MSD, and it is in phase 3 clinical trials. And there's some other drugs I was reading called Tempol and some inhibitory RNA and nanoparticles, which is being developed in Australia. And then the last is what about anti-malarials? So nothing much happening there, except for tafenoquine, which is approved in adults as single dose 300 milligram for radical therapy of vivax malaria. And it is contraindicated in G6PD deficiency like primaquine. But the main problem with tafenoquine is, though the compliance is better because it's a single dose therapy, once you give it and the person hemolyzes, it will continue to hemolyze because it's just a one drug therapy. Whereas if it was primaquine, you can stop primaquine. That's the problem with tafenoquine, but it is not available in India so far. So I think with that, I would end by saying that several novel drugs have become available for treatment of infections, and I have restricted myself only to those drugs which have been approved, either globally or in India. But drug development has not kept pace with emergence of new pathogens and drug resistance. So we still have a large gap. And most drugs which I discussed are approved for adults and are used off-label for children. So the main objective for this lecture was to tell you that, there are we should not use these drugs, like ceftazidime avibactam or astronam avibactam, etc., or the other gram-positive agents irrationally. But yes, there may be some situations like the cases I discussed in my presentation where you might use these drugs for successful clinical outcomes. Thank you.
Thank you, ma'am. It was a wonderful session with introduction of some newest drugs against viruses, MDR, tuberculosis, and malaria. Thank you so much. I now invite Dr. Pramod Kulkarni to lead the next session, which is a dialogue by Dr. Raju Khubchandani. Over to you, Dr. Pramod, sir. I request all the delegates to kindly put their questions in the chat box, and the experts are kindly requested to post the answers also in the chat box.
Am I audible and my slide visible?
Yes, sir. Your screen is blank.
Yeah. Good morning and welcome everybody to this fine Sunday morning in this CME, and with a solid batting and hitting opening by Dr. Tanu, let us go with the next therapeutics, which combines the diagnostic as well. So, inflammation which is infection, may have immunity, how to approach it. A dialogue with the master Sherlock Holmes. This is like a investigation, crime investigation by some bug or something else, some other pathogen. And we have the Sherlock Holmes with us, Dr. Raju Khupchandani, the master pediatric rheumatologist. So what are the interactions? You know, fever had been, was once a time bread earner for all pediatricians, us almost 1.5 years back. And we hope it should become same in the coming future. We know inflammation is behind every fever. And we know inflammation is mostly caused by infections. But the story doesn't end here. Last few decades, we are hearing inflammation can be caused by immunity as well, not only infection. The inflammation can be caused by drugs and toxin related to infection and also through the immunological medium. We know last few decades, we have seen the leaps and bounds of progress in the rheumatology with Dr. Khupchandani leading the sister subspecialty. And they also cause fever. Cancers are well known to cause fever, inflammation, as well as fever. But we know immunity is not just autoimmunity. We also have autoinflammation and primary immunodeficiencies to complicate. All this plethora and nuances are again governed by our genetics. And this makes me, hey, Bhagwan, kya kare? General pediatrician would say, from the fever, commonest lead, where do I go? How should I go? And where I go? Just let me know. This is difficult to remember. And who is going to navigate me through this juggle or jugglery? So let us. So I was absolutely no, Fox, oh my God. I gave up. But मुझे एक मैसेज आया, टेंशन ना ले भाई, कोई है तो मैं हूं ये, और ये मेरा सुपरमैन है, हमारा सबका सुपरमैन है, डॉक्टर राजू खूबचंदानी. And he said, let's do this. So let us go ahead. So let us start with the interview session. Sir, how are rheumatological disorders and immunological disorders characterized, interrelated, and broadly classified?
Pramod, on this Sunday morning, I really feel extremely humbled. And let me tell you, I have visited Baker Street 221 only once as a tourist. So, having said that, really overwhelmed by your introduction, let's get to the base of the issue. What I would like everybody to imagine while you are looking at this slide is 4 distinct circles. And all these 4 circles are meeting somewhere in the center, overlapping each other. Now let's label all these 4 circles. One circle you call immunodeficiency. The second circle you call autoimmunity. The third circle you call autoinflammation. And the fourth circle you call allergy. And these are 4 circles which overlap each other. With the result, there are areas in each of the circle which are exclusively belonging to these 4 titles, but there are areas where they overlap each other. So, just to give you an example, let us say the circle which has immunodeficiency overlapping with the circle which has autoimmunity. And the most classic disease that you see there is common variable immunodeficiency. You have recurrent infections, but patients with CVID are extremely prone to various autoimmune disorders as well. You have systemic JI on the other hand, which is an overlap between autoimmune and autoinflammatory. So in this way, if you have these four circles in presence of your mind, you can realize that these disorders can be put either into the exclusive categories or into overlapping categories. And as our discussion proceeds, probably we would be able to give more examples to explain and define all of them.
What is this additional term, sir? New term. I don't understand how it differs. What is immune dysregulation? And what are the disorders thereof?
So, very classically, just as I told you, it seems extremely counterintuitive to imagine that autoimmunity can occur along with immune deficiency, right? Normally, you say if the patient is immunodeficient, then you say, okay, if he's immunodeficient, then how does he create antibodies against himself, right? So, the most classic disease or example of immune dysregulatory syndrome is the IAP syndrome. Now, if you look at IAP, that is autoimmune polyendocrinopathy. Now, along with that, you see candidiasis, mucocutaneous candidiasis, which is actually occurring due to immunodeficiency. Alternately, you have, like I gave you the example of CVID, in a way that is also immune dysregulation. Then the most classic father disorder of autoinflammatory of immune dysregulation is the IPEX syndrome, where you have basically immune dysregulation with polyendocrinopathy and enterocolitis, and it is X-linked. That is why it's called IPEX. These are rare disorders, but let me say to you that 20 years ago, people would not even suspect rheumatologic disease. The issue today is rheumatologic immunologic disease is a cause of approximately 1 in 5 children with prolonged pyrexia. And this message should go out very clearly that the moment I see pyrexia beyond 15 days, or the moment I see recurrent pyrexia, as you mentioned, how do I firstly sort these diseases out in your initial introduction? Then it should immediately alert the pediatrician that I could very well be looking at the possibility of this scenario. The issue here is that if you look at autoimmunity, as I said, immune dysregulation, these are areas which basically, there is a very thin line between immunology and rheumatology. So what happens is the autoimmune and the autoinflammatory disorders are by and large looked after by the rheumatologist. The primary immunodeficiencies or the immunodeficient disorders and the allergy disorders are looked after by the immunologist. But often there is an overlap with a crossover between these two groups of diseases.
So, sir, apart from prolonged fever and recurrent fever, are there any clinical pointers towards a possibility of a rheumatological or immunological or immune dysregulation syndrome when my antenna should go up?
The first we have to clearly follow is that these disorders, let us now not talk about, I'm sure that immunodeficiencies have been covered extensively by speakers like Mukesh Desai, Surjit Singh, and such champions, where you see unusual infections, you see multifocal infections, or you see recurrent infections. Those are the situations in which you are likely to suspect,
Primary immune deficiencies.
primary immunodeficiencies. On the other hand, when you have atopies starting, very uniquely, rather early, sometimes severe asthmas, severe refractory atopic dermatitis, etc., you will go into the allergy category. In the auto-inflammatory category, you would start suspecting when these patients have prolonged pyrexia, they have frequent rashes. If you look at systemic GI is the prototype of an auto-inflammatory disease. These patients would have recurrent rashes, prolonged pyrexias. They would have often ophthalmic manifestations and systemic manifestations involving the kidney, involving the brain, involving the eyes. Autoinflammatory diseases are very often involve the eye, as against autoimmune manifestations where the eye is seldom involved. So when you see these kind of multi-system involvement, you immediately say, I could be dealing with an autoinflammatory disease. And these are disorders where you will invariably see marked leukocytosis, and we don't have to wait. But amongst the common endpoints is amyloidosis of the kidney or amyloidosis. So you see systemic GI in the olden days when we never used to have good kind of treatment for it, amyloidosis would be very commonly seen as a terminal complication of systemic GI. Similarly, if you look, the commonest complication of familial Mediterranean fever is amyloidosis. And when I speak to my friends in Turkey, what they would say is that they have a separate OPD for FMF, the number of patients they see over there. And in that, they have a sub OPD for seeing patients with FMF and amyloid, because it is so common in Turkey, Israel, Middle East area. So, which brings me to the question which you have put up on the screen right now. Are these disorders genetic or acquired? Let me tell you that under each of these four circles which I drew, there are hereditary variants and there are acquired variants. So let me give you an example. The most classic prototypic disease in the auto-inflammatory category, which is acquired, is systemic GI or Behçet's disease. But you have a bunch of hereditary autoinflammatory diseases as well. If you go to the autoimmune category, the most prototypic autoimmune disease is lupus. But if you have lupus which begins below 5 years of age, and I'm stressing this again because this type of lupus is quite common in our community, you should always suspect hereditary lupus, which is then called monogenic lupus. Similarly, in immunodeficiencies, if a person is HIV, then he is an acquired variety. Though you can have HIV got through the transplacental method, etc., but otherwise you are hereditary HIV. But if you have a primary immunodeficiency like agammaglobulinemia, then you are a primary or a inherited immunodeficiency. And in the allergy category, again, if you have asthma as an adult, this is probably your regular asthma that we see. But suppose you have allergies beginning at a very, very early age and taking a very refractory, unusual course, then you may start suspecting diseases like your job syndrome, hyper IgE syndromes, your STAT3 or DOC8 deficiencies, etc. So therefore, as I said, in all these four circles, I'm coming back to these four circles, there is a hereditary variety and there is an acquired variety. I think by and large, the ones that mimic infectious diseases, Pramod Bhai, is the autoinflammatory disorders. And this is because they come with fevers and rashes. And fever with rash is a very common conundrum when it comes to the patient who presents to a pediatrician. And the moment you see fevers with rashes, and this story has been going on for more than 10 or 15 days, and especially when you look that most of the viral exanthems today, measles, rubella, etc., have all got vaccines for them. So when you see funny fevers with rashes, you should immediately start suspecting this, especially if the fever has gone on for a longer period. Complicate infections? Yes, of course, because if you have immunodeficiencies, then infections can be a major issue. Also, very peculiarly, you can have autoimmune diseases complicating infections. And the father bacteria which does this is Mycoplasma. When you see Mycoplasma infections, there's a bunch of autoimmune manifestations which may follow Mycoplasma. Additionally, we are realizing even today that COVID is a peculiar bug which leads to a host of autoimmune manifestations. Not only autoimmune, but autoinflammatory manifestations of the MIS-C variety. But I have personally seen 2 children with sudden onset blindness and anti-MOG antibodies following COVID. And there's a host of other autoimmune manifestations which have been described after COVID. So actually pretty much all these can confuse or confront pediatricians. And I would therefore say that especially in this COVID era, nothing is impossible. Currently, Dr. Vibhor Borkar is looking after a child with a esophagitis, with a thick esophagus, which basically almost resembled a malignancy. The patient has had COVID some weeks ago, is anti-COVID antibody positive, and the disease, which was resembling malignancy, has responded to steroid therapy. Obviously, biopsies, etc., were done. So it's confuse or confront pediatricians. I would say at this stage, keep your eyes and ears open for anything that this silly coronavirus can do. But
Sir, the HLH complicating the dengue and other common infection would also fall in this dysregulation syndromes, immunological, is it?
Dr. Pramod sir, last 2 minutes, please.
the HLH would definitely, the macrophage activation syndrome is typically a story where there is autoinflammation. You see, here I just want to make one important point, and that is immunodeficiency is a problem with the humoral system. Autoinflammation is a disorder with the innate immune system. This is the way that one would look at it. Let me tell you that today there are 53 inherited autoinflammatory diseases which have been recognized. Your diseases like Blau syndrome, Sinca syndrome, Dada 2 syndrome. Just to summarize, we used to believe that these do not exist in our community. Over the last 2.5 years, I have identified 55 such patients and published a lot of them. The key point is you have an early onset of disease, you have consanguinity, and you have recurrent fevers, rashes, multi-system manifestations, and ophthalmic manifestations. Please put your antenna up. These conditions are diagnosed by genetics. Several of these conditions we do have medications for to control them. You cannot cure them. Genetics is now, I am reading your questions and answering because we are running short of time. But these genetic disorders, it is mandatory to diagnose them not only for the family, but also for future counseling of these people. And genetic testing has become progressively cheap in our setting. I won't say it is still very affordable, but between 16 and 20,000, you can have an exome study done.
Sorry to interrupt, but the time is up.
Just
Dr.
a minute.
Pramod, sir.
Yes, just last minute. So just tell us broadly about the therapies available and the outcomes of such autoinflammatory disease kids. Are they promising?
Outcomes are from extremely good outcomes like patients like Dada 2 to very, very guarded outcomes for certain diseases because IL-1 inhibition, which is important, is not available in our country as yet. So therefore, from the guarded to the most optimistic outcomes, and most of these are treated with biologic therapy.
Thank you very much, sir. So that's how we learn about the autoinflammation and the complex interaction between this. Thank you very much, sir. And we will have you with us to keep the force. Thank you. Thank you, organizers.
Thank you, Dr. Khubchandani, sir, and Dr. Pramod Kulkarni, sir. So this brings us now wherein we shall witness the inauguration ceremony of this midterm CME by where our chief guest today are Dr. Piyush Gupta. I invite our current president Pune IAP and the organizer of this CME, Dr. Sanjay Natu, sir, to lead the ceremony and also give a brief introduction of Dr. Piyush Gupta.
Just before that, Manisha, Dr. Ramesh Kumar, would you like to comment on the previous two talks, sir?
Yes, sir, absolutely, because the time was running short, but it was two fantastic sessions, and thank you so much for Dr. Pramod Kulkarni for that wonderful slides, which in fact he had the forms in the full flow. And talking above, before that, Dr. Tanu has given us a new insight into the domains of not only antibiotics, but more antifungals and everything, and not much of hope is still there about antibiotics, and that is what we have learned from Dr. Tanu. So the two wonderful sessions that we start the day with. Thank you very much.
Thank you, sir.
Thanks a lot, sir.
Thank you.
Thank you, Parag. Thank you, Dr. Tanu, madam, Dr. Khubchandani, sir, and Pramod Kulkarni, sir. So here we come to the short, small inauguration function of this National Midterm CME of the Infectious Disease chapter of the IAP. This is being organized by the Indian Academy of Pediatrics Pune branch this year. I welcome all the delegates who are attending these sessions online, all the esteemed faculty who have contributed and will be contributing throughout today on this very important topic. The office bearers of the ID chapter, the chairperson of the ID chapter, Dr. Yagnesh Popat sir, the secretary, Dr. K.A. Ghosh, and all the other office bearers of the ID chapter. And of course, our chief guest for today's session, Dr. Piyush Gupta sir, the Central IAP president. We had hoped at the outset, at the beginning of the year, to have a grand physical conference, and we had planned a lot for this. But as we all know, the COVID situation has panned out in such a way that physical conferences are going to be a little difficult for even more time, I suppose. Nonetheless, we have gone ahead and with the consultation of the office bearers of the ID chapter, Dr. Popat sir, Dr. K.A. ma'am, Dr. Jaideep, we decided to hold this session, this conference for 1.5 days in an online way. And here we are. Yesterday we had half-day session, which was quite interesting, attended by a large number of delegates. And today we have again many sessions by stalwarts in pediatric infectious diseases to address the delegates today. So with this, I request Dr. Piyush Gupta sir to give me permission to formally inaugurate, because it's the e-inauguration, sir. So we will do it online, sir, if it is okay with you, sir.
Please go ahead. Please go ahead. All the best.
Just give me half second, sir.
या कुन्देतु तुषारहारधवला या शुभ्रवस्त्रावृता या वीणावरदण्ड शङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहा हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां परमेश्वरीं भगवतीं बुद्धिप्रदां शारदाम्
So we have today with us for a chief guest for the inauguration function, Dr. Piyush Gupta sir. He is of course the president of the Central IAP, the academic guru for all of us. We all know he has been the editor of the Indian Pediatrics for 6 years. He's contributed a lot to the OP Guide textbook of pediatrics, and of course his own textbook of pediatrics, the Piyush Gupta textbook of pediatrics, is very popular amongst the postgraduates. The clinical methods is also a very popular book. He has been conferred the fellowship by the RC Royal College of Pediatricians of the UK, and he has several achievements, of course, to his name, including workshops on thesis writing, scientific paper writing, and I can go on and on with all this, but I mean, it's a long list. So I request Piyush Gupta, sir, to please address us on this occasion, sir.
Thank you, my dear Dr. Sanjay. Thank you. And it's a very lovely good morning to all of you. Nice to see bright, smiling faces of all my dear friends. Ramesh, already met in another program this morning. Bala sir, Parag, Vijay, Pramod sir, Dr. Ashwini, Jaideep, and so many. And wish you all the best. I'm not taking names. And it's really great to see the academics back on the rails. Out of the woods, or I would say out of the COVID woods. And morning we and myself and Ramesh, we were in the IPNA learning nephrology, and now we are into the infectious diseases chapter. As we all know, this is the most vibrant and most active chapter of the Indian Academy of Pediatrics, but now that was in the physical era. I think you have competition now in the virtual era, because in the virtual era, every chapter is now coming forward and and is now competing with each other. So there is no dearth of activities, because funding was a major issue. So I think virtual, the small chapters and other specialties are also doing very good, and they will keep you on toes. So it is good that now we are having this midterm CME. I wish all the best for the all the participants. My thanks to all the faculty who have agreed to be here for the benefit of the participants and the pediatricians at large, who are looking forward to learn on subjects other than COVID also, so that the practice may start in its earnest. Thank you very much. A very good morning once again, and wish you all a very, very happy CME and happy learning.
Thanks a lot for your words of encouragement, sir. Hereafter, I request the chapter chairperson, the chairperson of the infectious disease chapter, Dr. Yagnesh Popat, to express his thoughts.
Respected Central IAP President, Dr. Piyush Gupta ji, IAP Pune President and Organizing Secretary for the event, Sanjay Nathu ji, IAP Pune Secretary, Dr. Pramod Kulkarni ji, my colleague, NID Secretary, Dr. Khaya ji, all my senior past chairpersons, seniors, colleagues, and all viewers. Good morning and warm welcome to one and all. Year 2020 was an year of unhealthy surprises. COVID-19 pandemic continued. Its effect on the lifestyle, outdoor activities, and economics was of such a high magnitude that nothing else was possible. Our regular conferences were also on hold. Medical fraternity lost many of its frontline workers, and our association was not spared. We lost our past chairpersons and ID chapter chairpersons, Dr. A. Parthasathi, Dr. Ashok Kapse, Sitting Vice President of South Zone, Dr. K. Nagaraju, and many other colleagues. Our sincere prayers for the all departed souls. Now that the second wave of corona is receding, other infections have started resurfacing. So it is time to resharpen our knowledge and better prepare ourselves to fight the battle against them. With this intention, our midterm CME was planned in association with the Pune branch. It was planned as a physical conference, as Dr. Sanjay Natu said earlier, but due to the second wave of COVID, we have to modify it to the virtual events. There are many webinars going on. Piyush Gupta ji is correct. There are many webinars going on right now also. But to organize it for 1.5 days, involving so many stalwarts in a field is a mammoth task. I congratulate Pune IAP, Dr. Sanjay Natu, Dr. Pramod Kulkarni and team for their willingness for shouldering this responsibility. I am confident that event will be smooth enough to satisfy the thirst of all the viewers. So do use this opportunity to learn and de-learn the science. I am missing the opportunity to meet you all and greet you all physically, but we have to plan for future programs also, including our annual events, NCPID, but we will have to consider the third wave possibility and its magnitude. So your suggestions, motivations, and supports are needed to implement future programs. So do communicate with me at any of your convenient time. Wish you all a happy learning. Thank you all. Thank you.
Thank you, Dr. Popat, sir. I now request the chapter secretary, Dr. K.R. Ghosh-Uttam, to express her thoughts.
So, very good morning, respected Dr. Piyush Gupta, sir, the President IAP 2021, Chairperson IAP ID 2021, Dr. Popat, Organizing Secretary, Dr. Sanjay Natu, the Secretary Pune IAP, Dr. Pramod Kulkarni, the President-elect 2022, Ramesh Kumar, and so many my senior past chairperson of IAP ID chapters, all the esteemed faculty from different corners of India, and the enthusiastic delegate. At first, let me congratulate the IAP Pune branch for organizing this midterm CME of IPID chapter so meticulously. It's indeed a flawless CME, and it is so excellently planned, accurate implementation, and of course, above all, outstanding scientific sessions. I still distinctly remember when Dr. Pramod Kulkarni showed his keen interest before Pedicon 2021 Mumbai that he wants to host this Pune midterm CME. And we were planning in the EB meeting of the ID chapter, we were planning that we will have a chance to meet physically with all our friends and colleagues. But the unfortunate circumstances continued and we had to meet today in the physical platform. But really, believe me, we are enjoying every moment of this this virtual CME due to its rich scientific content. You all must be noticed that the CME has a very apt theme. It is known infections, newer insights. And what it actually depicts, it depicts the importance of always updating ourselves to have the recent knowledge of the old things, old diseases, along with the new diseases. We should not only carried away by COVID, but we have to update our knowledge about the old diseases also. So ID team as a whole always try to update its members with the recent knowledges, and thus we are organizing so many CMEs. Maybe the others are also doing so to update our members. And also we are having a monthly ID Connect series, which is a brainchild of our chairperson, Dr. Popat. I'm very happy to announce also that even amongst the pandemic, we are constantly having recruitment of new members in the ID chapter. And along with the other CMEs, we are also going to organize, as mentioned by Dr. Popat, the NCPID 2021 in Bhubaneswar. With all your blessings and supports, let's hope we can do it physically. If not possible, maybe a hybrid conference. And I request all of you to join this NCPID to make it a grand success. So before I end, I would like to again thanks and congratulate the Pune team for your sincere and dedicated work and a wonderful CME. Happy learning. Jai Hind, Jai IAP.
Thank you, Kaya Madam, for your words of encouragement and praise. Same, Dr. Popat sir, it could not have been possible without both of you supporting us so wholeheartedly. Thank you, sir. I request Dr. Kulkarni sir to propose a short vote of thanks. Sir, you need to unmute, sir.
So on behalf of Pune IAP as well as IAP ID chapter, I thank everybody, the central IAP, the executive board members of central IAP, ID chapter officials, Pune IAP team for supporting us, the sponsor of this platform, DigiShield, and all the friends who have helped us throughout arrangement of this conference. And thank you very much for the response, and enjoy the learning careful. Thank you.
Thank you, sir. So I think with this, we'll end the short inauguration program and hand it over back to the compeer, Dr. Manisha.
Thank you, Dr. Sanjay. So now we move on to our third session today morning. Just allow me a minute to share my screen. Is the screen visible?
Yes, yes.
Yes, it is.
Okay, just 1 second. So now we come to the third session today morning, which is a talk by 3 experts. Its heading is Alert to Art, Learning from the Experts. There will be 3 talks, 20 minutes each. The chairperson for these sessions are Dr. Ganamurthy and Dr. Mrityunjay Das. The first talk is on atypical ARI by Dr. S. Balasubramaniam. Second talk is MDR gram-positive bacteria by Dr. Vijay Yevle. And the third talk is MDR gram-negative bacteria by Dr. Jaideep Chaudhary. Let me allow me to do a short introduction of our chairpersons and the speakers. Dr. Ganamurthy N. He is a president IIP Bangalore. He was a president IIP Bangalore in the year 2011. President IIP Chapter Karnataka 2014. Joint Chief IIP Action Plans Coordinator 2018 and 2019. Central IIP Election Officer 2017, 18 and 19. Dr. Mrityunjay Das, he is a professor, Department of Pediatrics, Institute of Medical Science and SUM Hospital, Bhubaneswar, with areas of interest as vaccinology, critical care, infectious diseases and gastroenterology. Special achievements and awards will be, he is the EB member, East Zone Infectious Disease Chapter 2020 and 2021, ex-treasurer, Odisha IIP and Odisha NNF, Purvanchal Pioneer Award in 2018, scientific committee member in East Zone Academy of Pediatrics, and has 40 publications in national and international journals to his credit. Dr. S. Balasubramaniam, trained in India as well as in UK, medical director and HOD pediatrics, Kanchi Kamakoti Child's Trust Hospital, Chennai, honorary pediatrician, Southern Railway Headquarters Hospital, Chennai. Areas of interest being infectious diseases, pulmonology, PG education, clinical and OSCE trainings. He is teacher guide with over 90 publications in index journals and 10 chapters in books. He has 34 years of experience as PG teacher, guide and trainer. He has received multiple awards. He is a distinguished DNB teacher and has here I would like to mention that he has received Lifetime Achievement Award from Tamil Nadu Dr. MGR Medical University. Dr. Vijay Yevle needs no introduction, Head Institute of Child Health, Apollo Hospital, Director of Dr. Yevle Multi-Speciality Hospital for Children in Navi Mumbai, with areas of interest, infectious diseases and vaccinology. He has been the IAP President 2014, Editor, Pediatric Infectious Disease Chapter, Convener, IAP 2009-11. Dr. Jaideep Chaudhary, Professor, Department of Pediatrics, Institute of Child Health, Kolkata, Chairperson, IAP Infectious Disease Chapter 2020, Vice President, East Zone Central IAP 2019, and areas of interest being pediatric infectious diseases and vaccinology. So let us begin the session with the first talk by Dr. S. Balasubramaniam on atypical ARI. Over to Dr. Gangamurthy and Dr. Mrutyunjay Das to lead the session, please.
So good morning, one and all. And at the outset, I must congratulate IAP ID Pune chapter and IAP Pune for organizing this wonderful, excellent conference since last 1.5 days going on. And without much delay or without much wasting of time, I request our Professor Dr. S. Balasubramaniam sir to talk on this atypical ARI. So it's over to you, sir. Balasubramaniam sir, please start.
The time limit will be 20 minutes, sir.
I'll share the screen 1 minute.
Yes, it's visible, sir.
Good morning, friends. The topic given to me is atypical pneumonia or atypical ARI. Though the organizers first gave it as atypical pneumonia, then they changed it to atypical LRIs. I removed LRI because I'll tell you in the end why I removed LRI. Now the focus in this 20-minute session would be, what is atypical pneumonia? What is the definition? I'm going to discuss a few case scenarios from my personal file, and then would review the recent concepts in diagnosis and treatment, and end up with a summary useful for the general pediatrician. If you look at the definition of atypical pneumonia, the BMJ best practice says it is defined as a pneumonia caused by atypical organisms that are not detectable by routine gram stain and culture methods. And the BMJ says Mycoplasma, Chlamydia, and Legionella pneumonia should be called as organisms causing atypical pneumonia. If you look at the CDC definition, it says any pneumonia which cannot be diagnosed by usual methods, with sputum culture, etc., and the symptoms that are different from the typical pneumonia, that is a pneumococcal pneumonia, X-ray findings different from pneumococcal pneumonia, antibiotics for pneumococcal pneumonia not working, and these pneumonias should be called as atypical pneumonia. Here again, there is uniformity in both the definitions. It includes chlamydia, legionella, and mycoplasma only. The other definition is that if you have a pneumonia which is not typical of pneumococcal pneumonia, lobar pneumonia is not there, high leukocyte count is not there, then you call it as atypical pneumonia. But then I'll discuss in the end whether this term is going to remain in future at all. Let us move on to case scenario 1. This is a 10-year-old child who had fever and who had some macular rash. And look at the eyes. The eyes were bloodshot like this. Hemorrhagic conjunctivitis like. This child also had wheeze, was very ill, had respiratory distress. And of course, you know, anything like this, you always cover both typical and atypical organisms, because once there is conjunctivitis, you are supposed to cover for H flu, particularly below 5 years. So we gave amoxiclav and azithromycin, the child recovered. We got a mycoplasma IgM positive. Of course, there is lobar consolidation as seen in the X-ray. Is this really mycoplasma pneumonia? That's a research question for us. If you look at the pathogenesis and the manifestations of Mycoplasma pneumonia, it can cause any itis. Mycoplasma pneumonia is notorious for causing extra pulmonary manifestations. If you have a child with pneumonia and there is some other itis, nephritis, iritis, arthritis, etc., you always think of Mycoplasma pneumonia. So when you have hemolytic anemia, when you have rash, when you have arthropathy, when you have hepatitis or pancreatitis, when you have myopericarditis, when you have aseptic meningitis or ADEM, you always think of even Guillain-Barré syndrome, you always think of Mycoplasma pneumonia. But then the dilemma for the pediatrician, how do you diagnose Mycoplasma pneumonia? In fact, in the given case, I said IgM positive. Does that mean that it is always Mycoplasma pneumonia? Let us look at the facilities available for us and look at the advantages and disadvantages of both. Let us first look at the easily available antibody titers. Advantage is that it is very cheap. It costs only around 500 to 750 rupees in most centers. But unfortunately, it has got very poor sensitivity and specificity. Why? This IgM positivity may remain for 3 to 6 months. You don't know whether this pneumonia is because of Mycoplasma or because of this IgM positivity is because of past infection. Ideally, you require a paired sera. If you show a 4-fold rise in titer after 2 weeks, that indicates it's a true positive serology. On the other hand, if you have only one positive titer, it doesn't mean anything. Next is molecular test. What do you mean by molecular test? Nowadays, we have BioFire, nasopharyngeal aspirate, PCR is available. Costs about 7,500 rupees. The advantage is that it is highly sensitive. The disadvantage is the cost. The third disadvantage is that, like IgM, it doesn't tell you whether this is an acute infection or simply the person is harboring Mycoplasma pneumonia in the nasopharyngeal tract. Gold standard is, of course, the culture. But who does it? Nobody does it. In India, very few centers do it. The reason is it will give you positivity after 3 weeks, after the patient is dead or alive. So there are lots of problems in diagnosing Mycoplasma pneumonia. But currently, most microbiologists agree that in a given child who's sick with pneumonia, if PCR is positive, it is very much likely to be Mycoplasma pneumonia. 1. 2, if you have a 4-fold rise in titer, it really confirms the diagnosis. Other methods, single IgM value, single complement fixation test, cold agglutinin test is of no value. That is what the microbiologists say. Let us look at the case 2. This is again a true case. This girl, 8-year-old, came to us with fever. She had some cough and an X-ray was taken which showed pneumonia. The practitioner started amoxiclav. Exactly 48 hours later, these skin lesions developed all over the body. And the practitioner is worried whether he is going to be sued because he gave amoxiclav, whether it is Stevens-Johnson syndrome secondary to amoxiclav. This child, when she came to us, she developed full-blown Stevens-Johnson syndrome, and she had IgM positivity. She had 4-fold rise in antibodies, and we proved Mycoplasma pneumonia. We treated with azithromycin. As seen here, the X-ray also showed consolidation. And this was the first case of Stevens-Johnson syndrome in association with Mycoplasma pneumonia in Indian literature. Mycoplasma pneumonia, what are the features? It has got a slower onset, generally milder. That is why I said I removed the term ARI. If acute bronchitis is going to occur, laryngotracheal bronchitis is going to occur, pharyngitis is going to occur due to Mycoplasma, you don't have to treat. That's why I removed LRI and put pneumonia. If there is pneumonia, you have to treat it, and usually not associated with lobar consolidation, usually, and it is like your pneumococcal pneumonia, which responds to penicillin just like that in 24 hours, it doesn't respond to beta-lactams, and many other viral pneumonias, including COVID-19, can produce the same clinical and radiological picture. The dilemma for us is how to diagnose, how to confirm, and when to initiate empirical therapy. Somebody might say, you look at the ear, if there is bullous meningitis, very much characteristic of Mycoplasma pneumonia. I'm afraid that is wrong. The commonest cause of bullous meningitis is not mycoplasma, it is pneumococcus. So it is not specific for pneumococcus. Just because you see bulle in the ear, it doesn't confirm mycoplasma pneumonia. X-ray, somebody might say X-ray can distinguish. Is it possible to distinguish? Look at these X-rays in different children with mycoplasma pneumonia. You see here consolidation, you see here consolidation, you see here consolidation. All this is mycoplasma pneumonia. You see here the X-ray is normal, child is hypoxic. You see here there is pleural effusion. 25% of mycoplasma pneumonia can have unilateral or bilateral pleural effusion, very similar to pneumococcal pneumonia. You see here collapse. You see here round shadow, almost similar to mycoplasma pneumococcus. This is actually PCR positive. So mycoplasma pneumonia, radiological findings are non-specific. It is interstitial pneumonia. It can be lobar pneumonia. There can be pleural effusion. It is usually bilateral rather than unilateral. There are no specific findings. This is a very interesting study published in US. Crazy fellows. They did PCR in school-going children, normal children, for mycoplasma. And they compared it with the mycoplasma PCR reports in children with pneumonia. What did they find? They found 21% of asymptomatic children were positive for PCR, more than those with pneumonia. So your PCR also has to be interpreted with caution. Just because a child is PCR positive, we need not give antibiotic unless the child is having pneumonia or atypical pneumonia. Somebody might ask, all this is Western data. Is there any data on mycoplasma pneumonia in India? Yes. There are 5 studies available. And most of the studies, look, most of them have been done in Delhi, one in Manipal, one in Northeast. What does this show? Most of it show mycoplasma pneumonia constitutes around 1/4 to 1/3 of all childhood pneumonias in India. And the methods used have been culture, serology, PCR, different methods and different studies. But mind you, in India, particularly above 5 years, 25% of pneumonias is likely to be mycoplasma. Below 5 years also, it's not very uncommon. Below 2 years, it is highly uncommon as far as Indian data is concerned. Case scenario 3. This is a young infant who presented with cough, had dyspnea, had retractions, but there is no fever. Counts were normal. Eosinophils was 5%. And the X-ray showed some bilateral infiltrates suggesting pneumonia. PCR in the nasopharyngeal aspirate in the biofire, chlamydia was positive. Is this chlamydia pneumonia? Yes, it is. Unlike mycoplasma pneumonia, which can produce false positive PCR even in a normal child, chlamydia, if PCR is positive in the biofire, it is highly specific. It really confirms the diagnosis that the child has got an LRI. Chlamydia pneumonia, though textbooks say staccato cough is characteristic, it need not occur. Eosinophilia may be there. It is usually below the age of 3 years in contrast to mycoplasma pneumonia. Laryngitis is more common. Hoarse voice is more common. PCR is a very, very useful test. Antibody tests are useless. Case 4. This is an adolescent who gave us restless days. This 12-year-old boy had fever for 6 days. He had a persistent wet cough. He had increasing respiratory distress. He had abdominal pain and loose stools. Saturation was low. He was toxic. He developed acute renal failure. He didn't improve ceftriaxone. Total count 39,000. We were wondering whether it is HUS. CRP is 50. Platelet count is 1.2. Creatinine is 1.5. Sodium was low. SGOT and PT were minimally elevated. CPK was elevated. He had myalgia. And an X-ray was taken. You see here consolidation, right middle zone, and pleural effusion on the right side, severe pneumonia. What is the cause for this atypical pneumonia? This is not typical. Something unusual is happening outside the respiratory system. We did a urinary antigen for Legionella. It was positive. We hit him hard with azithromycin, initially IV, then oral for 10 days. Mind you, if you are going to treat Legionella pneumonia with drugs other than azithromycin, you have to give for a longer period. If it is doxy or levofloxacin, you have to give for 14 to 21 days. Unlike Mycoplasma pneumonia, which requires only 5 days of azithromycin, Legionella requires 10 days therapy. Quinolones might be superior, and air coolers are said to be a notorious source of infection. But Legionella pneumonia is highly uncommon in young infants and neonates. We have seen very few cases. But if you have diarrhea and if you have myalgia and elevated CPK with hyponatremia, please think of Legionella pneumonia. The diagnosis, urine antigen test, though it can be positive for up to a few months, is the only test available for most of us. Of course, you can do a PCR in the bronchopulmonary lavage or in the nasopharyngeal aspirate, considered very, very sensitive. To the practitioner, the most important question is, okay, you say atypical pneumonia cannot be diagnosed with all lab methods. It is clinical diagnosis. How do you treat it? I would boldly say in resource-limited settings, none of these tests is required. If you think it is atypical pneumonia, it is cheaper to treat rather than test. Macrolides has been the traditional choice. Mind you, resistance to macrolides is very much on the rise throughout the world. In China, 90% of the strains are resistant. In Korea, 70%. Even doxycycline resistance is emerging. No Indian data is available. And beta-lactam should be given below 3 years to anybody with pneumonia. Why? If there is bacteremia due to pneumococcus, your doxycycline and macrolides might fail. So you always do a combo therapy of a macrolide or a doxycycline along with the beta-lactam. Levofloxacin fortunately covers typical and atypical. A good monotherapy choice is there with levofloxacin, particularly in older children. In fact, this study from Bangladesh has shown levofloxacin has shown very good results when compared to ceftriaxone in community-acquired pneumonia. That doesn't mean I am advocating levofloxacin. When you are stressed, when your macrolide is not working, please consider levofloxacin if this is atypical pneumonia. What about new drugs in our armamentarium? New
Last
drugs are
5 minutes warning, sir.
Lefamulin, a first-in-class fluoromutilin antibiotic, is being tried. It covers typical and atypical. It is FDA approved. It not available in India. Dilafloxacin, a new fluoroquinolone, non-inferior to moxifloxacin, will be available soon. Solithromycin is probably superior to azithromycin. No resistance reported so far. Omedocycline, a new tetracycline, a recent article in the New England Journal has proved its efficacy in atypical pneumonia, but none of them is right now available in India. If you ask me, do you have personal experience with these atypical pneumonia? We did a study, we are yet to publish it, we are just working on it. We had shown that 30% of our pneumonias had mycoplasma IgM positivity, 30%, very high. That doesn't mean everybody is having mycoplasma pneumonia. We compared this with healthy children. They had only 9% positivity. This indicates that mycoplasma pneumonia is quite common in the Indian setting. We saw quite a few mycoplasma pneumonias, even PCR positive, within 1 to 3 years of age. There were no seasonal variations. Of course, we are currently doing a PCR study. We'll have the details in another 6 months. In the end, I would summarize by saying the term atypical pneumonia should go. In fact, in the next ID CME, there should be no topic of atypical pneumonia. Why am I saying this? The reason is the term is becoming outdated. In fact, in a recent article in Lancet Infectious Diseases, they have criticized the very terminology. They say you call it mycoplasma pneumonia, you call it chlamydia pneumonia, you call it legionella pneumonia, because you have PCR available for the diagnosis. The term atypical is not correct, it should go. Second is, clinically, you cannot distinguish a typical and an atypical pneumonia, even if it's a shrewd clinician, it's not possible. And decision to treat is entirely clinical. You don't wait for the reports. Treat rather than test is the best option. Don't waste your money in testing. Macrolide alone for severe community pneumonia is irrational. You have to combine it with the beta-lactam. Multiplex PCRs, costly, will help you diagnose. Treatment is probably beneficial only in severe cases, not in mild cases. Macrolide and doxycycline resistance are on the rise. Levofloxacin is likely to emerge as the drug of choice for severe atypical pneumonia. Final slide is one which is beautiful. I've taken it from one of the articles. If you have a child who has got pneumonia, there are no extra pulmonary features, typical pneumonia, then you don't worry, you give a beta-lactam. If there are no typical features, atypical pneumonia, you get a zoonotic history. If you don't get a zoonotic history, exposure to animals, you always think of mycoplasma, chlamydia, and legionella. If there is bradycardia in that child, you think of legionella, which is supposed to be very characteristic. If there is no bradycardia, you think of mycoplasma. If there is positive zoonotic history, if there is relative bradycardia, you think of zoonosis. If there is no bradycardia, you think of tularemia or Q fever. In other words, you make a diagnosis of typical or atypical pneumonia, proceed to give macrolides or other drugs rather than wait for the test to arrive at your doorsteps. Thank you very much. Forgive me for my atypical presentation. If there is any feedback, negative, positive, please mail it to sbsp@gmail.com. Thank you very much.
Thank you, sir. It was a very excellent deliberation about atypical pneumonia, and especially you have described with all the evidences with you. Can I, if the organizers will allow, can we take the questions, or we'll take the question at the end of the session?
Sir, we have half a minute if you want to take any question.
No, I think questions will take after the 3 talks are over. That will be better.
Okay, so we can go after all the 3 talks will over, then we can go for the questions. Now, Gyanamurthy sir, it is over to you. Dr. Gyanamurthy sir.
Hello. I have a
Yes,
problem in internet.
Yes, sir. You are audible now, sir.
Yeah, now I'm audible. I'm sorry I missed my due apology, and first few minutes I missed because of internet problem. And I was so blessed. In fact, I wanted to have my resume that I happened to chair the presentation of Balasubramaniam. That would have been more ideal of introducing him. Anyway, this is a beautiful talk from Dr. Balasubramaniam, and always he gives us a carry-on message.
Not audible.
You're not audible, Dr. Jnana.
I think he has internet.
So, sorry,
internet problem.
Internet issue. So, we'll go ahead. Now, I request our esteemed ex-president, Dr. Vijay sir, to go on the talk for his deliberations on MDR, on gram-positive bacteria. Sir is always famous for the multi-drug resistance type of cases, antimicrobial stewardship. Sir is the hero for that. So, without any much delay, I request Vijay sir to carry on the session forward. Sir, it's up to you, sir. Over to you, sir.
Today in particular, and thank you, Dr. Das, for those kind words. Let me start sharing my screen. Is my screen visible to you?
Yes,
is the screen visible?
Sir.
Yes, sir.
Yes, sir.
So I've been asked to talk about MDR gram-positive bacteria in next 20 minutes, and I would only say that the MDR gram-positive bacteria, which are of clinical relevance and importance to us, are Staph aureus, we popularly known as MRSA, methicillin-resistant Staph aureus. Then you have strep pneumonia or drug-resistant Streptococcus pneumoniae, and enterococci or VRE, vancomycin ristriae. Very often not discussed in areas and population. So I thought I would touch upon these 3 bacteria, which are of gram-positive bacteria, which are of clinical relevance. And what I intend to cover in my talk is the clinical presentation and when does suspect infection with one of these resistant gram-positive bacteria, and how does one treat it. So to begin with, Staph aureus we know is methicillin susceptible or methicillin resistant Staph aureus. MRSA started appearing very early in the healthcare setting and was known as healthcare associated MRSA. And later on, this healthcare associated MRSA was very often the presence of invasive device, previous hospitalization, or previous infection with staphylococcus, history of dialysis, surgery, presence of device in the body, so on and so forth. However, later on, a similar kind of resistant staph was detected in the community, and then it was molecularly characterized. And what they found, this community-acquired MRSA had a different genetic origin, and it differed in terms of antibiotic sensitivity pattern as well. And it had peculiar, sensitivity to fluoroquinolones and doxycycline and cotrimoxazole. And there were the risk factors which were associated with healthcare-associated MRSA are very often absent with the community-acquired MRSA. And typically, it led to complicated skin and soft tissue infections and necrotizing pneumonia. However, over a period of time, one started finding community-acquired MRSA in the hospital setting and vice versa. And so the difference between the HA and CA started disappearing. And now the new terminology that is used is hospital onset MRSA and community onset MRSA. Hospital onset MRSA, when we isolate MRSA after 40 hours of admission, and CO MRSA or community onset MRSA is an MRSA which has antibiotic sensitive pattern similar to your healthcare associated MRSA. Let us quickly look at this patient. This is a 10-year-old boy who came with high fever and limping on the right side and had little abdominal pain and tenderness in the just below the renal angle on the right side. We went on to investigate this leukocytosis. He had leukocytosis, and the sonography showed psoas abscess with 13 cc per in the psoas sheet. The CRP was also elevated. Now, this child, we gave a trial of antibiotic, and since cloxacillin and the first generation cefazolin was also not available, we treated this child with coamoxiclav. And since we took this decision because this was a hemodynamically stable child, came from the community, otherwise healthy, and had not had any prior hospitalization or infection. And this child improved steadily and finally was discharged at the end of 2 weeks of, he was discharged at the end of 1 week and continued with oral coamoxiclav for another a week. So this perhaps was methicillin susceptible staph aureus. So the point that I'm trying to make is not staph aureus, all staph aureus that we see are MRSA. Though, like Western world, the incidence and prevalence of MRSA is on the rise in our country as well. Look at this 6-month-old child, child of one of our areas at Apollo hospitals, was brought with excessive sleepiness and irritability. He had tachycardia, and we could not find any focus of infection, including the oral cavity. And the only clue that we had was this child, since a couple of days, was not only refusing to feed, but there was a little bit of saliva, excess salivation coming out of the mouth. We went ahead and imaged this child, and to our surprise, we found a peritonsillar abscess on the right side. And this child, this abscess, we tried to drain it under ultrasonography. We have an excellent sonologist at Apollo Hospital. And partially liquefied abscess, we tried to aspirate. We could aspirate very little tissue, and fortunately, it gave us the tissue diagnosis or mycological diagnosis to MRSA. Now, the cefoxitin screen was positive, indicating that it was MRSA. It was resistant to clindamycin. It was also resistant to cipro and cotrimoxazole. So this is a community onset MRSA, which had HA-MRSA kind of antibiotic sensitivity pattern. So we went on and ahead and treated this with vancomycin in the hospital, and we discharged the child on linezolid. This is case which was shared to be by Dr. Prakash Vaidya of Mulund, and this was a child with a very bad umbilical sepsis. And this was methicillin susceptible staph aureus. See, why I'm showing this picture is, let us not equate virulence or severity of infection with resistance. A sensitive staph aureus can be very virulent and the child can be extremely toxic and serious. Now, it's very easy to infections caused by susceptible versus resistant staph aureus. They have similar disease spectrum. There is no particular pattern of progression or complications. There is poor response to beta-lactam if it is MRSA. And if the child has taken multiple antibiotics, especially in the past 1 year, or has recurrent staph infection, or if there is clustering in the household, one is justified in thinking in terms of MRSA and treat accordingly. Tanu has given us an excellent account of newer antibiotics. I just summarize the anti-MRSA agents: vancomycin, linezolid, teicoplanin, and daptomycin. A few practice points to remember: the vanco is bactericidal, requires infusion, but we have emerging intermediate and high resistance against vancomycin in the staphylococcus. Linezolid, though bacteriostatic, there is an increasing evidence of successful therapy with linezolid in otherwise immunocompetent patients, even if they are bacteremic, staph infections. It also has antitoxin effect. And then you have daptomycin. Most of the studies are in the adults, but now the lot of dapto is being used in children as well. Again, bactericidal. One peculiar thing is it is inactivated by surfactant, so it cannot be used in treating the lower respiratory infection. Teicoplanin advantage is once a day, can be used intravenously, very, very long half-life of 100 hours. Though not US FDA approved, it is a good substitute for vancomycin, especially when you have renal function, compromised renal function. And our old friend clindamycin has both MSS as well as MRSA activity, but there is a very high level of resistance to in staph against clindamycin, and it also has antitoxin effect. Now, this is a case of dengue fever, which was receiving IV fluids and bacteremic skin and soft tissue infection and IV site abscess, which had to be drained. And you see a small abscess on the thigh also. And the blood culture gave MRSA. And we successfully treated this child with linezolid. So there is evidence to treat gram-positive pneumonia, bacteremia, or complicated skin and soft tissue infection with linezolid. Daptomycin, as I said, it cannot be treated cannot be used for treatment of LRTI and CNS infection, because CNS penetration is very poor. Some practical situations where one could use daptomycin is staph bacteremia until the final sensitivity report is available, and where vancomycin cannot be used because of concomitant renal failure, this is a good alternative. Ceftaroline is the new 5th generation cephalosporin made available, and Tanu did mention about this molecule today morning. But a word of caution: many times we have non-responding pneumonia because of one, inadequately drained pleural fluid, synpneumonic, parapneumonic, or frank empyema. So this inadequate drainage is very often construed as evidence of resistance. So I'm little worried that ceftaroline is likely to be overused in such bacterial community acquired pneumonia at a drop of hat. Let's not do that and preserve this molecule for where it is indicated. Now let us look at this patient. 3-year-old boy was admitted with fever and loose motions, had high counts, high CRP, was treated with ceftriaxone, and this child had undergone blood culture investigation, and the blood culture comes back as Enterococcus species and gram-positive cocci. So this was a case of enterococcal bacteremia. So do we treat this? Because the child had improved and was about to be discharged. In fact, the report came on the day of discharge. This is from one of the medical colleges in Navi Mumbai. And this child was left alone and was not treated. So enterococci are again gram-positive cocci of importance. Infections are not very, very common. You have two important species which we must remember: E. faecalis and E. faecium. And you need damaged mucosal surface, because normally the GI tract is inhabited with enterococci, and colonization occurs as early as first week after birth, and it is more with E. faecalis, which is much more as compared to E. faecium. And the source for infection in an individual has to be its own flora very often, or it can be carried on the hands of the healthcare worker or the instruments which are very often used in the ICU setting. Damaged mucosal surface or impaired immune system are sort of prerequisite for a child to develop enterococcal infection. That's the reason we did not treat the child that I showed you previously. And inherently enterococci are resistant to cephalosporins, and the drug of choice for treatment of enterococci is ampicillin or penicillin. And when it comes to treating enterococcal infection, if it is localized infection, you treat with ampicillin. If a few of them can produce beta-lactamase, then you can use enterococci. Nitrofurantoin is found to be very useful in treatment of lower or simple UTI caused by enterococcus. And invasive infections are always treated with a combination therapy, ampicillin plus aminoglycoside, because aminoglycoside as such do not don't have side effect against enterococci. But once we use a beta-lactam like ampicillin, the cell wall is disrupted, and then aminoglycoside enters and it does its job. Vancomycin plus aminoglycoside is another option for treating, and that is the combination very often used in treating your endocarditis caused by enterococci. Let us look at these two cases quickly. 10-year-old acute appendicitis treated with ceftriaxone and metrogel undergoes lap appendicectomy. Child about to be discharged, but somebody finds him to be this girl to be dull on the day of discharge. And she starts spiking. You do USG and this step to piperacillin tazobactam and the child improves. Then there is a big discussion of whether we should treat it or not. Yes, once you open the bowel, once there is an intraabdominal surgery performed, whatever it grow in the blood culture needs attention. So this enterococcus, which was isolated in blood culture, was fortunately sensitive, and this child was treated with linezolid. 17-month-old, this child is courtesy Dr. Sham Kukareja from Delhi Max. The second case is 7-month-old girl was admitted, had fever for 4 days. This child had undergone living donor liver transplant at the age of 9 months at Apollo hospitals and was on immunosuppression like tacrolimus and MMF. This child came back and we sent blood culture, and the child was put on injection Piptas. However, the blood culture grew VRE and we had to step up the antibiotic, and this child was later on treated with vancomycin, discharge on linezolid. So vancomycin resistance amongst enterococci is attributed to spectrum of genes, VAN A to VAN E, and you have to have MIs of more than 32 to label it as vancomycin resistant enterococcus. And the A gene encoded resistance is very high level of resistance, and teicoplanin can also be not a very good choice at times, especially when you have MIs of more than 16. However, a subset of VRE with say vancomycin VAN B encoded resistance can be sensitive to teicoplanin and can be used successfully. So what are the risk factors? When do you suspect VRE infections? Prematurity, prolonged stay in the ICU, indwelling catheters like IV lines, urinary catheter or shunts, necrotizing enterocolitis in the neonate, intraabdominal surgery, immune dysfunction, you have chronic renal failure, malignancy, transplant patients, and if there is a use of agents like vancomycin, then one would have a very high index of suspicion for vancomycin cause UTI, infective endocarditis, intraabdominal and pelvic infection, and bloodstream infection, and at times meningitis as well. So how do we treat vancomycin resistant enterococci? You use linezolid treatment, including a few patients with meningitis. VAN B VRE can be treated with teicoplanin. I have already alluded to that. Quinapristine dalfristin is another combination which is effective, but when it comes to treating E. faecalis, so it is extremely important to have the culture antibiotic sensitive report to guide your therapy. Daptomycin, we have already talked about it. Ceftaroline, like anti-MRSA, has good anti-VRE effect, especially when it comes to treating E. faecalis, and has synergistic effect when combined with daptomycin. Tigecycline has also been used, but the data in treatment of VRE is very limited, especially in children. And finally, let us look at our age-old friend Streptococcus pneumoniae. Gone are the days when we used to say that most of the Streptococcus pneumoniae that we see are penicillin sensitive. Remember, the resistance is by alteration of penicillin binding protein to beta-lactam, and you have penicillin resistant strep pneumoniae, you have cefotaxime non-susceptible and cefotaxime resistant Streptococcus pneumoniae. We must not forget the revised breakpoints or MICs when it comes to treating pneumococcal infection. For many whereas in non-meningeal isolates, there is less than 0.06 is susceptible, between 0.1 intermediate and above 0.06. Use IV medication, the dose is high and the MIC is less than 2 to 4 and above it respectively for susceptible intermediate resistant. So there is no intermediate category in meningeal isolates. And if you look at this, publication from the growing trend amongst pneumococci to resistance to penicillin group of or beta-lactam group of antibiotics. Here the blue line is the penicillin resistance, and it is to the tune of 42.8% as on in 2016. And similarly, there is cefotaxime non-susceptibility to the range of almost 30%. Having said that, following this publication, which included a reasonably good number of samples from different parts of the country, the IAP...
Sorry to interrupt, 4 more minutes, please.
Yeah, I'll finish before that. So following this publication, the IAP vancomycin in addition to third generation cephalosporin like ceftriaxone in the treatment of community-acquired meningitis beyond neonatal age. And you send appropriate cultures if required, do molecular testing, and then once you have some definite result, you tailor the therapy accordingly. So when does one suspect DRSP? Previous antibiotic use, especially beta-lactam macrolide, previous hospitalization, daycare setting, institutional or orphanage, living in urban or crowded area, which most of us are, nephrotic syndrome, hemoglobinopathy, sickle cell disease, HIV, primary immunodeficiency, fever, etc. So when you have this kind of setting, one must think of DRSP. And finally, there is a big debate and discussion about dose of amoxicillin when it comes to treating otitis media. Now, if you look at this slide, it talks about the MIC value of antibiotics for acute otitis media pathogen related to concentration of drug in the middle ear fluid. Now, it is said that the amoxicillin does not achieve very good concentration in middle ear fluid. However, look at the patients treated with your standard dose of amoxicillin. Very often the treatment succeeds. So clinical failure is not very, very common. So we continue to treat these children with amoxicillin standard dose. However, on the background of some evidence of intermediate sensitive step pneumonia, there is a case to use high dose amoxicillin. And these are the children who have recurrent otitis media or resistant otitis media, where one may use high dose amoxicillin so that you take care of this gray shaded bar diagram, which represents perhaps the intermediate step pneumonia responsible for this kind of infections in some children. So only barring this recurrent and resistant otitis media, I think we should stick to a standard dose amoxicillin when it comes to treating otitis media. With that, I would thank once again the organizers and IIT Pune for share my thoughts on gram-positive multi-drug resistant infections. Thank you.
Thank you, sir. Thank you for finishing in exactly the time, 5 minutes or 2 minutes left for you also. So thank you for finishing in time. So I think Gyanamurthy sir is still not there. So without much wasting of time, now I request our own Jaydeep sir, Dr. Jaydeep Chaudhary from our East Zone to share his deliberation and share the screen. So he will be talking on MDR gram-negative bacteria. So it is over to you, Dr. Jaydeep Chaudhary.
Yeah, I hope the screen is visible.
Yes, yes, clearly visible.
Okay, and you can see the next slide also?
Yeah, yeah.
Thank you. Thank you. Good morning, everybody. Thank you, Chairperson. Thank you, the organizers, the IAP ID chapter office bearers for initiating this midterm CME. It's a pleasure. Now, I feel like I have come to bat after Sachin and Kohli. It's like, I mean, my two preceding speakers were Dr. Balasubramanian, Dr. Vijay Ole. They are Sachin and Virat of IAP ID chapter. So I am feeling a bit like Ajinkya Rahane or this Pujara type of character, but still I will try to score runs steadily and in singles. Now, the fact is that the gram-negative bacterial infection, which are becoming MDR, are a cause of bit concern because it's not only restricted to the hospital-acquired infection, but it has spread to the community infections also. There are not many studies on pediatric population, but in adult population, ESBL E. coli infection is up to 50% in some cases. And as we know, the quinolone resistant salmonella infection is often very high in some pockets. There are, as we know, sporadic reports of ceftriaxone resistant salmonella infection. This is mainly due to a new type of ESBL that we will discuss a bit, but still for a general practice, ceftriaxone is still the intravenous medicine of choice. For salmonella, we don't have to suspect resistance in all the cases. So that's an important factor that we must remember, though we discuss MDR infection. Now, almost 70 to 80% of gram-negative healthcare associated infections are by ESBL producing organisms, and even the rates of carbapenem resistance is also increasing. So these are few points of caution that we must all remember, and let us discuss a few cases. Now, this child is a 9-year-old boy who had intermittent fever for 2 weeks, was developed high-grade fever since the last 1 week. Initially, the child was treated with some homeopathic medicines. The child came with some mild pallor and a hepatosplenomegaly. Now, after admission and before admission, also investigations were done. Before admission, the investigation-wise, the total count was a bit low. Once SGPT was done, which is high, hemoglobin was around 9. Malaria antigen dengue was negative. Vidal done outside before admitting was 1 in 160 positive. And of course, after admission, Bactec blood culture was sent and IV ceftriaxone at 100 milligram per kg was added. Now, since admission, the child was having CRP high with platelet also coming down, that we will come later. But within this time, before these investigations were done, we found that bilirubin was normal, the liver enzyme slightly raised, USG showed hepatosplenomegaly with mild ascites, and on day 4 of admission, the child was on ceftriaxone, blood culture came Salmonella typhi. Initially, we were happy that we were treating with ceftriaxone, but the report showed it's resistant to all third-generation cephalosporin and sensitive to meropenem, azithromycin, teicoplanin, and colistin as the child was admitted and quite sick. So we started meropenem in place of ceftriaxone. Now, next day, the child deteriorated, looked toxic, the child was febrile, tachycardia, blood pressure was low, the child became more pallid, the skin became mottled with hemorrhagic rash and some abdominal distension. We suspected and then we did the investigation. The ferritin was high. This is the triglyceride, lipase, LDH, fibrinogen level. FDP was very high, as you can see, the chest X-ray. And yes, it was MDR typhoid with HLH. And when later the bone marrow was done, it showed hypocellular marrow with hemophagocytosis. So it was MDR typhoid. Then it developed HLH, though HLH is not a complication of MDR infection, but incidentally this child developed HLH and responded to meropenem and other steroids and other medications for HLH also. This is a 5-month-old baby, fever and cough for last 20 days. In between, the child was hospitalized twice, received multiple antibiotics. The condition deteriorated and 1 episode of convulsion was there. Outside, just before admission, investigations done, the normal count and CRP was also normal, and this was the X-ray. But with this history, the child was admitted. On admission, the child looked drowsy, but responding to stimuli, the pupils were constricted, there was tachycardia, BP was high, respiratory was tachypnea, bilateral vesicular breath sound, saturation was 100% with 4-liter oxygen. There was hepatomegaly. Investigations where other investigations were sent and ceftriaxone started, and this was the chest X-ray of the child. The second day of admission, condition deteriorated. There was increasing distress, falling saturation. The child needed to be intubated, ventilated. Inotropes started and sedatives added. We were wondering whether it's time to switch or upgrade antibiotics considering the clinical picture of the child and deteriorating X-ray. So we started meropenem and vancomycin. Then investigation showed high total count, high CRP, and there was sudden desaturation with decreased air entry on the left side. You can see the X-rays. White bore needle was inserted and water seal chest drainage was given, as you can see in the X-rays. Now the backtake came and it was Klebsiella pneumoniae, which was carbapenemase resistant. Which antibiotic now? Because the child was on meropenem and vancomycin, there is no point in continuing vancomycin as it's a Klebsiella. But what to do? It's a carbapenemase resistant. Which antibiotic now? So we started IV colistin, but there was no improvement of inflammatory markers, fever persisting. High ventilatory settings are inotrope required even after 72 hours of IV colistin, and you can see the chest X-ray. It showed further deterioration. So a bronchoalveolar lavage was done and it was sent. And bronchoalveolar lavage revealed a heavy growth of pan-resistant Klebsiella pneumoniae. It was resistant to beta-lactamase inhibitor combinations. It was resistant to carbapenem. It was resistant to colistin, which we were giving and the child was not responding. And it was resistant to polymyxin B. So we had very little option. Now, a pan-resistant Klebsiella or Acinetobacter, the treatment options are colistin or polymyxin with tigecycline, colistin or polymyxin with fosfomycin, colistin or polymyxin with mino or doxycycline, or double carbapenem like meropenem plus doripenem or ortapenem, or meropenem plus fosfomycin. But here you see the colistin is resistant in this particular child. So polymyxin also trying will not be very logical. And of course, it's a carbapenem resistant. So we cannot go to this below 2 lines like double carbapenem or meropenem fosfomycin. And we have this part also resistant. So we had very little options in our hand. So what we did empirically, we started fosfomycin and tigecycline, these two. It's empirically, it's not the recommended combination also. But luckily the child showed gradual improvement and extubated after 11 days and the child was shifted to HDU with mother, and here you can see the child. A 2-year-old boy had recurrent fever for last 8 months. There was a single painless solitary macule of about 4 centimeter to 5 centimeter on the left side of the forehead for the last 2 days, and the child also had abdominal distension. The child was sick looking, high fever, moderate pallor. There was generalized lymphadenopathy with cervical, axillary, inguinal, right-sided epitrochlear lymph node was also palpable. There was hepatomegaly and a large splenomegaly was also there. If you see the macule on the forehead, on admission, it was a simple macule. Then gradually, it turned into edematous papule, then erythematous pustule within 24 hours. And the next day, this was the picture, dark violet-ish color with surrounding erythematous halo. Hemoglobin was low, total count was very low, with absolute neutrophil count was only 462, platelet was low, so it was anemia with absolute neutropenia and also thrombocytopenia. Marrow was done, obviously. It showed myeloid hyperplasia, erythroid hyperplasia, and increased megakaryocytes, so it was hyperplastic marrow. USG, there was enlarged peripancreatic and retroperitoneal lymph nodes, so it was a generalized lymphadenopathy, part of it. And the blood culture and culture of punch biopsy specimen from the forehead lesion both revealed Pseudomonas aeruginosa. The cervical lymph node biopsy was not very productive. It was only a reactive hyperplasia. The immunoglobulin levels were normal. The peripheral blood lymphocytes were analyzed by flow cytometry for double negative T cells, and the patient sample showed 2.5% of double negative cells. So the diagnosis was there's an erythema gangrenosum as the presenting clinical feature of autoimmune lymphoproliferative syndrome, ALPS. Now, considering it's a pseudomonas infection, we empirically started piperacillin tazobactam and amikacin on admission. But when we got the culture report, it showed sensitive only to colistin and polymyxin. Otherwise, it's resistant to all the other antibiotics, as you can see from the report here. So we started colistin and the child responded. A 2.5-year-old girl, high fever for 20 days, cough for 15 days, the progressive respiratory distress for the last 4 days. The child got admitted. While taking history, we got a history, the case of freshwater drowning about 3 weeks back. And in between, over the 3 weeks, the child received amoxicillin, azithromycin, and cefixime also outside. The child was sick looking, febrile, tachycardia, tachypnea, saturation was low in room air, capillary refill was also normal. Auscultation showed decreased breath sound in the right side of the chest. There was hepatosplenomegaly and ceftriaxone was started. And when we took the X-ray came and it showed this picture. You can see the right upper zone. There is a cavity with adjacent pneumonitis. You can see here. And in the light lower zone, you can see a cystic lucency with predominantly thicker dependent wall. You can see the dependent wall is predominantly thick. So this was the chest X-ray of this child. We see the investigation serially before admission. The hemoglobin was dropping, the count was dropping, the platelets was also dropping. Initially, the CRP was very high, then it came down. This is just from the day of admission, and as we went down after the 20 days, the child's hematological parameter improved. But even after 72 hours of starting ceftriaxone, fever continued. We sent the blood culture initially, and it showed Burkholderia infection, which was sensitive to levofloxacin, meropenem, imipenem, and minocycline only. So levofloxacin was added, and the child became afebrile after 5 days. So as Dr. SBS was telling in his previous lecture, maybe the levofloxacin will come out as the drug of choice for suspected atypical pneumonia, as we found in this child also with this atypical presentation. Now, these are all gram-negative infections. If we note the mechanism of resistance of gram-negative bacteria, the commonest are the inactivating enzymes, which is the beta-lactamase. Then there may be impaired penetration in the cell wall also. There may be increased efflux or target modification. Now, the beta-lactamases actually are the hydrolyzing enzymes, which is plasmid mediated. Now, plasmids are dsDNA, which is present in the cell, but it's usually separate from the basic chromosome of the organism. And this often mediates the production of the beta-lactamase enzyme. Now, as we see here, the evolution of beta-lactamase initially after ampicillin was discovered around 1960s, it was quite sensitive to the penicillin group. Then gradually we find the development of ESBL, and the extended spectrum cephalosporin was detected around 1980s. As we come to the 2000s, we see more than 200 SPLs are there worldwide. Now, initially the
last 5 minutes,
yeah,
please.
I know, I'll finish in time. Initially, the ESBL could hydrolyze penicillins, cephalosporin, and aztreonam, as we can see here. So the sensitive antibiotic options were the BL-BLI combination, the beta-lactamase with beta-lactamase inhibitor combinations, and also carbapenem. These were effective. Now, gradually, and even more potent than ESBL that we had initially, the AMP-C lactamases, which were chromosomally encoded enzymes, they came into the system. Now, the mutants producing these enzymes, they are in copious quantities and are produced such that the beta-lactam and beta-lactamase inhibitor combinations are also ineffective. That we saw ESBL was effective, but here it's ineffective. So we only had the choice of carbapenem. So AMP-C beta-lactamases, our choice of antibiotic, we had only carbapenems. Then came the carbapenemases. So this enzyme, this is the most potent of all the enzymes that hydrolyze cephalosporin, penicillins, carbapenems, but luckily not aztreonam. And the conventional beta-lactam, beta-lactamase inhibitor combinations are ineffective. This carbapenemase can be serine carbapenemase or metallo beta-lactamases. The serine carbapenemase are also known as Klebsiella pneumoniae carbapenemase, that is KPC, and also OXA, that's another. And the metallo beta-lactamases can be various, like the NDM and others. Now here only we have a very limited option in our hand. We have polymyxin, we have tigecycline, and we have fosfomycin to use. So this is a very, very critical situation. So we are moving up in the ladder of antibiotics, and now we have only few antibiotics in our armamentarium. So these antibiotics are right now available, and we have to use judiciously. But unfortunately, this excessive use of polymyxin has now resulted in very limited number, though, but it's an ominous sign, presence of the prospect of totally drug-resistant organisms or pan-drug resistant organisms that we were talking about. One case we presented. So that's an ominous case. So we are actually exhausting our armamentarium. Now we have few options of in our hand, the newer BL-BLI combinations, which are the first two, that is ceftazidime avibactam and meropenem vaboractam combination, which are have got the approval, but it's not available in India. But again, these are ineffective against the NDM carbapenemase, and in India the most common carbapenemase are NDM and OXA. So that is a very critical situation. Another option is there, which is in the trial phase, is the aztreonam avibactam combination. But
last 1 minute.
That is a long time to achieve. So practically we are at the dead end of the antibiotics. We have whatever we have to use judiciously. Otherwise we have to wait till we get these antibiotics, and that's a very, very difficult situations that we might be facing. So we have to be judicious in our antibiotic use. Thank you. Thank you so much.
Thank you, Dr. Jaydeep, for finishing in time, and very nice discussion about the 2-3 cases, very complicated cases that you have managed. So now it's a time for the question answers. So organizers, are there any question in the chat box? Because in my chat box, I am not getting any questions. So is there any question from the other link?
No, I don't see any questions.
Okay. So then one question and answer has come. What to see practically in culture reported in different types of microbiologists, especially by a general pediatrician, from Anup Kothari. So anyone can take this question. What to see practically in culture reported in different types by microbiologists, especially by a general pediatrician. This question is there in the question and answer box. You can see also, anybody wants. Because we are getting a lot of different types of culture report from different labs. So how to interpret the culture report from different labs? That's the question I think Dr. Anup is asking.
Yeah, if I may take that question, Dr. Dash, I must first of all say that it's a good practice to ask for culture, number one. Number two, most of the laboratories have now started giving MICs So that would be of great help in selecting antibiotics when you have different antibiotics effective against an organism. Number 3, please don't treat any report in isolation. You must always take into consideration the clinical picture and corroborate your antibiotic. For example, for common pediatrician, I'll give you an example. You have a child with UTI where you grow E. coli and the child has improved on, say, Ceftriaxone or Cefixime, and the report comes as ESBL, showing resistance to Ceftriaxone or Cefixime. Here the child has responded because the beta-lactams are hyper-secreted in urine, and high dose can overcome this kind of resistance. So don't treat a report in isolation. Number 3, you need to know there are certain pathogens which are inherently resistant to certain antibiotics, and then the culture reports are based on the achievable MIC in the serum, and we need to have the desired concentration made available at the site of infection. So very often Salmonella typhi, for example, would show sensitivity to aminoglycoside. However, we know that it being an intracellular organism, your aminoglycosides are not going to be of any use in treating such infection. So there are different, so many nuances of interpreting a culture report. And of course, I'm very happy that almost none of the labs in India now any longer report 1+ or 2+ or 3+ in terms of sensitivity and resistance. They have started reporting S, I, or R, and many labs, in fact, have started giving the MICs. Finally, when antibiotic is rolled out in practice, not only the in vitro culture report, but the effectiveness of such an antibiotic has to be backed by ample clinical trial where the particular antibiotic needs to be shown to be effective in clinical trials. Unless you have that data, you cannot just simply go by what is there on paper and what is demonstrated in the laboratory. I think this should cover, this should satisfy the query raised by the delegate and should be of use in practice.
And there is one more question. What instruction to be given to lab for Salmonella specifically, for Salmonella culture?
Salmonella, fortunately, is very easy to grow organisms. Rather than lab, I think we must instruct the pediatrician that regardless of the antibiotic that the child has taken, first of all, don't start antibiotic before sending culture. And if the child has taken some antibiotic, please make an attempt to grow Salmonella and send adequate quantity. In automated system, you see that you maintain the ratio of 1:5 in the culture broth and the sample that you collect. You inoculate this blood in culture broth and send it. And at times Salmonella grows easily, but at times it is worthwhile waiting for 3-4 days also. Sometimes you see a delayed growth of even Salmonella.
And last question, why the MIC is low for meningeal strain of pneumococcus as against the non-meningeal strain of pneumococcus? Is it because of the different strains?
It is not
strain of meningeal strain.
It is not because of the different strains, but it is because of the ability or inability of the antibiotic to go and achieve that much concentration. Fortunately, it is only in the inflamed meninges that some passage occurs across the blood-brain barrier. Otherwise, the blood-brain barrier is to cross. It's not all that easy, and so that's why you have to be extremely selective when it comes to treating CNS infection. So the same step pneumonia. However, the ability of the antibiotic to achieve a particular concentration in the CNS tissue would vary because depending on the permeability of the blood-brain barrier.
Thank you so much, sir. Now we'll conclude the session and we'll hand over to the organizers for the next session.
Thank you very much, Dr. Balamurthy, sir. We conclude the third session here and move on to our fourth session. Allow me to share my screen.
Madam, just hand over to the chairperson of the ID chapter.
Okay. So for the fourth session, which is a Dr. Tapan Ghosh oration, I hand over this session to
Dr. Yagnesh Popat, sir.
Yeah, thank you.
Hello,
Dr.
can you hear
Sanjay.
me?
Yeah.
Can you hear me?
Yeah.
Yeah, sorry. So Dr. Tapan Ghosh oration, I hand over the session to President Infectious Disease Chapter, Dr. Yagnesh Popat. Thank you.
Thank you, Madam. We start with the Tapan Kumar Ghosh oration. Tapan Kumar Ghosh is no one to all, but as my personal privilege to introduce or present some of the abilities of Dr. Tapan Kumar Ghosh, let me enumerate. His all-round contribution to Indian Academy of Pediatrics was immense. In brief, following were his achievements in the association: scientific coordinator in the Institute of Child Health, Kolkata. His passion for constant work benefited the institute to develop the academics and to create a state-of-art infrastructural facilities to provide quality healthcare facilities to the children at the affordable cost. He was the chairperson IAP Infectious Disease 2006-2007, a president of Indian Academy of Pediatrics West Bengal branch 2007, past president of Indian Academy of Pediatrics East Zone Coordination Committee 2005, joint secretary IAP Central Committee 2004, national coordinator for PP Quiz. He took initiatives in developing journals like Indian Journal of Growth, Development and Behavioral Pediatrics, and he was the editor-in-chief for the journal. And his association with the prevention and control of rabies in India was also noteworthy. He was a member of Indian Academy of Pediatrics Committee for Immunization. He conducted many CMEs, workshop, conferences on vaccine, infectious disease throughout his tenure. He had edited and authored many textbooks, monographs, and articles in various infectious disease areas and vaccines, etc., which had a wide acceptance among the practicing pediatrician and the postgraduates. A great academician, very dynamic personality, very kind-hearted human being. His extensive work in IAP has made a permanent imprint in the heart of pediatricians across the country. He was the strength of the pillar of IAP West Bengal and IAP as a general. He dedicated his life for IAP activities, a true selfless IAPian, rare to find. He has devoted his entire career for the development of childcare delivery services throughout the academic body of IAP and a postgraduate teaching institute in ICH. The cordial and loving nature of Dr. Tapan Kumar Ghosh has developed a good unity amongst the pediatricians across the different states of India and in the neighboring countries, Bangladesh, Pakistan, and Nepal. We all pediatricians across India and neighboring countries deeply mourn for the extremely sad and untimely demise of our beloved Dr. Tapan Kumar Ghosh on the 6th November 2009 at 8 a.m. at Goa. He was 56 years and left behind his wife, 2 daughters and elder son-in-law, and many friends and well-wishers. Our sincere prayers towards his peaceful rest at the heavenly abode. Tapan Kumar Ghosh really lived a life for all of us, and our salute to him. We are united, we all united would fulfill his vision for the glorified IAP. Long live the memory of Dr. Tapan Kumar Ghosh. Thank you. Now I will request our secretary, Dr. Kea Ghosh, to present the details about the achievements of our today's orator, Dr. Abhay Shah.
Thank you, Dr. Popat. I feel very nostalgic and to chair a session on Dr. Tapan Kumar Ghosh. Sir was the person who used to encourage me from my student life, from my PG life. He involved me in all the activities of IAP. And he has an immense contribution to involve me in this IAP infectious disease chapter. Sir, you will be always remembered. Now, it's my proud privilege today to introduce Dr. Abhay Kumar Shah, a ever-smiling personality, a lovely human being, a famous pediatrician, and above all, a great academician. He has a brilliant start of his professional career by achieving gold medal both in MBBS and MD. He is presently the director of Children's Hospital and Pediatric Infectious Disease Chapter, Maninagar, Ahmedabad. He was a member of SCVIP 2020-21 and also past member in 2018-19. He is the National Scientific Convener IAP Action Plan for 2020-21. He was the executive board member of Central IAP 2018-12 and 2009. He was the chairperson of Infectious Disease Chapter, our own chapter in 2015. And we have all seen how academically he organized. And this year also, he's contributing a lot to the IAP Infectious Disease Chapter, being the academic administrator and planning the academic sessions. His areas of interest are infectious diseases, vaccinology, general pediatrics. He is a resource person and contributed for more than 25 IAP modules. He's a recipient of Dr. Shivananda Oration 2015. It's a member state mentoring group of Lakshya Improvement Program of Government of Gujarat. He had many publications, all of you know that, and has contributed his chapters in the book, and all those numbers exceeds 50. He's a member of editorial board of a number of famous books that we read on daily life: IAP Textbook of Pediatrics, Textbook of Pediatric Infectious Diseases, IAP Textbook of Vaccines, IAP Guideline on Immunizations, Color Atlas of Pediatric Infectious Disease, FAQ in Pediatric Infectious Disease, Immunization in Clinical Practice, 2nd edition, and Textbook of Pediatric Tropical Diseases, FAQ in Rational Antibiotic Therapy, Handbook on Infectious Control in Hospital Settings, IAP Question and Answers in Vaccine and Vaccinology. And friends, the list is long, and all of you know, and so I think I will end the introduction here. Over to sir.
Before Dr. Abhay Shah starts, let me add a couple of lines about the other qualities of the such a huge academician. I have known him since 2005 when he entered the active IAP as my secretary in AOP Gujarat. It was his first appearance in the active IAP. Thereafter, we had worked together at various platforms. His administrative skills, his communication skills, and respect for the fellow colleagues is also noteworthy. So it is our proud privilege to have a Tapan Kumar Ghosh oration delivered by Dr. Abhay Shah. Over to Dr. Abhay Shah. Now platform is yours.
Yeah, thank you, Dr. Yagnesh Popat and Dr. Khea Madam for giving me this nice words of introduction. And before I start my deliberation, I'm extremely thankful to the IAP ID chapter, office bearers, EB members, and all the members for giving me this wonderful opportunity and a great honor. And before I start my deliberation, let me remind some of the memories with Dr. Tapan Kumar Ghosh. I have known him as an staunch IDian, an ardent IAPian, a great academician, and a great contributor. Though I have a connection or association with a very short time, but we're so intimate and close. In every ID event, I feel that Dr. Tapan Kumar is always with us. Secondly, he was a person who has always encouraged the youngsters. And it reminds me of first experience, the first association in Ahmedabad, when we organized our national CME on antimicrobials under leadership of Dr. Raju Shah and Dr. Baldev Prajapati. At that time, I was a joint secretary of that conference. And after my deliberation on MDR staff, it was just a small 15-minute talks, but he came crossing 2 lanes of sofa, patted me, encouraged me, and he told me that persons like you and many youngsters are the need of the chapter. Otherwise, this chapter will be going to be in the hands of only few persons. And today, this infectious chapter of IAP, I would say it is one of the most vibrant and the largest association of the chapter in the history of Indian academic pediatrics. So I pray my tribute, my namaskar to this great soul, and I thank once again IAP chapter for giving me this honor. And I now start my sharing the slide. And the topic that I have selected is emerging challenges in the recent times from the perspective of the pediatric infectious diseases. And friends, when we have an unprecedented pandemic of corona, I think what big challenge or the worst challenge we can imagine. But if you look at the history in the past, the medical history teaches so many things. I think the medical history teaches us where we came from, where we stand in the medicine at the present time, and in what direction we are marching. It is the compass that guides us into the future. And yes, when the same medical history has now disproved our famous optimistic and dogmatic quote by William Stewart that it is now time to close the books on the infectious diseases. Why? Because the microbes are versatile genetic engineers. In spite of having their very fragile genetic material, very fragile, very small and tiny genome, they keep on changing and changing and emerging and re-emerging. And this emerging infection is nothing but a new unidentified infectious disease. It may have some recent increase in the incidence, or if there is a threat in the near future. And there is sometimes an old disease with a new features which might have crossed the boundary of one region to another region, which have targeted the next population or the different age. What I mean that emerging, it is already emerging, it has been recently emerged, or are going to be emerged. As far as the re-emerging infection concerned, there is a period of long quiescence following the discovery, or these are the infections which are thought to be controlled, eliminated, or eradicated. The classical example is chikungunya, which was first identified in 1963. We have a resurgence since 2006. Where the Zika, which was identified in 1960, has a resurgence in 2015. And here is the map. You can see that the chikungunya initial outbreak was in 1963, which was caused by the Asian strains of the virus. But now we have got the African strain of the virus, which causes a large outbreaks across the nation. We have got the diphtheria and pertussis, and majority of this resurgence is mainly because of the low coverage of primary immunization as well as the booster. And if you look, you will notice the epidemiological profile of this new emergent and resurgent diphtheria and pertussis. You can see that there is an epidemiological shift, and now the outbreaks have started occurring in the older children, especially 5 to 19 years of the age. Having said that, let me now take you to the newly emergence of the disease. And amongst them, I think the zoonosis is up front. And the researchers have documented that at least approximately one new human infectious disease has emerged every 8 months. I repeat, one infectious disease every 8 months. And in the last 3 decades, we have got new 35 infectious agents. And 75% of them are of zoonotic origin, and out of them, 2/3, that is 65%, are originating in the wildlife. And amongst them, 44% of viral, followed by protozoal infection, and the rest of the organisms. Remember, the current COVID-19, our Ebola, MERS, swine flu are the instances of the zoonotics. And why this zoonosis emerging? And this is mainly because of the imbalance in the ecosystem created at the human-animal interface. And there is an interaction with the wild and domestic animals. There is a migration of the infected wild birds, and this probably results into a loss of biodiversity. There is a spillover of the microorganism or the virus from one species to other species, and when this organism passes into the multiple hosts, it is more prone to have mutation, reassortment, and development of a new virus, and that is how the novel virus comes into the picture and the zoonosis pandemic falls. Remember that the current COVID-19 has a resemblance as far as the genome is concerned, similar to bat coronavirus by tune of 96%. And in addition to this encroachment of the ecosystem, there are 3 important factors, that is expanding population, globalization, and migration. And this triad is very, very dangerous and has always a link with the new epidemic event because it gives rise to an opportunity of an organism and a vector to flourish in the newer areas of this globe. When there is an expanding population, there will be a demand for the land. There will be a scarcity of the water. There will be a deforestation. There will be agricultural reforms. And all this will damage the ecosystem, will reduce the biodiversity, and will give rise to the emergence of the new organism. In addition to that, when there is a water system or a land shortage, shortage in the water or in the land, remember that it gives rise to a vector-borne diseases, that is mosquito breeding. And now we have got the resurgence of the dengue, chikungunya, Japanese encephalitis, and the West Nile disease. As far as our lifestyle is concerned, recently the lot of youngsters and persons are involved in the tattooing and the drug abuse. And if they are unsafe tattooing is there, they give rise to a blood-borne virus infection like hepatitis B virus, hepatitis C virus, and even HIV. Our medical advancement, the transplant, use of the immunomodulators are very, very important as they give opportunity for the opportunistic infection to give rise to this. There is a development or emergence of the healthcare associated multi-drug resistant organism. And at times, there is a reactivation of the various latent infection, which may include cytomegalovirus, EB virus, HHS6, and even parvovirus. So even it is not only the disturbance in the ecosystem, but our human behavior, our lifestyle is also important. People are now going for the wildlife hunting. They are now going for the exotic places as a recreation, as a refreshment. And I think this encroachment to the animal habitat is the main source why the zoonosis is emerged. Remember that our COVID-19 has emerged because of one person eating the bait soup. So that is the real instance of the zoonosis is concerned. Now, let us not forget our misuse of the antibiotics. The antimicrobials are used widely in the livestock. And this has reduced the microbial diversity, and therefore the selection pressure and a mutant drug or the resistant drug is selected. And the classical example is a methicillin-resistant Staph aureus transmission from pigs to humans. We have got the immunization disruptions because of the many causes. We have got the vaccine refusals. We have got the vaccine hesitancies, and probably this result in the re-emergence of the vaccine prevention disease. Of course, these two are very, very multifactorial, and this gives to poor coverage and absence of the herd immunity or the less of the herd effect. The other one is the neglect of the biosafety requirement, a bioterrorism. I think a new mishap that is coming, and natural calamities like flood gives rise to the resurgence of the leptospira and civil unrest. These are some of the factors which leads to emergence and non-emergence of the various diseases. Now, having said that, once the new organism has emerged or re-emerged, the old organism, whether it will go for the pandemic or not will depend upon the number of factors. And this number of factors are microbial factor, environmental factor, and the host factor. It is the interplay of these three factors will decide whether the organism has a pandemic potential or not. So we have already discussed the environmental factor and host factors and their interaction. But what I want to say that as far as the microbial factors are concerned, there is selection pressure for the fitness. There is always a struggle for the survival, and there is always a struggle for the existence. There is selection pressure, and this ultimately passes the number of the host, and there is emergence of the novel virus strains with or without assortment. And once there is a novel virus there, it helps to overcome the immune surveillance system. This mutation will modify the receptor structure in the body, will ease the entry and the replication of the virus in the body. There is viral genomic recombination, and there is persistence of the organism in more than one species. And that is how the pandemic takes place. Having said that, we have got a huge number of organisms which are there. You can see that the red one are the newly emerging one. We can have a blue one, they are the emerging one. And you can see this here, the enterovirus, you can see H3N2, you can see E. coli 0104, you can have MERS-CoV, and to add into the list now, we have got SARS-CoV-2, since the end of the 2019. Now, as per the major global outbreaks of the recent time in concern, I will not go into detail of this table, but we have got the SARS in 2002, swine flu pandemic in 2009 and 10, MERS in 2012, Ebola in 2014 and 16, Zika in 2015, and COVID-19, which is currently we are facing. But what I want to emphasize that all are the instances of the zoonosis. So friends, as far as the re-emerging challenges concerned, I think zoonotic has a prompt place in our biosphere. And as far as our India is concerned, there are three major categories of the newly emerging viral infections. They are the respiratory viruses, which include our H1N1 2009 pandemic, H5N1 influenza, SARS-CoV-2 2003, MERS 2012, and COVID-19. As far as the arbovirus is concerned, we know about chikungunya and dengue, but new are the Crimean Congo hemorrhagic fever and Kasansur forest disease. As the bat-borne disease is concerned, we got the Nipah as well as the Ebola virus. And if you look, that they have a simple common presentation. All these viruses can present as a mild disease, can have a fatal illness. They all can have an unpredictable course, and they usually present acute respiratory illness, viral hemorrhagic fever, or an acute encephalitis syndrome. They may start with any one of the system, but at the same time, a multi-organ involvement is also known to occur with all these emerging infections. Amongst the viral hemorrhagic fever is concerned, there is always a typical epidemiological fever, epidemiological link. There is a fever with thrombocytopenia. There is rapid onset of coagulopathy and multi-organ involvement, and there is an unpredicted and unprecedented force. So it is a very it has our biosafety level 4 pathogen, and remember that they have got a long incubation period. And because of the long incubation period, I think it is very, very important to remember our travel history. We sometimes forget our travel history of short duration, but it is very important that this travel history is very, very important. And as far as our Indian subcontinent is concerned, we have in our own Gujarat in 2011, we have got the Crimean Congo hemorrhage and the Zika in 2017. In I would say we have got the Zika virus in 2017 in Tamil Nadu, and the most important of the last of the recent past in 2018, it is the Kerala, that is the Nipah virus. I will have a special mention of Nipah virus here because in this outbreak in 2018, out of 19 persons who were infected, the mortality was seen in 17 people. Means the death rate is 89%. So I think it is a highly, highly fatal disease, and it can present with the encephalitic fever, encephalopathy, drowsiness during the mental cancer. And so it is a very, very important. The first outbreak was detected in 1919, but since then we have got the 11 outbreaks. So this Nipah is the latest addition in 2018. As far as the acute encephalitis syndrome is concerned, I think it is now time to revise our protocols and our book. As soon as we hear the name of the acute encephalitis syndrome, we say that the Japanese encephalitis is the commonest cause of endemic and epidemic encephalitis. As far as sporadic encephalitis is concerned, I think it is the herpes simplex virus. But now you can see here that the 20% of acute encephalitis syndrome are because of the scrub typhus by this organism. And we have seen that the Japanese encephalitis is now migrating toward the urban pocket. So I think these are two important challenges that are coming. One is the development of JE in the urban pockets and spread of the scrub typhus in the various parts of India. And now I feel it will not be a bad idea to add doxycycline as an empirical therapy in all cases of acute encephalitis syndrome where scrub typhus is known to occur. As far as the emerging respiratory viral illnesses are concerned, I will touch upon two important things, that is H1N1, that is 2009 pandemic, and the current SARS-CoV-2 2019 pandemic. Now, people have said that both are the influenza viruses, but they have quite difference. Remember that this new coronavirus is 10 times more transmissible and more serious than our conventional flu, that is influenza. And this is mainly because of that, you can see that this genetic structure is fragmented. And because this fragmented genetic material is there, they are more prone to antigenic shift and drift. And here you can see that genome is a non-segmented. And if you look at the epidemiological factors, I think the incubation period as far as H1N concern is 1 to 4 days. Here children are affected. Actually, the children are the vector. When one child in the family is affected, I think it can transmit the disease to more than to entire family. And the speed of transmission here is more, but it is short lasting, and the clearance of the virus from the body is fast. And that is how the calamity with H1N1 is comparatively low as compared to our new SARS-CoV. As far as SARS-CoV-19 is concerned, the spike protein is the most virulent component, but you can see the incubation period 1 to 14 days. And because of this long incubation period, it remains infective for a long period of time. The virus clearance is very, very slow and transmission is long. And that is how it transmits disease one person to another. And this transmission rate is mainly because of one important factor, that is our reproductive number. And you can see this, that R0 in COVID ranges from 1.9 to 5.7. I think it's a dynamic process. This keeps on changing. But if you take the R0 of 3, I think 1% can infect 3%. And this is how about 40% are infected in no time. So that is a very, very speedy transmissible disease as far as the COVID-19 is concerned. Now, WHO has declared this COVID-19 pandemic, as we know, on the 11th of the March 2020, after the first case has been described in 31st December 2019 in Wuhan. And as one of the wonder, I would say, research in the field of medicine, we have got our own vaccine on 16th January 2021. That is where the India began its vaccination program, and that is a proud moment for all of us. But in this process, till today, we have lost 3.9 lakhs individuals, and the infection has gone to nearly more than 3 crore individuals. Now, which are the challenges of this current time? So, as we talk of this COVID-19, I will look at it at two different parts. Number one, what has happened during the wave 1 and what is happening currently during this wave 2. The wave 1 was mainly conspicuous by our knowledge gap. The virus was new, we were new, and we were struggling. Everyone was scientists, researchers, all were struggling how to go about it. And as far as the wave 2 is concerned, I think the entire health structure and infrastructure was struggling how to tackle this pandemic. And the first important part I would take is a knowledge gap, that we were not sure or certain about the mode of transmission. We were struggling, whether it's a fomite, airborne, and droplet. Now it is clear that fomite has less part to play. We were also not clear about the pathogenesis and pathology. We were talking first about the interstitial pneumonia like any viral pneumonia, but now then it has come that there is no the thing like pneumonia, and now we realize that probably it is mainly the pulmonary vasculature endothelial activation. As far as preventive modalities, non-pharmaceutical modalities are concerned, WHO has declared there is no need of the mask initially. We all remember that. But now we say that yes, mask is important. Not only mask, a double mask is also good. So that is how it has changed the non-pharmaceutical modality. As far as the repurpose of drugs for the treatment and prevention is concerned, azithromycin, our hydroxychloroquine, doxycycline were used, misused, overused, and disused. And as far as reproxy vaccination, people were moving here and there with BCG, MMR, and flu to have some indirect protection with the COVID-19. But friends, over the time, we have become more wiser. Experience is the best teacher. And by the end of the 6th wave, 6 months of the first wave from the beginning, we have realized that we have got the 3 different stages. That is a stage of viremia, pulmonary phase, and hyperinflammatory phase because of the release of the various cytokines. And we also realized that as far as the mortality, morbidity, and hospital stay is concerned, the day 5 and day 15, the interval between day 5 to 15 is very, very crucial. Remember, these were the days in the initial part where the diagnosis of some microbial disease was done with the help of the HRCT and not with the help of molecular or with the culture techniques. So these are the major challenges as far as in the early part of this pandemic is concerned. And because we thought that there is period of viremia, we were using antiviral left and right. But we realized when the clear guideline came in nearly in January 21, that the only thing works required is a prednisolone, that too in a severe cases, hospitalized cases, and they are not required otherwise in mild and moderate cases. There is no role of the anticoagulants as far as prophylaxis is concerned. There is no role of the favipiravir, remdesivir, toci, HCQ, chloroquine, and there is none of the drugs, including ivermectin, have any prophylactic role. So by this time, the guidelines have been very, very clear. As far as the disease severity and statistics is concerned, we have got our IAP guideline. IAP has always remained proactive in publishing and publishing all this type of the material for the fellow pediatrician and the health of the children of our nation. And as far as the disease statistics are concerned, we have now reasonably wiser that it is a mild, moderate, and severe disease, and sometimes the critical cases. And the investigation and the hospitalization is required only for this moderately severe with SpO2 less than 94, or the child who has got the severe disease or a critical disease like shock or MISC. So this is the situation how up till now we have lost, misused our resources unnecessarily because of the knowledge gap. Having said that, let me push you that while we were learning all this, the first wave, because of its natural course, has come down, but only to reappear after second wave. So now we are wiser as far as our protocols are concerned. But this second wave was rising dangerously fast. And if you look at the figures, I will not go into the jargons of these figures, but if you look at the highest cases recorded on 18th of April, 2,73,000, which was quite high, more than double of the first peak, that is nearly 98,000 in September 2020. So we were have good protocols, but we were not having the enough infrastructure. Now this is the second wave where the children, large number of children got infected. There is increased severity of infection has also been declared, and more number of cases of the multi-inflammatory syndrome have started appearing again. But still, disease in the children is still milder than adult, and only 1 to 2% will need hospitalization. Lucky enough for us as far as pediatric practice is concerned. But we also know that this second wave was full of crisis and catastrophe. People were searching desperately for the life-saving measures like oxygen, ventilation, and ICU. And two important things emerged out during this second wave. Number one, a stressed public health system and the collapse of the global solidarity. And this global solidarity means that there was an undervaluing of the science, there was weak public health infrastructure, there was lack of vaccine, and a great resistance from the public to use our mitigation measures with discipline, that is measuring mass, maintaining social distance, and there was unwanted gathering, unwanted crowd, political rallies, and all the social marauders. I think these were enough to add fuel in the fire. And if you look at the pitfalls and lessons from this, I think there was a major delay in the China's reporting as per the first case was identified, number one. Second, WHO has also been criticized for not declaring the health emergency, because by that time, nearly the virus has gone 10 to 20 places outside China. And along with this, the third thing that has emerged as a challenge to all of us is a global bidding war. There was a global competition for the scarce medical resources, including the vaccine. And therefore, the person who are living in the high income country were at some benefit at the cost of the deaths and disease of the low and middle income countries. But there was a silver lining in the cloud. And therefore, we come out with a COVID-19 vaccine. After Ebola vaccine, which took even 5 years to develop, this is the vaccine that our researchers, scientists can develop just in the tune of 1 month or 1 year or 15 months. But this was also not enough. Why? Because there was a lot of scarcity as far as our India is concerned. There was unequal distribution of the vaccine. And there is always a problem of the vaccine hesitancy, especially when the new vaccine comes in the fold. As far as the inequitable distribution of vaccine is concerned, high-income countries with their own vaccine supply were able to give their entire population by the end of 2021. And in a sharp contrast to that, a low-income country may not accomplish the same until the 2 years. And remember that these 2 years is a big gap as compared to the mortality and morbidity associated with this dreaded monstrous virus is concerned. Now, with some estimate predicting the world will not be fully vaccinated till the end of a decade. So I think this vaccine inequality is very important as far as the resource restriction in the low and middle income countries are concerned. As far as the vaccine hesitancy is concerned, delivering the vaccine in the world's second most populous country is always going to be challenging. We know that India is a large country and to vaccinate them is very difficult. And if you look at the literature, the India's vaccine hesitancy was in the tune of 28.7%. This includes all our ignorant, judgmental and prejudiced people. But remember that, surprising that in a highly informed group like resident doctors in the 22 states, the survey was done, and they were also have some amount of some status of the vaccine hesitancy in the tune of 10.6%. So I think this vaccine hesitancy is very important to remove as if we want to have a high vaccine coverage and to get the herd immunity and herd effect as early as possible. Having said that, we need to remove this vaccine hesitancy. And it is mainly, we can do it by our education drive for the safety and efficacy of the vaccine. Every single person should be there. We should remove the misinformation. We should review our existing system, and there should be easy access to the vaccine, including we may include some of the incentives that if you vaccinate the person, you will get some incentive. And some of the misinformation regarding this vaccine where that there's a fear of the genetic disease, there is a fear of neurological disease, there was fear of sterility, there was a fear of disorder of the menstruation and even death. And therefore, something like Amitabh Bachchan or a celebrity can come forward to say that jind ke liye do bund kafi hai, just like polio, we need to have some of the celebrity. We need to emphasize the people that more vaccination for the COVID means a chance to return to the normal. So that is very important. And nearly these vaccines are going to be nearly 100% effective if you want to prevent the severe disease and death from the COVID-19. Needless to say that the COVID-19, though vaccine development was fast, it has not skipped any step as far as safety and efficacy trials are concerned. And the vaccines were used on the platforms which we were using, scientists were using over the ages. So I think this type of the reinforcement is and reassurance is very important if you remove the root cause of the vaccine hesitancy in our country. As far as the second wave is concerned, unfortunately, the rise was very steep, but at the same time, the decline was also very fast. So now we are coming at the fake end of the second week. We are just having a sigh of relief, but at the same time, we are worried that whether the third will come or not. And this third wave will depend mainly on the three important things. What will be the COVID appropriate behavior of the masses? If we would not follow this COVID appropriate behavior, probably the upcoming wave would be going to be a harsher and harsher. Then the behavior of the virus, how the virus changes its genome personality, how it's going to wear. And last one, how speedy the vaccination coverage is there and how vaccine is going to be effective against the new variants. As far as the variants are concerned, I think they were first named as their region of origin, but now we have got the alpha, beta, and delta. And out of this, the delta strain has now moved across 80 countries. And amongst all these mutants, let me tell you that they have got the increased transmissibility, they have got the detrimental change in the epidemiology, there is increased virulence or change in the disease presentation, and there is decreased effectiveness of the prevention and control measure. And most important, they have got the immune evasion and escape. And probably if this virulent new variant is more virulent, is not matching the vaccine strain, probably we need a new vaccine or we may need a booster. But I think it's a research work which is to be done. And for that, probably what is required is a tracing and tracking, and a genomic surveillance is a need of the time. So this genomic surveillance will give us give idea how to identify the variation in the existing SARS-CoV-2 virus and monitor the new variants in terms of the understanding the science that how it has a impact as far as the health of the public and epidemiology and transmission is concerned. I think the genomic surveillance is the need of the time. As far as the post-COVID illnesses are concerned, of course, we are not in the post-COVID phase, but I'm telling of the post-wave 1 and phase 2, we are facing with the three important problems. One is a mental health, second is a MISC, and third is the mucormycosis. And as far as the post-COVID impact is concerned, I think this mental health issue is likely to outlast a silent pandemic. It's a silent pandemic. It is going to last longer and longer, even after a acute COVID. I will not go much in the debate. I will just only look at the PID perspective of this, but we have the increased cases of anxiety, depression, stress, psychosomatic disorder, obesity, fearful attitude, and whatnot. As far as the MIS is concerned, I think it's a post-infectious hyperinflammatory response. You can see this a blue line and a red line. The red line follows the blue line by the tune of 4 to 6 weeks. And this is the case where the post-COVID multi-inflammatory syndrome is there. We know how to diagnose. We have treated a number of cases. We have now the protocol for the diagnosis. But what I want to say that this is mainly thought to be because of this neutrophil entrainment, enhanced antibody dependent enhancement, super antigen, and recurrent antigen expression. The four mechanisms have been there as far as the development of the MIS is concerned. And in 60% of cases, the serology for the antibody post COVID-19 is always positive. But what I want to sensitize about you is that positive antibody for COVID-19 is not MIS-C. That is very, very important message that I want to give, that all COVID antibody is not a MIS-C. WHO has given us the criteria as per the definition and the diagnosis of the MIS is concerned, and all these 6 must be present. That is age 0 to 19 years, fever more than 3 days, involvement of the more than 2 organs, elevated markers. But what is important is that we must rule out other obvious cause for the same syndrome, like toxic shock syndrome, rickettsia, dengue shock. So all this is very, very important. And there should be an evidence of the COVID illness. And therefore, the another challenge that has emerged in this pandemic is the overdiagnosis of the MIS-C, but missing and underdiagnosis of common illness like typhoid, brucella, hepatic abscess, dengue, and rickets. It is very, very. I have seen that 4 cases were referred as MISC, where 2 turned out to be typhoid fever, 1 out to be a hepatic abscess, and 1 turned out to be a brucella. So I think the neglect of the non-COVID illness is also very, very important emerging threat as far as the current time is concerned. As far as the mucormycosis, it is mainly we see mainly in the adult, but you can see that in 2019, before the pandemic takes place, you can see this bar is very short, but this white bar is all about mucormycosis, and therefore the incidence is rise. This mainly because of the indiscriminate use of antimicrobial, glucocorticoid, immunocompromised child, and lapses in the infection control practices. So mucormycosis is not an issue as far as children is concerned, but it can occur any immunocompromised or any obese adolescent child. As per the, I think this is a big issue that we need to address, and that is the immunization disruption. And 80 million children are under the age of 1 year are at the risk of the vaccine preventable diseases. And you can see that more than half, that is 53% of the 129 countries where data are available have reported moderate to severe disruption in their various immunization schedule since April 2020. And the common reason of this are reluctant to leave the home because of the fear that if they go outside the home, probably they will catch the COVID-19. There was a financial issue, there was transport issue, there was lack of information. As far as the health structure is concerned, number of health staffs, workers have been deployed to a COVID-19 duties. The staff, there was no staff to take care of this vaccine. And last one, there was transport delay for the vaccine, where the vaccines are coming from other area, I think there was a transport delays were there and lack of guideline was also there. I think this immediate discussion is a huge problem as far as this COVID-19 is concerned. And if you look the data of this vaccine campaign that disrupted, the badly hit are the measles containing vaccine, that is measles, rubella or MMR, and that is polio, either both IPV, monovalent OPV, as well as the bivalent OPV. You can see that there are disruption in the 27 vaccination campaign as far as measles are concerned, and as polio is concerned, I think it is more than nearly 40. So this is the very, very important. And it is very, very important that we have neglected our non-COVID illnesses, which can be jolly well prevented by this vaccine. I think it's a time that we might have to face the epidemics of these vaccine preventable diseases because we have neglected them. And if you look at this polio, that as a part of the polio NK system, we have to go far. The game is not over. You can see this, the wild polio virus, that the bar is increasing, 175 cases as far as 2019 is concerned, and 140 cases in 2020 concerned. As far as CVDP is concerned, you can see there are more than 1,000 cases in 20, and till May, we have got 75 cases as far as the CVDP is concerned. So I think the game, polio end game, is not over, and this type of the, I think, vaccine interruption, vaccine disruption are going to affect our polio end game strategy adversely. And if you compare the reproductive factor of this, all this disease, COVID-19 has a 2.7, but the fatality we say it is just 0.1% of the children. As against this, the measles with a RO of 12 and 18, it has got the case fatality of 15%. As the pertussis is concerned, with a RO of 12 and 17, it is 1% in infants. So it is 10 times higher compared to this 0.1% of the COVID-19. As far as polio is concerned, it causes the paralysis, permanent paralysis, and mortality has fatality has IS 57%. So I think we cannot neglect any of the vaccine preventable diseases, and we should not miss any opportunity to vaccinate at any child. So this immunization disruption, I think, is a grave thing that we are looking forward. And IAP has, again, here is proactive. We, as the IAP, CYP, have given a clear guideline how to go about the immunization during COVID-19. As far as the antimicrobial resistance concern, I think it is the insidious and silent pandemic in making. The healthcare experts are now alerting that this COVID-19 is accelerating the perish of AMR. And this is mainly attributed to the use of steroid, antibiotics, and biologicals. Number of children, number of patients, a number of individuals have started doxycycline, azithromycin, ivermectin. There has been overuse of antiseptics. So I think these are the enough to have the foundation for the emerging new resistance. And we look at this, that 3.6% is the rise of the MDR. Out of them, 91% is bacterial and 5% were fungal. And this is mainly because of the impaired ability of the host to clear the bacterial pathogens and the bacterial products because of the release of the cytokines like IL-10, IL-6, and IL-17. IL-20, there is reduced function of the dendritic cell, macrophages, and natural killing cell. And if you look at the study of 17,000 patients, ICMR, at 10 different studies, the incidence of 3.6%, and out of this, majority of them is a gram-negative, the Klebsiella, Acinetobacter, Pseudomonas, E. coli. And you can see here that 83% of the organisms are because of the ESBL Enterobacteriaceae, and out of these, nearly 70% were carbapenemase negative. So I think resistance to a gram-negative, that is CRE, carbapenemase resistant Enterobacteriaceae, has risen like anything during this COVID-19 pandemic. And this is again in addition to our own ICMR survey of methicillin resistance, that it is now endemic in the tune of 25 to 50% in different parts of India, including the community called MRSA. We have the clindamycin resistance, that is MRSA 40%. We have occasional Visa and occasional linezolid resistance. So I think this is very, very important. And for that, I think what is needed is an infection control program, a rapid test to have an alternate diagnosis, whether they are dealing with a bacterial infection or not. We need to take care of the molecular test, and we have to use our, we should not use our antibiotic in the livestock. We have got our these modules, that is IAP, rational antibiotic therapy, our war module prepared by our own Dr. Vijay Yevle, Dr. Suhas Prabhu, Dr. Danya, and Dr. Tanu Singhal. I think you can go through it and you practice their antibiotic stewardship. As far as the TB is concerned, I think India contributes nearly 27%, the first in the country, in the world, to have the maximum number of the MDR TB. And let us see what COVID-19 has done. This said there is a striking 80% reduction in the TB notification, a huge one. So lots of cases have been not notified, means they're not getting the treatment. I think these are enough to lay a foundation for the MDR, XDR TB in the country. And as per the mathematical model, India will need to manage 2.32 lakhs more cases for every month of the lockdown, and India will see an excess of 11,600 cases of MDR for every month of the pandemic. I think the burden is huge, and we need to, we cannot stop here. We need to continue our Stop TB campaign, irrespective of the status of the pandemic. And now there is a dual challenge. We are in the modern era. There is a transition from the urban to rural area. The urban slums are swelling like anything because of the migration, and we have seen a very unfortunate convergence of the non-communicable disease and the communicable disease in a low and middle income country. And as the infection diseases are new emerging, some of them are prevented with the help of vaccine preventive disease, but the non-communicable diseases are going up and up, and this mainly includes our obesity, hypertension, diabetes, even maternal malnutrition predisposes our children to a childhood onset of the adult diseases and metabolic syndrome. And remember that when this infection occurs in this group of population, they are going to be more severe, they are going to be more complicated, and the mortality in this comorbid situation is very high as far as the infection is concerned. And let us not forget that some of the infection are the root cause of the cancer is concerned. I think this is the area we need to work. This is a new challenge that is upcoming, irrespective of the pandemic. That is HPV, cervical cancer. We have got the vaccine. We have got the hepatitis B and hepatitis C for the liver cancer. We have got the H. pylori for gastric cancer. We have got HH6 and 8 for the Kaposi virus, the Epstein virus for nasopharyngeal cancer, Burkitt lymphoma. We have the liver flukes for cholangiocarcinoma, and we've got the schistosomiasis as far as bladder carcinoma is concerned. Why I'm telling you that infection can cause cancer, and some of the infection are vaccine preventable, like hepatitis B. We have got our HPV. I think we can do a lot of justice to our nation, children of our children of our nation. And remember that COVID-19 can have its long-lasting effect. Yes, we have seen a chronic pulmonary fibrosis. We have now seen in a MIS-C and MIS-A patient a thrombosis and even coronary aneurysm. I think a long follow-up is required for these cases, and this challenge is straight ahead with us. So friends, if I enumerate my first talk, that is challenges, we are challenged with the various emerging reinfection. We are challenged with the ongoing pandemic. We are challenged with the post-COVID illnesses, and this antimicrobial resistance, MDR TB, and immunization deficiency are there to add fuel in the fire, including our non-communicable diseases. We have got a neglect of non-COVID illnesses. At the same time, we have got the vaccine hesitancy, and we have got the economic constraint, and we have got the irresponsible more behavior, and we have the virus which are known to have mutate. And so the challenges are very endless. I think sky is the limit, but friend, let us try to turn the risk and challenge into an opportunity. And history is the witness of this. We had a Black Death, but we found out that non-pharmaceutical countermeasures like hand hygiene, isolation, and quarantine are very important that we follow even today. We have got the Spanish flu. It has given birth to the epidemiology. The book of the epidemic started accomplished by 2025, but the foundation is laid in the 1920. As far as the smallpox is concerned, a great research for the humankind, a concept of variolation, it has given a birth to a smallpox vaccine. Now we have eradicated this smallpox, and now we are in the verge of eradicating the polio. As far as HIV is concerned, we have learned that the stigma, associated and disease will not help us in our control measures. So there's no stigma should be applied to any disease. It will help harm our control measure. We have got a SARS 2004, a core global action come into work for the first time, and the screening of the individuals was done at the airport for the first time. We have the pandemic of 2009, where the robust surveillance came into existence and prompt action have been implemented. And this COVID-19, I think, has shown a link between the human health and plenary health. Yes, friend, this plenary health is a new concept that is emerging. And it says that the emerging concept of this plenary health emphasizes the health of all the species, depend upon the health of the biodiversity and the whole system. Means we have to preserve the biodiversity. The emerging concept is that plenary health emphasizes the health of all the species, depend on the health, biodiversity, and the whole system. So we just as a human being cannot ignore the other elements of the biosphere. That is the concept of the plenary health that as we have taught that pandemic 19 is there. So where can be a way forward? Yes, friend. We need to say that every health issue is a global issue, global health issue, and not an individual issue. There need to be a system for the early declaration of the emerging microbe. There is a need for the very robust private-public partnership. And for that, we have got IAP of 33,000. We can take help of the IMA. We have got the ID chapter. We can take help of our nurses, paramedical staff, or even resident and the medical student. There should be a public awareness and public engagement. A mob behavior is very, very important. Everyone should behave to put an objection for the other member in the community. I think this public awareness and engagement is very, very important. There should be a equal resource access irrespective of the financial condition. I think there should be an equal resource access, and this we need to try to reach to the unreached. We need to test, track, treat, and vaccinate, and that should be the motto. I think this will prevent most of the emerging diseases to do this to go towards a disaster safe. Then there should be a very ready to implement robust plan, where there should be a surveillance as far as the human health is concerned. There is surveillance as far as the animal health is concerned. I think this should be there, and there is a therefore there are infrastructure investment, increased budget, and more health personnel required, and there is stewardship in the use of the various resources. Various guidelines are very. So we can do so many things as far as these emerging challenges of the new era is concerned. So I stop here saying that however secure and well-organized, regulated, civilized life may become, the bacteria, the protozoa, the viruses, the infected the lice, ticks, mosquito, bedbug always lurk in the shadow, ready to pounce when neglect, poverty, famine, or war lets down the defense. So friends, be careful, stay safe, stay healthy, and my sincere acknowledgement are due to IAP ID chapter, especially Agnes Popat, Heya, Dr. Bala Subramaniam, Dr. Vijay Yevle, Dr. Jaydeep Chaudhary, IAP Pune branch, my mentors, my teachers, Dr. Raju sir, Dr. Amdekar sir, Dr. Baldev Prajapati, Dr. Nitin sir, my colleagues, my little patient who has taught me, who has given me the opportunity to excel in the scale of medicine, my hospital staff, my parents, and of course, my lovely family members. I take this opportunity to introduce them. My wife, Dr. Sonal, my son, who is a gynecologist, my son, Dr. Asha, is a pediatric gastroenterologist. My daughter is a physiotherapist, Dr. Anil, and I've got a beautiful grandchildren, Kian and Krishiv, and my son-in-law, Dr. Harsh Patel. So thank you, friends. Thanks to Vankar for this wonderful honor. Thank you so much. Thank you so much.
Excellent presentation, Dr. Abhay. A new insight on the subject. I congratulate Dr. Abhay Shah. At the same time, I thank the orator committee for the selection of such a wonderful topic and such a wonderful orator too. Friends, if this would have been a physical conference, it would have been our proud privilege for me and Dr. Khea to felicitate Dr. Abhay Shah personally. However, I have managed to travel 200 plus kilometers to greet him along with my joint secretary, Dr. Chetan Trivedi, and my personal secretary, Dr. Swati Popat. We are at his place only, so let us honor him. Meanwhile, I reached the place where Dr. Abhay Shah is there. I would request Dr. Khea to express her feelings. Dr. Khea, please.
Yes, and it was just a mind-blowing, very comprehensive, very heart-touching oration. I think we, the oration committee of IPID chapter, our selection was absolutely correct, and no one better than Dr. Abhay Shah could deliver this. So I am missing this. Had it been a physical conference as we have planned in the Pedicon 2021, we are all planning to meet physically and to organize it in a very successful way. But anyway, IAP Pune had done a very great job, and of course, Dr. Abhay Shah. So we will now see something which has been possible just because of Dr. Popat, who took the trouble to travel for more than 200 kilometers. He started yesterday and reached Ahmedabad yesterday night. So, Dr. Popat, should we start? I think you are going to witness. So, congratulations, Dr. Abhay Shah, for an excellent, comprehensive oration. And thanks also goes to Dr. Chetan Trivedi and Mrs. Popat. I would have loved to be along with you.
And let us all wish happy birthday, Dr. Chetan Trivedi.
Oh, thank you.
Oh.
Thank you so much.
Congratulations, Abhay.
Congratulations, Abhay bhai.
Thank you.
Congratulations, Abhay. It was wonderful.
Thank you, sir. Thank you.
Really fantastic oration. Fantastic.
My special thanks to Dr. Yagnesh and Dr. Swati Ben. I think they gave me surprise yesterday night. They came from Rajkot and Chetan today morning. So it was a big surprise for me. And happy birthday, Dr. Chetan also. Happy birthday, Dr. Chetan.
Thank you, sir. Thank you so much.
Abhay bhai, you are lucky. Dr. Ambedkar sir is also here.
Yes. Actually, I used to keep the pic of Dr. Ambedkar in my chamber, and still I am having that.
Congratulations, Abhay bhai.
Thank you, sir. Thank you.
Thank you. Abhay bhai, congratulations.
Thank you. I think.
Congratulations, Dr. Abhay. Congrats.
I think.
Thank you.
Abhay, we are so proud of you. Heartiest congratulations.
Thank you, sir. Thank you. Your blessings are always with us.
Thank you, Dr. Sanjay. You can now proceed.
Thank you. Thank you once again, everybody. Thank you. Ambedkar sir, my namaskar, Ambedkar sir. Raju bhai.
All the best. I enjoyed your oration. It was wonderful. Thank you very much.
Thank you, sir. Thank you.
Sandesh, can you take over?
Yeah. Yes, I think you can proceed.
Sure.
After a wonderful oration ceremony, let's have with us our next session, which is coming up, Pulse of Wisdom session, which the topic for this is New Insights and Hope for the Future by our own renowned Dr. Ambedkar sir. The chairpersons here would be Dr. Nathu and Dr. Pramod Kulkarni sir. Dr. Nathu, President for Pune IAP, year 2021, and Dr. Pramod Kulkarni sir, Secretary for Pune IAP, year 2021. So I hand over to Dr. Nathu, who will introduce Dr. Ambedkar sir.
Thank you, Sandesh. So after a fantastic oration by Abhay Shah sir, we are on to the next very interesting and again much anticipated talk. I'm too small a person to introduce someone of the stature of Ambedkar sir. I don't think any of the pediatricians need any introduction to Dr. Ambedkar sir. We all know him as a great teacher for last 50 years almost. He has been the director of BJ Wadia Hospital. He has been associated with the Grand Medical College for long. He has also been visiting consultant at Bridge Candy and Jaslow. And as I said, this is more than sufficient because it will go on and on, and I won't be able to end. So I hand over the mic to Dr. Ambedkar sir for giving his thoughts on new insights, hope for the future. Ambedkar sir.
Thank you very much, the organizers, and in particular, Dr. Nathu and Pramod. I think when Pramod asked me to give this talk, and I realized that the theme of the conference was the known infections and newer insights. I realized that he was trying to remind us that even in known infections or known knowledge, there is a lot to learn even more, and therefore you continuously need new insights. And I recall earlier, having seen this title, the author talked about science from sight to insight. And look at the cover page of this book. One eye is open, the other eye is closed. The author wants to suggest that what you see with an open eye is just a superficial understanding. But that is only what the occipital cortex and the retina can see. But with a closed eye, an academic meditation, as if you need to use the entire cortex for the insights. And that's the difference between the sight and insight. And I love this page, which itself depicts what has been the principle of this book, Science from Sight to Insight. But when I started looking at insight, I thought often we are out of sight. Now, whatever little we know about infections or all other diseases, we know because of insights of some geniuses who came out with a deeper understanding. And I think that is what insight really means. Now, at my age, understanding is itself an overstatement. And deep understanding is far away. But I am aware that we have a lot of critical knowledge gaps. For a long, many years, I did not know that I did not know. It is only recently that I started knowing that I don't know. I thought this is the first step of insight, that I know today what I don't know. And to know correctly, we have to look at unexplained events which occur in day-to-day practice. And unless we make a good knowledge out of it and an experience base, but good observation, we cannot define a problem why these unexplained events do occur. And I think that is what is insight really. And for that, you need a lot of inspiration and of course ability to solve such problems, create new ideas. And I feel many of us, and of course myself, lag behind this kind of an insight into a problem. But we can certainly observe closely and define a problem that we could take it further so that somebody with a good insight plans strategies out of available choices and then gives us an action for benefit. But when it comes to action for benefit, I must remind every one of us that every researcher has a bias and he decides what he thinks is right and he goes on to prove the fact irrespective of whether it is right or not. And we have seen umpteen number of times, including the recent pandemic, that each new knowledge was only short-lived and very soon it was proved to be totally invalid. So this kind of a bias and a hurry to kind of put an action for benefit is what I think the human tendency is for finding the insight. And we need to be very sure that we have a right kind of action. But I must remind everyone that insight without action is worthless. Doing something new, but it does not translate into action. Possibly that new insight does not work in clinical practice. And we need to have such an insight into the problems that ends up with an action that was worth, that was beneficial ultimately to the welfare of the society. Over years, I thought what insight our genius forefathers gave to us. And we know today that disease is the result of tripartite interaction. On one side is the host. And what do we know about the host? We possibly know about his age and his name. We are not aware of his correct genetic makeup. We roughly know what nutrition he holds, but many micronutrients and many interaction between various factors, disease, drugs, genetics with nutrition is still not understood. And then we only know that the host is immunocompetent or immunodeficient, but we do not know still what is the inside in-depth understanding of immunology of this particular host against this particular infection. And that is what we are talking about. The result is we are not able to immunomodulate the way we want. And that is what is still lacking behind. And of course, we are aware of how comorbidities can make the situation worse, but we are not aware what is the mechanism of such comorbidities affecting the immune responses and ultimately the world. You can see one component of this tripartite interplay, the host, we know so little. Do we know enough about pathogen? Probably not. In our country, large number of times we even don't have an isolation of an organism. We do not know the number of organisms that are really multiplying. We have no idea about their correct virulence. And far from knowing many other things, we are not aware of the characteristics of this particular pathogen. Today we know how the COVID virus has a totally a different characteristic of highly transmissible and causing a lot many serious implications. But we are not aware of many such characteristics of a pathogen. And you can see how the second component of our tripartite interplay, we still lack a lot of knowledge and we need a lot of insights to decide really how we should go further on that. And the third component is the environment itself. By that we mean the epidemiological exposure, the immune status of the host, and the epidemiology would ultimately decide what kind of interplay these three can go about. And it's not only that the disease manifestation depend on these, but ultimately the progress and even the response to treatment depends on how good the host is able to mount a very balanced immunity. And unless the immune competent host understands how to correctly modulate a balanced immune response, we will not know how to manage that. These are all our ignorances. And unless we have a balanced immune response, we will not win the battle against the infection. And when we talk about antibiotics, we know very little about pharmacodynamics and pharmacokinetics. We have started knowing about drug resistance, and we are all aware broadly how in vitro and vivo resistance differs. But again, many complicated issues that ultimately work in this battle, we are totally unaware of, and we need a lot of insights into this problem. I'm sure tomorrow's prescription of antibiotics would take care of all these factors and give us a total different insight into how to treat a particular infection with a particular antibiotic. And gone would the days when you just give BD or TDS, because whether the drug acts the same way in the morning as against evening, the circadian rhythm of the body, many other issues before feeding, after feeding, all these we are very ignorant about it today. And I think that is where we possibly look at how every other systems of medicine have focused their attention on treatment. And it's worth learning from every other system what is the best in them and try to inculcate in the modern medicine or a Western medicine. I don't call our medicine as allopathy. Allo is different. We are modern medicine, Western modern medicine. And we look at the Ayurveda, it emphasized a lot on host-environment relation. And you can imagine it talks about how healing depends on the amalgamation of 5 elements of nature, Pancha Mahabhuta. They brought a concept that how environmental and host interaction ultimately would play an important role in the disease manifestations as well as the disease progress and the disease outcome. West had largely ignored such issues, and I thought this is what we started learning of late because we had a better insight of what other systems started doing. And you look at homeopathy, they claim to bring change in the host immune response. This was a concept in homeopathy that now today in Western medicine we are all aware of, and we know that it's the host immune response that ultimately decides. We got this insight from these other systems of medicine, while earlier Western medicine concentrated on treating disease with a specific drug. Now, newer insights into Western medicine have started focusing attention on many other issues that other systems always practice. Today we know we give large dose of steroid, single dose in the morning, because we have understood the circadian rhythm and how to minimize the side effects of a drug. We have learned how to give some drugs on empty stomach while some other drugs on a full stomach. And I think these are the concepts of other systems of medicine that we have had an insight to take into our system. That's why our system has an advantage of evidence-based medicine, which many other systems may not have. But if we get the insights out of other systems and practice good part of it into our system, I feel we will have a lot of insight into our immune processes, and we will know how to immunomodulate them. Today, we only know that we could suppress immune response, or to small extent, we could enhance immune response. I don't think that alone will work, because when we suppress immune response to kind of control the hyper responsiveness towards a particular disease, we are also making this susceptible to other infections. And I think we don't want that kind of general immune suppression, nor we want an immune enhancement by giving any factors, but we want immunomodulation. We want a balance between the two wings of immune responses. And I think unless we understand the concept of immune modulation, mere immunostimulation or an immunosuppression will never work in large number of cases. Well, it works sometimes, but we are never sure whether it will work or not. And that for that, as I said, the Ayurvedic concept of circadian rhythm and relation to food, etc., I think need to be inculcated into our Western medicine and our insight. I'm sure that would make a lot of difference ultimately in terms of giving benefit to our Western medicine benefit. I think we have observed many unexplained events in the past as well. We learned hexagonal reaction in syphilis, and we knew that it was due to toxin production because of bacteriolysis. I recall one of the homeopaths telling me that he finds his drug to be effective only if there is a flare of a disease to begin with. I would not trust him. And Herxheimer reaction exactly did that. The disease flared up and then the disease settled down. But there was the risk of a flare up of disease as well. We in Western medicine understood why this kind of Herxheimer reaction occurred, and we would start taking care of it. And that's what we did in neurocystic courses. When we gave albendazole, there was suddenly an edema developing around the lesion and even an encephalopathy and a flurry of convulsion. And we realized that this was due to, again, our drug causing a little flare up, and we started using steroids before starting albendazole. We have learned from these insights, but when we looked at a streptococcal infection, a simple streptococcal infection, we understand that many of us may be asymptomatic or very mildly symptomatic. Many of us may get cured even without an antibiotic. Well, we will prescribe an antibiotic with cure. But even without treatment before antibiotic era, these infections did get well. But some of us may be left behind with a carrier state, and few unfortunate ones develop complications, not only within few weeks like a rheumatic fever or a glomerulonephritis, but even after a long time, a neuropsychiatric illness like a pandas. Well, we have understood all this spectrum of events occur, but are we able to find out which host will go which way? Unless we have that insight, we will not be able to predict and even possibly avoid complications. And these are our shortcomings, even in many simple observed explained events. And same is about tuberculosis, that we had a varied presentation. Gone are the days when a TB comes with low-grade evening drive of fever. Today, TB will come without fever, with any kind of fever, with high acute onset, high fever. And we have understood how is the mechanism of, say, Mycobacterium tuberculosis interacts in a different way in different hosts. And today we know that a 10-year-old, very healthy child, immunocompetent, presents with an acute onset of high fever and severe breathlessness within 12 hours of onset of a disease, and develops a large pleural effusion all within 24 hours, only due to Mycobacterium tuberculosis and not any other acute bacterial infection. Imagine all this we came to know only by observation, but we haven't understood which host will go which way. And I think we need the insight for knowing that if I knew somebody is going to develop an acute onset high fever, I would consider that high onset acute fever also be due to tuberculosis, which is really a subacute or a chronic infection. All this needs a lot of insight. And finally, we know in tuberculosis that so-called cure is not really that the last bacterium is out of your body. That last bacterium is still inside, and it may have a chance reinfection or reactivation. And I think we have not understood how to get rid of that last bacterium, and we still call it a cure. These are the observed problems that we have. And I recall years ago, decades ago, on the outskirts of Mumbai in Dombivli, there was a typhoid kind of a local epidemic. And during that epidemic, we realized how varied spectrum of events take place even in typhoid. I recall a doctor couple coming with their child of 6-7 days of fever. And I said, this looks like an enteric fever, but because they had not started any antibiotic, I told them to send a blood culture and start chloramphenicol. Those days, we used to use chloramphenicol for typhoid fever. They went home, but by the time he organized the blood culture, the fever had disappeared. And he sent a blood culture, but did not start chloramphenicol. 2 days later, when the final blood culture report came, it was Salmonella typhi, but his child had remained afebrile for 48 hours. And he phoned me to say, should he start with chloramphenicol now that the fever has disappeared? Well, I recall that even pre-antibiotic era, some of them, not many of them, some of them got well even without antibiotic. I told him, let's wait for a day or two and see how he progresses. Oh, he came back with a vengeance and high fever again, and we had to start chloramphenicol at that time. Fool us about getting febrile, but again come with vengeance. And then we saw all kinds of complications in typhoid, which mostly have not been included in the classical text. And I recall having seen a pericardial effusion coming after typhoid, and the pediatrician who asked me to see this said whether this could be tuberculosis. And I said, let's wait on, because he's comfortable and we will only follow him clinically. And after some time, without steroid, the effusion started disappearing. Same thing, we saw myelitis following typhoid. These were not due to salmonella infections themselves, but these were immune responses. And what I meant was, when there was a large number of cases, we start seeing all kinds of rare events. And these rare events give us the opportunity to know more insight into that. We look at the old practices, even Hippocrates has mentioned that the disequilibrium of body fluids is what is the ultimate responsible. And I recall in 50s, it was clearly observed that if ICU patients were highly febrile, they came out of their condition, but they did not have fever, they succumbed. At that time, the object of physician even trying to induce fever. Of course, that never worked because we did not know of this situation. Today we are a little better of that. During my house post in early 60s, I recall Dr. Udani showing us a literature where he said there is something like a transfer factor. And if you pick up a child who is responding well and take his plasma and put it into somebody who is not responding well to similar disease, there seems to be a benefit, and it was called as a transfer factor. Those days we did not know much about immunology and immunity. And I recall having practiced, you used to have a row of TB meningitis in our ward, and many of them would not improve finally. Some of them might, of course, be left with a lot of damage, but many also would be fatal. And we tried on few patients to removing blood from a recovering patient and trying to infuse into a patient who was not recovering. I don't think it happened anyway beneficial. But now back, the full insight was getting developed and we called it a transfer factor. And would you believe that one of my teachers used to give vitamin D to all chronic disorders? And I wonder why. And he said, I have observed that it helps. Those days we never knew vitamin D had an immune also benefit, and of course to a very small limit. But he was very fond of considering vitamin D, not knowing that it would have some immunological reaction. I recall the days when preterms were not easy to survive, and there were trials to give toxoid to them to stimulate their immune response. The point I'm making is, those days there were insights, though they did not come out to be into action because they could not be proved for that. Of course, we are aware that we use a single dose steroid in a flu meningitis, H flu meningitis, before even giving an antibiotic, so that the ototoxicity and other side effects of our antibiotic working on an organism do not occur. And therefore, we understood it's the host who decides the pathology. And we need to know more about the vagaries of immune system responses. We must know about gene-nutrient interaction, of which we know very little. we must know about the gene environmental interaction, and finally even gene to gene interaction. One gene can compensate for the bad effects of another gene, or may even promote the bad effects of another gene. So it's not enough to pick up a genetic makeup, but we need to know a lot of such genetic diversity with a very broad array of immune and inflammatory phenotypes. And today we know asthma has a lot many phenotypes, and we know that every infection and every disease has a lot of phenotypes. We do not know clearly what is the mechanism of evolution of this phenotype, and that's where we one of the insights for future. We have to understand the pathogenesis. And COVID is the example that thinking that virus is causing pneumonia. Today we know that there is a pulmonary vasculopathy which is coming in the way. And today, if somebody is mildly tachypnic and is hypoxic, we might even do a D-dimer to find out whether he is going into any thrombotic issues. So we have understood some, but so much to know more and more. The very insights will help us to consider a very potential target therapy. And today, possible vasculopathy in a possibility only because we understood some areas of pathogenesis and we know how to target them. This will make us practice a personalized medicine. I recall my olden days, my father used to be a family physician and he never prescribed a cough syrup or whatever syrup. He concocted a mixture of something. And I thought that was a personalized medicine practice. Thereafter, we totally diverted into a generalized practice. We are coming back to personalized medicine practice, but with a lot of evidence and a lot of understanding. Imagine tomorrow we will know how to stratify the risk involved. We could have an insight to say this infection, this disease in this host is likely to run a higher risk. And we start looking at what kind of risk this host is likely to mount, and we could possibly even prevent them. The insights could tell us which drug, and partly this has happened in cancer chemotherapy, that you select a base drug that would, in this particular genetic makeup, would act the best when you have 2-3 drugs as an alternative, and we can choose a drug in a better way. Well, it will help a lot in vaccine production. For example, the dengue viral vaccine is not yet evolved. What is the reason? We all know that the first episode of dengue viral is almost benign. But when the second episode comes with another strain, oh, it causes a lot of complications. So we need a vaccine which takes care of all 4 strains. Now that is a challenge. But we have now an insight where we need a vaccine that takes care of all the strains so that there would not be a complication occurring with a reinfection with another strain. These are all possible with insight. Finally, I thought this is fine, but I told you to begin with, most of us are out of sight when we talk about insight. So my last question is, can I, as a insight-less person, am insight, can I help the process of developing insight? Yes, I think I can. Even if I observe what is going on differently than what I know, I think it becomes a starting point for those geniuses who have an insight, who can deeply think, who can find out something more. And tomorrow, that's only the hope. So friends, each one can contribute to the betterment of better new insights for the future. We'll be happy to be a part of small help, a small help in ultimate benefit. And I'm sure each one of us has definitely that obligation to observe carefully, to note down carefully, and to put up a problem to those who are geniuses for them to solve. You and me can define a problem, others can solve. I hope this was what my perspective has been, that we have to have insight and insights for future for a better action. Once again, thank you very much to organizers and Pramod in particular to have given a thought of this topic, that known problems and newer insights. What does it mean? We know so little. And so many of the best of the scientists have clearly said that as they started knowing more and more, they realized how less and less they knew. What about mere small creatures like us? We lack a lot of understanding, but we can also promote the newer insight. Thank you very much for this patient hearing. And once again, thank you very much for all this.
Thank you very much, sir. So that's the reason everybody craves to listen to sir. So once you listen to Guru, like Dr. Ambedkar sir, you come to know what you presume to be your insight is not understanding, not knowing, it's just a information. And that's really the force giving us the humility and humbleness, sir. Thank you very much, sir. Thank you very much.
Thank you. Thank you.
That was a good pulse for us. Yeah. Those were the pearls of wisdom from Dr. Ambedkar, sir. Thank you very much, sir, for your insights. Now we move on to next session, that is a panel discussion for infection and or immunity, that is infection mimics. For this, we have moderators Dr. Jayant Joshi, sir, Dr. Bhaskar Shinoy, sir, and panelists, we have Dr. Kiya Ghosh, madam, Dr. Deepa Firke, madam, Dr. Vijay Vishwanathan. Something about them, a little in brief. Yeah. Dr. Vijay Vishwanathan, who is a consultant pediatric rheumatologist at Jupiter Hospital, Thane. Special achievements awards are, he was a secretary at Pediatric Rheumatology Society of India. He has a number of publications on his name and 8 chapters in his textbooks. Dr. Deepa Firke, who is an associate professor at Government Medical College, Kolhapur. Her area of interest is pediatric infectious disease. Special achievements for her is she's a secretary Kolhapur Academy of Pediatrics in the year 2015-16, president Kolhapur Academy of Pediatrics 1920, also an EB member for Master IAP in the year 2020 and 2021. Dr. Kiya Ghosh, she is associate professor and NICU in charge of Institute of Child Health in Kolkata. Areas of interest for her is neonatology, infectious disease, and vaccinology. Special achievements: she was a secretary of ID chapter 20. She is presently a secretary of ID chapter for the present year 2021. She was a past secretary of West Bengal Academy of Pediatrics. Awards: she had received a Provincial Pioneer Award, also an Indian Gyani Award by IAP, and Bhaskar Mani Kalpana Award by West Bengal Association of Pediatrics. Moderators Dr. Bhaskar Shinoy, he is head of Department of Pediatrics and Chief Pediatric Infectious Disease Division of Manipal Hospital in Bangalore. Also an adjunct professor of pediatrics at Manipal University. His areas of interest again is infectious disease, vaccinology, and Kawasaki's disease. He is a managing editor in Pediatric Infectious Disease Journal, editor-in-chief of Carnatic Pediatric Journal. He is an honorary IMA professor of pediatrics. And lastly, Dr. Jayant Joshi, sir, who is a senior consultant pediatrician at Dinanath Mangeshkar Hospital and Sahyadri Hospital, Pune. His areas of interest is again infectious disease, pulmonology, and vaccinology, neonatology as well. He was EB member for Central IAP Maharashtra for the year 2016, 18, 20. Vice chairperson of IAP ID chapter presently 20 and 2021. Vice president of IAP respiratory chapter in the year 2021 and 22. He is a national trainer for various IAP modules and a number of publications and book contributions on his name. So over to the next session to the moderators, Dr. Joshi and Dr. Shinoy, sir. Take over.
Hello. Share the screen, Jayant.
Yeah. So, good afternoon, everyone. Am I audible?
Yes.
Yes, sir.
Okay.
Yes, sir.
So, after a very thought-provoking and a always inspiring lecture from Dr. Ambedkar sir, we are at a very important topic. Now, all of you who have connected from morning to listen to this fantastic program, I must give compliments to Dr. Pramod and Dr. Sanjay for making it a very comprehensive and a very well thought of scientific program. And in the morning, Dr. Pramod interviewed Dr. Uh, Raju Khupchandani, who actually gave a little bit of prelude to our panel discussion. And if you probably would have linked in, you must have heard for his very comprehensive and a very good talk. And he mentioned about this topic, which is infections or immunity. Now, more often than not, when we deal with fever in our clinical practice, at the back of our mind, the first priority we think about is infection. However, there are so many situations wherein a fever, when it does not respond to a conventional form of treatment, or when your regular diagnostic modalities or the workup does not really help you, one has to keep other possibilities in mind. Now, for the benefit of those who probably missed out in the morning session, Dr. Khupchandani highlighted on 4 possible mechanisms where the immunity could play in picture. First, of course, was an immunodeficiency. Second was an immunomodulatory type of picture or a hyper-inflammatory state. Second was, and the last was most important, being the critical modulation of the immune system stage. So all these 4 were considered and they were taken as a part of this particular thing. So they become the backbone of our discussion today. And I think in the due course of time, I am privileged to be with Dr. Bhaskar Shonai, who is a very respected and a reputed figure in the name of infectious diseases. He's been a most efficient editor of the Pediatric Infectious Disease Journal, which all of you are receiving, and we know how much his contributions are. It is a privilege to be with Dr. Khea also, who is a very dynamic secretary of the ID chapter. And it's my pleasure to welcome and greet Dr. Deepa Firke. It's been a long time. She has been kind to invite me often to Kolhapur for in various scientific deliberations. And with these experts, we are now moving ahead with this particular panel discussion. Now, in this,
Dr. Vijay Vishwanathan.
Yeah, I'm sorry, I forgot to mention Dr. Vijay, a very dear friend and a very reputed rheumatologist who not only practices in Navi Mumbai, but I think he comes to Pune also often. So welcome, Dr. Vijay. And with this, I think we'll proceed further. Yeah. So coming to the first case, it's an 8-year-old girl. These are real cases. This is an 8-year-old girl, fever for 3 days. She had vomiting, which was significant. The fever was high grade, intermittent, with chills. She had vomiting 3 to 4 times at the height of fever, associated with abdominal pain and dysuria. She had a history of constipation. She was incidentally constipated for 2 days. She was unable to retain oral fluids, hence she was admitted. On arrival in the casualty, she was febrile, she had a toxic look, the pulse was 120, BP was okay, saturation was normal, the peripherals were well filled, she was conscious, alert. On abdominal examination, it was soft, there was no organomegaly, no localization. At this point of time, what would one thing, may I start with Dr. Kea, please?
Yes.
Yeah.
So as you can see, it's an 8-year-old girl with 3 days history of fever, vomiting, and which is associated with abdominal pain and dysuria. So whenever you see a fever, you always try to take the history so that whether it is focusing on something. So it has no respiratory tract component. It is mainly with vomiting, pain abdominal, vomits, abdominal pain, and dysuria. So it's an abdominal infection. No? Now, whenever there is dysuria associated with constipation, we have to think of UTI. But in situations like in monsoon, though it's mentioned here, it's April 21, in this type of fever with vomiting, abdominal pain, we have to think of common infections like malaria, dengue, of course, UTI, as I mentioned, even simple acute hepatitis or acute gastritis. Because then we have to go also for the common surgical cause, because an 8-year-old girl, often they come with this type of features and they come with acute appendicitis, maybe acute cholecystitis and so on. So, and basically the baby was also a little tachycardic, tachycardia was there, pulse was 128, a little toxic loop. So we have to see, we have to examine the abdominal examinations, whether any associated findings like rashes, because
So-
it can be dengue. So we have to keep in
Very
mind
well summed up, Dr. Khea. I think she has given us a very clear insight of one would possibly think in an OPD when you see a child for the first time like this. Dr. Bhaskar sir, next slide, please. So obviously she was admitted. She was given IV fluids, antibiotics. The lab was sent. The reports, as you see, hemoglobin was 11.5, TLC was 13,500. There was the counts differential were normal, platelets were normal, malarial parasite was negative. Urine routine showed trace of albumin, pus cells 50 to 20, no RBCs, no cast. Incidentally, the nitrites were positive. USG abdomen was normal. CRP was 25, dengue serology was negative. Urine culture was sent, and as we do everywhere, empirical antibiotics were started.
Dr. Jain, I just want one thing, because you mentioned 21 April. With this scenario, you have to keep COVID also in mind.
No, I'm coming to that, please.
Yeah.
Okay, next slide, please. Dr. Bhaskar, next slide, please.
1 minute.
Okay, so day 3, she was clinically little better. There were no vomits, vital stable. The urine culture on day 3 grew E. coli, which was significant colony 10⁵, sensitive to standard cefotaxime, ceftriaxone. However, the fever spikes continued. On day 3, generalized rash appeared. It was non-itchy, erythematous, poor oral intake. Interfebrile status was a little dull. We got a urine routine just for cross confirmation. The pus cells showed 3 to 4. So clinic, the lab parameter wise also there was a recovery in terms of urinary infection. So what now one can think of, Dr. Khea?
So as we were thinking, and maybe the physician.
You are muted, Khea.
Yes, sorry. So as we were thinking, and maybe the physician was thinking in the same line, so the person has investigated in such line, and as you can see, there is a clearly a E. coli. I think it's a significant, means you mean 10 to the power 5, which was sensitive. So definitely we will start, when you are getting a focus, you are getting a microbiological confirmation of something, and there was an associated clinical symptom, dysuria, vomiting, abdominal pain. So in first go, we will definitely think this is an UTI, and we will start with the antibiotic. But again, the fever continued in spite of a good antibiotic and sensitive antibiotic. And when there is general rash appearance, you have to rethink your diagnosis. So most likely our diagnosis may be an associated finding, but it is associated with something, because general rash, appearance of rash or fever continue can lead in UTI. It can be only if there is some complications of UTI, but as you said, the ultrasound was normal, so we are not thinking in that way. So when there is general rash along with a continuous fever for more than 6 days, so we have to think of, as you were mentioning, Dr. Kupchandani in the morning session said, what are the conditions? Those are actually immunodeficiency, autoinflammatory, autoimmunity, and allergic disorders. So all this, out of this, autoinflammation always will present with prolonged fever, rash, and eye changes. So I would like to ask whether there were any eye changes, or if we are thinking of some autoimmune or immunodeficiency disorder, we have to take past history, whether there were repeated history of fever or some other infections. Or coming to April 21 scenario, you have to think also that whether there was any past history of this baby suffering from any fever, or any household contact suffering from any fever. They may not be tested, but whether they had any fever or not.
I'll just interrupt here.
Sorry.
Just to give you a brief thing, nowadays it is mandatory in the tertiary care hospitals. In at least April, it was mandatory that you get an antigen test done. So this child was tested for COVID-19 antigen, which was negative before admission. So this is just to give you a filler. And as you rightly pointed out, your thinking has been perfect. And when you suspect with a good antibiotic cover, the fever still continuing besides the reasonable duration of time. Dr. Bhaskar sir, next slide, please. So again, we revisited history. She has had no history of UTI in the past, no hospitalization. History of COVID-19 in grandparents 1 month ago. They were home isolated. They recovered uneventfully. All other family members were tested negative, but the children in the family were not tested. Now, any clue, Dr. Khea?
So as you can see here, the child was not tested at that time. So
Yeah.
you always know many of the children go asymptomatic. So it may be that here at that time, the child had a COVID infection, which was not tested, and the child was asymptomatic. So whenever you have a very close household contact with a positive COVID history and with a fever, with a rash, with an abdominal findings like acute gastrointestinal problems, you must think of whether it's a missy, because then you have to you have to see whether there are markers like high ESR, CRP, and you should investigate accordingly.
Okay.
So, and of course, you have to see. You said in your previous slide, the child was looking a little bit dull with
yes.
poor oral intake. So,
Yes.
when the child looks a little bit dull, we often think of the baby might going into some sort of hypotension or hypoxia. So I think we should have to have a very critical note of this. A child looking dull, you have to evaluate the child, whether there is any hypotension or something like that. And you have to send investigation, at least basic CBC, CRP, ESR, you have to repeat and see whether they are very high or something. And then you can go for the second tier.
Yeah. So we did that. Next slide, please, Dr. Bhaskar. So we sent the repeat labs. The HB was 9.8. The total count was increased. There was a leukocytosis. Platelet counts had dropped down. CRP was 116. RFT, LFTs were normal. Prothrombin time was 21/16. INR was 1.1. D dimer was 1500. Procalcitonin was raised. COVID-19 IgG positive. The antibody we had sent, it came positive. Pro-BNP was raised. 2D echo showed myocardial dysfunction. However, the coronaries are normal. Diagnosis was, of course, as Dr. Khea rightly said, it was MISC post-COVID-19. She shifted to PICU, treated with IVIG, methylprednisolone, Clexane, and other supportive treatment. Fever settled in 48 hours. She gradually recovered over 1 week and discharged on oral aspirin and steroids. So, next slide, please. So, what are the learning points from this case? A persistent fever despite correct antibiotic given over a reasonable duration in a culture-proven UTI should raise an alarm in your mind. Asymptomatic COVID infection was never considered a possibility. The child was not tested in the beginning. That was a time when actually the testing was getting difficult. There were difficulties in getting appointments. So there was a tendency on the part of the clinicians to just go, because the second wave had such a bad infectivity that almost all family members were affected. So it was assumed that they probably were affected as well. Appearance of new symptoms like rash and discoloration took a little while to appear. As always it happens, as it's an inflammatory phenomena. Now, can you please highlight a little bit about MISC, Dr. Khea, in short testing?
So basically, to diagnose MISC, all of you know, we have IAP guidelines. So basically for this case, yes, you can hear?
No, we are all familiar with the protocol. I think what we need to do is just to be aware about how to go about it.
Yes,
and
yes.
The antenna raised for this particular thing.
So anyone who comes with a fever nowadays, anyone who comes with fever, and if there is conjunctival injection, especially maybe this child didn't have that, but whatever we are seeing in our institute, the people are coming with fever, abdominal pain, and conjunctival injection, and many of them are turning to be messy. So you have to keep a high alert if you see rashes, conjunctival injection, and a fever, and the child is looking unwell. So that should raise, and of course you can see whether there are GI system involved, cardiac involvement, and find out. So you have to have a very high suspicion for this, and a very less threshold to investigate for MISC. And truly speaking, in our ward, we are often getting this type of cases coming only with high fever, high CRP, high ESR. Procalcitonin is not done in the first go. So we are getting cases like this with some rashes, some with erythemal eye conjunctival injection, and then within a day or two they are collapsing. So and getting admitted in the PICU. So we have to have a very high alarm, and of course you have to be very, very sure that you don't miss out the other common infections like the bacterial sepsis. Like this was a case of UTI. It could have gone to an urosepsis with some complication. You should not miss out that. And staphylococcal and streptococcal syndromes, shock syndromes, and of course you have similar type of features like Kawasaki disease also. I think we will take another case for that. So we should not miss that. But of course, as it has been said, that no other obvious microbial causes of inflammation or any other autoinflammation should be excluded before diagnosing it to be MIS-C. And if you have obviously the facilities for doing the antigen and the antibody, you do it in the first go.
Thank you so much.
I have a question. So in this case, you think it is only MIS-C, or how will you explain the UTI, the culture positivity? Do you think it is two things have occurred in the same patient, or these are different things?
So I think Dr. Jain can say it better, but I think in a MIS-C season, after an infection, your body is overreacting with an inflammatory response. Okay, that doesn't mean you cannot have an infection along with it. Okay, so if it was a significant UTI, I hope the urine was cultured in a proper way. We have to take it.
No, it was done in a proper way.
Like in Kawasaki, we get in a sterile pyuria.
That is sterile pyuria. Here it is a culture positive.
Yes, culture positive.
Yes.
Yeah.
Culture proven asepsis.
One more question I have.
Yes, sir.
See, the D dimers may be elevated in any inflammation for that matter, any infection.
We should not chase.
Now we are talking about more of D dimers. And before, whether with the severe infection, we never tested D dimers. So how do you take it? Because people are more looking at D dimer and trying to chase the D dimer. What is your message?
Sir, what we have seen in my little practice and from our hospital, we should not chase the D dimer. D dimer, children are not that much thrombotic. Children, prothrombotic conditions, okay, there may be, but not like the adults. So we should not chase D dimers in children. And often in a stable baby, if the baby is stable, not that sick, you wait. The D-dimer, it comes down within 48 hours. Sir, we have seen many cases like that. So I don't think we should be very particular about D-dimer.
And
so it's my opinion.
Just if I may add to what Dr. Khea is saying, now when it comes to a diagnosis of MIS-C, I think always follow a protocol. There are very specific, correct criteria laid down for diagnosis. So only chasing one parameter like a D-dimer or only a procalcitonin or a CRP, it's always a serial thing. And I think more often than not, the clinical plus lab parameters will give you the clue. Thank you so much. I have not touched upon some parts of the investigation which you use in MIC. And now I invite Dr. Bhaskar to come with the second case. I think he will take it up from here. Thank you so much.
Thank you. This is a 3-year-old boy, fever of 103 degrees, shown to a pediatrician on day 3. And he was given antibiotics, amoxiclav. He developed a rash on the trunk and eye redness on the day 4. And this was the picture, as you have been telling. So he consulted a second pediatrician and a dermatologist, because the first pediatrician told you consult a dermatologist. And they opined that it could be drug reaction because he was on amoxicillin. And he changed it to oral cephalexin. On day 6, he continued to have fever with a hemoglobin of 11 and a total count of 12,000, platelet count of 2.6, ESR 70, CRP 50. He was admitted and started on ceftriaxone and amikacin, as is the usual practice. And he continued to have fever even on day 9. He developed swelling on the feet and hands. And this pediatrician, he did many more tests to rule out other causes, rickettsia, dengue, Vidal, urine infection. Urine test was done, which showed 15 pus cells per high power field, but the culture was sterile. And he thought it is provisionally UTI bar sepsis. He upgraded the antibiotics to vancomycin. And 12th day, he was admitted to our unit. Now, I would like to ask Dr. Deepa, how do you proceed with such a case? In your unit, this kind of child comes. How will you tackle this problem?
So at first, this child has come with a fever initially only. So first 24 to 48 hours, any case of fever, if there is no localization, there is no role of antibiotic at all. What we advise is just plain paracetamol and just tell our parents to look for the pattern of the fever, how is the rhythm, how is the interfebrile period. So because most of the times after 48 hours, there will be either a localization or some associated symptom that may come up and that may give a clue towards the diagnosis. So yes, here they have started with an antibiotic within 48 hours, which is definitely not advisable. After that, this child has developed a rash. So there are many differentials for a child at this age for having a fever with rash, maybe viral exanthems, maybe dengue or rickettsial fevers, leptospira. There are many differences for it. So the rash, how it has appeared, the pattern of the rash is very much important to know what we are considering. So again, here there's no role of antibiotic, just going for an antibiotic. We need to know the differentials what we are dealing with, and accordingly we can go for the investigations. The CBC that has been done at a day 6 now, that there's a fever is persisting and there's a rash. So as already has been described by Chandani sir, where it has not been responding, and here a lot of antibiotics have been already been given to this child and developing a rash. Whenever a child is not responding, we need to think of either we need to revisit the history and the examination, whether we are right with the diagnosis, we are right with the bug that we are dealing with, whether the choice of the drug is good, the dose that we are giving, or is there any complication associated with the diagnosis. Looking at the CBC over here, we can see there is a leukocytosis with neutrophilia, and yes, the inflammatory markers are raised. So yes, I would definitely not consider this now at present as an infection, but still with a persistent fever, we would go for investigations as suggested, like we may go for Vidal and dengue fever here. Dengue, by day 6, the fever has to come down. But looking at the CBC picture, I would definitely say, and the urine examination showing a pyuria with a sterile culture, that is a sterile pyuria. My diagnosis most probably may be probably autoinflammatory disorder or Kawasaki disease like thing, rather than a
very nicely told. Thank you, Dr. Deepa. You have highlighted one important point, misuse of antibiotic, which has been going on, and multiple antibiotics without diagnosis, without proving they have given. And this is what is going on. And that point you have aptly highlighted. And now it is time that we should move forward, that when you don't have a response to antibiotic, or when you don't have any other things coming out of your investigations, probably you have to go ahead, and you have to keep in mind some of the other important clinical pictures, and the clinical examination, as you have rightly pointed out, is very important. This child has rash, this child has swelling of the peripheries. Definitely we need to look beyond that. So this is a child who has presented at 12 days with 12 days of fever, no response of antibiotic, has high CRP and inflammatory markers, eye redness is there, rashes are there, and swelling is there. What more you need? The diagnosis is looking at you, laughing at you. So you have already told the course of the child and the usage of antibiotics. Yes. Probable diagnosis also, you have inflammatory thing we have already told. So this is a child who has provisional diagnosis of Kawasaki disease. So does the child satisfy the diagnostic criteria of Kawasaki disease in this child? Because if you look at the various diagnostic criteria, do you think this child fits into that criteria?
Yeah, this child does have a fever more than 5 days. And this child does have a non-exudative conjunctivitis. There's a swelling of dorsum of feet. There's a rash over here. I'm not sure about whether there is any oral involvement, and I don't know whether he does have a cervical lymphadenopathy.
No.
Okay, so if he's just satisfying the 3 criteria out of 5, I would say this is an incomplete Kawasaki. But still, we cannot just rule it. We need to go for an echo to see whether there are any changes in the coronary arteries in this.
Dr. Vishwanath.
Sir, if there is fever and more than 7 days fever and 3 criteria are met, then we can go for the ESR CRP. If ESR CRP is high, as in this case, then either we can do echo or we can have some lab parameters. If 3 of them are positive, we can take it as a Kawasaki. So there is an algorithm of suspected Kawasaki. We can go along with it. Because
yes, it is a clinical plus a lab parameter. You did not have. That's what I was going to ask Dr. Vijay. See, Dr. Vijay, here all manifestations were not there at the same time. Do you think, how do you take it? Like, what is your comment on that?
Thank you, Dr. Bhaskar, for the question. Am I audible?
Yes, sir. Yes, sir.
So this is a perfect example of keeping a watch on evolution of symptoms, like Dr. Ambedkar said in his lecture. And this child has nicely evolved or is still in the process of evolution into a KD. So like Deepa said, this fits into the definition of incomplete Kawasaki from what has been shown to us so far. And as Dr. Kea was pointing towards, you would want a bit more evidence, if not an echo, at least some lab clues. So when you're stuck with this situation, your algorithm typically will start with a high ESR and a CRP, which this child has already ticked. Now, the other investigations, if this child has anemia for age, neutrophilic leukocytosis for age, thrombocytosis, a low albumin is often a marker of acute inflammation, a high transaminitis, and a sterile pyuria. Out of these 6, if the child is fulfilling more than 3 at least with a positive echo, then I'm justified in treating this as an incomplete Kawasaki disease. So the first thing I will do is do the blood test again, because as we all know, we have entered the second week of illness, and that typically is the time when this child will start having the leukocytosis, thrombocytosis, and the very high ESR consistent with increasing fibrinogen levels. So
thank you, Vijay. You have brought out a very nice point that it is an evolving disease. It is like a blind man touching the elephant in the first few days. When you say fever, you think it is viral, then you think it is a UTI, then you think it is a viral exanthema, then you think it is it depends on, we also have gone through such a state. So you have nicely brought out these issues. So Kea, do you think this child has a UTI?
Sir, in contrast to the previous case, what we can see here is a pyuria. There is no, culture doesn't show. That doesn't mean always the culture will be positive.
Can you tell me some conditions? Yeah.
In Kawasaki's disease, you have sterile pyuria. You have sterile pyuria due to urethritis, and it's a known fact. And often it is misdiagnosed as UTI because initially they will present with fever, high CRP, and so clinically they will not have dysuria, but they will have a pyuria.
Yeah, this is one of the things which Kawasaki is misdiagnosed. Dr. Vijay, this child, how will you treat? Now this child has come to you, and we have given a reference rather to you, and how you manage this?
So once the child gets referred to me at this stage, we are reasonably sure that the cultures are sterile and we are not dealing with an infection, but more of an inflammatory complication. In the current era, I might just throw in a COVID antibody in the scenario to just rule out a possibility of a MIC with a KD phenotype. Otherwise, 2 gram per kg of IVIG over 12 to 16 hours is the usual protocol. And aspirin is a bit debatable, but we are gradually going away from aspirin. But if at all I use aspirin, we use a lower dose, so 30 to 50 for about a couple of days since afebrile, and then switch over to the low dose aspirin. And we will give aspirin till at least we document an echocardiographic normalcy of the coronary artery lesions.
Yeah. So now going back, Vijay.
Can I just ask? Dr. Yeah. So Dr. Vijay, I have a question for you. Now, with the present COVID pandemic, we are seeing a lot of MISC. So can you give us some clues by which one can distinguish between the MISC and a KD? There could be a variant, as you rightly said, you can have a KD with MISC, but then can there be distinguishing feature between these two?
So my understanding is that till the end of the pandemic, any kid who looks like Kawasaki with evidence to suggest a COVID epidemiology, so whether it's a PCR or an antigen or an antibody or a contact, you will still call this child as an MISC with a Kawasaki disease phenotype, and most of them will be incomplete or atypical. But a child who comes with, like this kid, with no evidence of any of the 4 linked to COVID, you may err on the side of caution. So I have seen a kid with exclusive 9-month-old with extreme irritability, no contact, rash, and only a BCG that lit up. And it was one of the few cases which most of the kids are testing seropositive these days. But this kid was a very virgin Kawasaki-like presentation and got better only with IVIG without the need to give steroids. The issue is most of the MISC kids will probably end up getting both IVIG and steroids as per most of the guidelines. But if you want grossly to understand, the KD kids are usually the younger ones. Still, it behaves the 1 to 5-year-olds, whereas the MIC kids are the older or the adolescent, pre-teenage kids. Kawasaki looks like Kawasaki, whereas the coronavirus following KD-like children will probably have 1 or 2 signs without fulfilling the whole gamut of KD-like stories. Kawasaki disease shock syndrome is extremely rare. It's only seen about 15 to 20% of KDs, whereas the MIS is almost 70 to 80% of kids come with severe abdominal pain, hypotensive shocks. And last but not the least, what has been the story is Kawasaki still is more of a coronary artery damaging disease, whereas MIS is, due to various molecular mechanisms that we are reading, is only primarily more of myocardial dysfunction and relatively less propensity to cause long-term coronary damage.
Thank you.
Thank you, Vijay.
Yes, and one more, like in the inflammatory markers also, if you see in MISC, there are quite sky-high markers with coagulopathy is seen more commonly with MISC rather than the KDs. Thrombocytosis is more of a predominant feature of KD rather than MISC. And if you look for the CVC, a severe lymphopenia should point out towards an MISC.
So unless in this present pandemic, probably if like Dr. Vijay was lucky with finding a 9-month-old baby with a pure KD case, I think if you are trying to investigate, for all the reasons you'll be calling it MISC, unless you have everything negative pertaining to COVID. Am I right, Dr. Vijay?
That's correct. That's correct.
Yeah.
And when it comes to this WBC count,
yeah,
most of the Kawasaki start their life with a normal count going towards a cytosis in the second week, whereas almost all the MICs who present in the first week are leukopenic and lymphopenic, suggesting that there are some macrophage activation overtones initially, and then in the second week they start behaving like a KD. So that's another clue for differentiation.
Nicely told. Vijay, you were mentioning about aspirin. We have been some time back using 80 to 100 mg. Even Nelson textbook mentions 80 to 100 mg. Now we have come to 30. And what is the rationale? And just we want to be sure that because some of the countries they use still 100, and some of the countries they have Asia, and some of the countries they use 30 to 50. So which do you better? Are we going still down on aspirin? That's what my question.
As we speak, I think aspirin is going out of fashion. I'm talking about the high dose aspirin going out of fashion in managing KD patients. Where it actually came from is the Asian, there was a nice paper coming from Hong Kong, Taiwan, where they started seeing a lot more adverse effect with aspirin. And the original rationale was probably extrapolated from rheumatic fever, managing rheumatic fever with high dose aspirin, which is why the KD patients got a reasonably higher dose of aspirin initially. But the Asian community started seeing a lot more adverse effect in KD, probably secondary to certain genetic reasons, and they tried comparing a lower dose, which is 30 to 50, and they found equivalent results. Over the next decade, what we have found is it is actually the IVIG and or the steroids which do the maximum firefighting in controlling the Kawasaki disease inflammatory part, eventually protecting you against coronary long-term sequel. So what we now know is whether you use 30 to 50 or 80 to 100, the duration is not 14 days for sure, like we used to do previously. If you use it in, and typically that if is only when the cardiologist forces you that this child has very bad myocarditis, etc. I will use it at 30 to 50 for 2 days till the child becomes afebrile. What is more important is instituting the lower dose. So it's the antiplatelet dose which ends up preventing against long-term coronary dilatation or aneurysm. So I have not used aspirin in the 30 to 50 also for almost 1 year, and many of the ped room colleagues are also doing that. But no 80 to 100 for sure. please keep a watch on enzymes, because many KDs will have deranged enzymes, and by using 30 to 50 mg also, you may end up damaging the SGOT PT also. So keep a watch on enzymes along with platelet count, low dose.
Yeah. Thank you. Dr. Deepa, I have a question for you. This child presented at day 12. Will you still give IVIG? Because the traditional things say it is better if it is given before 10 days. So what is the best time to treat the Kawasaki disease?
So yes, basically the first 10 days, if we give it is more efficacious, definitely it's been proved. But if there is ongoing inflammation, there is still a role of IVIG. Usually the inflammation is assessed by ESR and CRP, but they may not be exactly very relevant, because ESR may be persisting even after the fever has gone down, or CRP is a very short life, so it may come down very soon. So it's not just ESR and CRP, but also we can go for echo. So if a child is coming by day 12, even if the ESR is coming down, but the echo is abnormal, then there is still indication of IVIG, and we still can give an IVIG dose.
Absolutely, absolutely. If there are signs of inflammation and the child presents beyond 10 days, definitely it is a case to be given. Only condition is if there are all the parameters are normal, child is clinically better, echo is normal, only in those cases probably we don't give. Otherwise, even if the child presents to you much later, it is better to give whatever the benefit child has to reduce the inflammation. Am I right, Vijay? Yeah.
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 Dr. Bhaskar, can we be little stop, because we are the time is getting up.
Yeah.
So please proceed a little faster.
Yeah. So Dr. Vijay, when would you perform the echocardiography in such cases, especially the follow-ups?
So the classical situation, 0, 2, and 6 weeks. Earlier, in case the child presents with bad ejection fraction and myocarditis, but as a rule, it is at diagnosis a couple of weeks from then, and then 6 weeks. If the 6-week echo is normal, we may close the file. If it's abnormal, then maybe once in 3 to 6 months till it becomes normal.
Yeah. So echo was done at admission. LAD was 7, RCA was 4, and main left main was 4. How would you interpret this result, Dr. Vijay?
I would want the Z scores to be quantified for the body surface area of the child, and the criteria for coronary dilatation has been revised from more than 2.5 considered as abnormal. We now know that any score above 2, you start calling it dilatation, and we will gradually go up to 10 where it's a giant aneurysm, 5 to 10 is a moderate aneurysm, and 2.5 to 5 is a small aneurysm.
Dr. Deepa, thrombocytosis is supposed to be a classical picture in most of the cases, but in this case it was 2.6. Is it against the diagnosis? What is your take?
Those few of the cases, KD may come with a normal count or even a thrombocytopenia, and it's taken as a poor prognostic factor. But usually, when we do have cases of thrombocytopenia, these children are may land up in a severe form of the disease.
So usually the thrombocytosis occurs after the 2nd week. So it is not a early thing. So later it may present. So now the parents are not convinced about your diagnosis. Father asks, how do you confirm the diagnosis? Is there a proof or any diagnostic test? How do you handle such parent, Vijay?
So I will ask the parent if they have 1 extra hour to spend with me in my consulting room, or they can have the answer from the pediatrician in 5 minutes. So most of them agree to take 1 hour of my time, and it's just a matter of sitting with them and convincing them. But subtle clues like periangual desquamation, which is not very specific for Kawasaki, but it kind of, we are not hiding anything, but it's the proof of the pudding is you have to tell them that this is more of a clinical story, and you have ruled out most sinister things, and the response to IVIG is often the easiest thing to convince the parents. And as long as the echo gets normal, most of the parents are okay not asking me for an explanation.
Yeah. So most of the other questions have been answered. So the message is that the Kawasaki disease is a clinical diagnosis. Features evolve over a time. All features may not be present at the same time. So continuous day-to-day examination is more important. Thrombocytosis occurs at the end of second week. Don't rely on thrombocytosis in the initial period. Normal echo doesn't rule out Kawasaki. And even if it is normal, you need to repeat, as Vijay told, 2 to 4 weeks and 6 weeks. IVIG in the standard care is 2 gram per kg over 12 to 14 hours. Once you diagnose, you have to give. And beyond that, if there are other features that we told, echo abnormal or high inflammatory markers, patient is symptomatic, febrile, then probably we should continue to give IVIG. So these are the few things, and we have co-authored with Vijay under the guidance of Dr. Surjit, Indian Academy of Pediatrics position paper on Kawasaki disease. Next case, Jayant.
Yeah. So thank you. It was a very good discussion on Kawasaki. And that brings us to the third case. It's a 10-year-old boy. This is again a real case. March 21. He had fever for 5 days, high-grade continuous associated with chills. There was vomiting, there was epigastric pain, poor intake for 1 day. The child was looking sick. He was febrile, he had a flushed face, erythroderma, grade 2 dehydration. The BP was just okay, 90/60. And the vitals were otherwise fine. Peripherals were palpable. Liver was 2 centimeters, palpable, tender. There was a slight fullness. He was hospitalized and initial IV fluids were started. Dr. Deepa, at this stage, what is your thinking?
So this is a 10-year-old boy. Now this child has come with fever and abdominal symptoms. There is a hepatomegaly, which is also a tender hepatomegaly, but this child appears to be toxic. So yeah, if it we consider a viral hepatitis, usually they come with prodromes with a mild grade fever and anorexia. And the child is not much sick looking. So here is a child with a sick looking child. So we need to think of some non-hepatotrophic organisms here. Maybe it may be dengue, enteric fever, even leptospira, malaria can present like this. So yes, we need to keep these differentials in mind. And
It's the month of March. So leptospira.
Last 10 minutes.
Yeah, it is.
It's okay.
Yeah.
Next
Last
slide,
10 minutes,
please.
ma'am.
Dr.
In case it was a monsoon, we could have think of lepto.
Yeah, sure. Next slide, please.
We'll expedite.
So we investigated this child. The HB was 11, total count was 3,500. Platelets were 40,000. Dengue serology, NS1 was positive. IgG and IgM both were positive. SGOT 130. As you see, a slight rise in the enzymes. The urea was normal, creatinine was 1.1. Urea was mildly elevated, I'm sorry. Ultrasonography showed mild hepatomegaly. There was a small right pleural effusion. CRP was 15. RT-PCR COVID-19 was done. It was negative. He was treated with IV fluids and supportive treatment. He was better by day 7. No fever. There was urine output was fine. And the repeat counts also showed an improvement in platelet. Dr. Vijay, what is your take about the dengue serology and how does one follow that further?
I may not be the right person to answer dengue serology.
Okay, I think I'll shift it to Dr. Kea. Dr. Kea, please.
Yeah, as you can see here, it is on the day 5. In the first 4 to 5 days, we should concentrate on NS1 antigen. But if it is more than 5 days, we don't usually, because the curve, if you remember the curve which is shown in most of the CMEs, it just goes down. And then the IgG and IgM becomes positive. So here, as it was a borderline case, it was on the 5 day. So we have got both NS1 positive, IgG and IgM positive. So it's a classically a dengue case where both the antigen and the antibody is positive.
Next slide, please. And he was almost on the verge of recovery. And then suddenly developed high-grade fever again. The pulse, he was tachycardic. The BP had put down. The peripherals were weak. The saturation had dropped down marginally. He had hepatomegaly earlier, now also developed a splenomegaly. And he had a respiratory distress. He was shifted to PICU. The chest X-ray was not looking very nice. It was more or less like an early RDS. Treatment was started with anotropes, broad-spectrum antibiotics. Of course, IV fluids were readjusted. And he had to be taken on ventilator in the due course of next 24 hours because his distress could not respond. Now, Dr. Kea, what was happening here? What is your primary possibility? He was recovering from dengue. He demonstrated by a high platelet count also. What has gone
So
wrong
here, I don't think there is not a clinical dilemma about dengue, because it was very classically both clinically and laboratory wise.
Yeah.
So if a patient who is recovering from dengue again goes into this type of things, you have to think of few possibilities. Sometimes in monsoon, we do see dengue with co-infections. I don't know what's your opinion, but we have seen dengue with malaria, dengue with acute hepatitis, dengue with rickettsia. And sometimes they, after some response, this second infection copes up, and maybe they have acquired it from the hospital. It may be like that, going into shock.
Malaria,
So this
malaria was negative.
Malaria, yes. As I
Yeah.
said, dengue with malaria is very common.
No,
So
but
I've
malaria
seen.
was negative, Optima was also negative.
Just for because the patient was here for a few days in the hospital. And maybe another thing is sometimes the complications which might arise. And as you can see here, there was hepatomegaly, there is onset of new splenomegaly. Okay, there is onset of new respiratory distress, and the peripheral pulses are becoming weak. And this might, of course, we have to think of some complications. And as you know, typhoid and dengue is very notorious for developing HLH. So we often get HLH-like complications. So we have to think of like, or some secondary infection, which may be some hospital acquired.
Yeah.
So these are
Dr.
the things.
Bhaskar, next slide, please. So again, of course, this child had re-investigations. And as you see, there are a lot of changes. Hemoglobin has dropped down. Total count is 2,000. The polymorphs have come down. The ANC is 150. And the platelet count is also dropped down again from 75 to 30,000. ESR is increased. CRP is 115. It was earlier 15. The prothrombin time is deranged. The INR is deranged. Bilirubin is 8 with a direct of 6. SGOT is 426 and SGPT is 600. Blood culture by that time has showed no growth. What are we looking at? Is it, Dr. Deepa, is it dengue complicated by occult sepsis, or is it an acute fulminant hepatic failure which has come on the onset of dengue, or is it something else? Can you just differentiate points on this?
Here is a child where we have diagnosed him as dengue, but the fever has continued, and the recent splenomegaly has come in. And now if you look at the CBC, there are there is a pancytopenia with the hemoglobin of 9.6 and leukopenia as well as a thrombocytopenia. Looking at the ESR and CRP, yes, whenever there's an infection and inflammation, there is both the ESR and CRP go high. But here the ESR is near normal and CRP is raised. So this is something which may not go in only with inflammatory. It comes usually with HLH, where ESR comes down.
Very good.
And occult sepsis, I won't think of a secondary infection over here. The neutrophil count is almost.
What about fulminant hepatic failure? Would you like to do something here for that regard?
Here, considering HLH, I would like to investigate more in the form of ferritin and triglycerides, fibrinogen, and then I would like to go further.
Yeah, perfect. So Dr. Bhaskar, next slide, please. As Dr. rightly mentioned by Dr. Deepa, we did this. Ferritin was 11,000. The triglycerides were 200. We did the bone marrow biopsy. It was suggestive of HLH. So it was finally HLH secondary to dengue. He was lucky that he got treated with dexamethasone, and as per the HLH protocol, we also gave etoposide. The child was under the care of hematologist as well as hemato-oncologist and a supportive PICU care, and he luckily made it over the next 2 weeks. He gradually recovered. He was off ventilator by day 3 and all these things. Next slide, please. So what are the lessons learned from this case? So dengue fever can complicate occasionally. As rightly mentioned by Dr. Khea, in particular season, you can have mixed infections coming, like a dengue and a malaria, like a dengue and a typhoid. Now, septic shock, though, has to be considered as a primary possibility here in such an acute worsening. Conditions and like HLH are something, HLH is quite rare to happen, but one has to keep our antennas up for this possibility. A marked bicytopenia with a marked rise in ferritin is an important clue for HLH, and it requires a multidisciplinary treatment with a good PICU team. Can Dr. Vijay please throw some light about HLH?
So all the infections that we talked about in the discussion, whether it is EBV, whether it is rickettsia, whether it's mycoplasma, whether it's enteric, or whether it's dengue, all of them have a unifying pathway. If they do not behave the way they have to, the rheumatologist in me thinks that it is a immunodysfunction or immune dysregulation, and the only complication you You will call it HLH, and I would prefer to call it macrophage activation syndrome, which is a form of secondary form of an HLH. The clues in this case were very obvious. While we were about to discharge this child, I didn't see an ESR. So my message, I can't leave any CME without highlighting the importance. जब भी CRP भेजेगा, ESR भेजना please.
Yes.
A child who worsens with a normal ESR is a problem for me. And then what does the ESR suggest? Hypofibrinogenemia. So a normal ESR is a sick child. Transaminitis will give you a clue. And many times you may not even have a bicytopenia, because remember, macrophage activations generally start in the liver and spleen, unlike HLH, which follows a leukemia, starts in the bone marrow. So even one cell line down, a climbing CRP, a normal or a lower ESR, and last but not the least, ferritin. A ferritin more than 5,000. As a blanket rule, please think of sepsis, but please give steroids. More than 5,000, there is no differential diagnosis. Invariably, you will end up with a diagnosis of mass, and do not stop at ferritin alone. Please send everything at one shot. So CBC, CRP, ESR, ferritin, triglycerides, LDH, and fibrinogen. We can't compare 3 days Veleca CRP with today's ferritin with, so it's a dynamic process, all documented at one go. And then once you have documented everything, just go ahead with pulse methyl prednisolone and or DEXA, and then move on from that. So the high index of suspicion is what is important.
Thank you very much.
We will
please proceed with the last case.
Last case. 5 minutes I have.
5 minutes. No, we are already late, sir.
Yeah, please.
Okay, this is I will just go through it. A 7-year-old male with the fever of 2 months, joint pains, abdominal distension, and ulcer over the left corner of mouth. Hello? Ulcer over the corner of mouth, tongue, and fingers. 20 days. He had multiple respiratory tract infections starting from the age of 6 months with 1 or 2 admissions. History of abdominal surgery, probably for the drainage of pus from the abdominal wall. He had abscess in the left thigh, drained, and family histories. He is the male who is affected, and there are no other significant family history. So here he had swelling of the joints, had ulcers in the mouth, outside of the mouth. Hepatosplenomegaly was there. This is the picture wherein you can see the cancrum oris kind of picture, both in the near the mouth and hands, and the joints which are swollen. He is emaciated. And his CBC was done with a hemoglobin of 9, total count of 23,000, and ANC of 16,000, ALC of 4,000, platelet normal. Dr. Deepa, do you think anything abnormal here?
So looking at the history, there's a suggestive of ongoing fever, joint pain, ulcers, rash. There's some autoimmune phenomena, autoinflammatory things going on. As also there's a past history of repeated infections, deep-seated infections. So there appears to be immunodeficiency in this child also. A CBC.
Something abnormal with the CBC.
Yeah.
The lymphocyte count appears to be normal, so that rules out our T-cell disorders, and the neutrophil count is quite high in this child. Okay. Sometimes, like in case of your leukocyte adhesion defects, you can get high neutrophilia.
Yeah. So as you told, we looked at immunodeficiency, did HIV, which is negative. What next you would like to do in such cases, Deepa?
Just a moment. We'll just cancel the break and we'll proceed. We can take 5 more minutes.
Thank you so much.
Thank you so much.
God bless you. So, what is the next investigation, Dr. Deepa, you would like to do?
So now, considering an immunodeficiency, we would like to go for an immunoglobulin assay to look whether there's any decreased immunoglobulins first, and in case further, you can go for a flow cytometry to look for the CD cells.
Now, I want to ask you, what made you think of immunodeficiency, and what is your message to the audience? When do you suspect immunodeficiency?
So, any child who comes with either recurrent infections, whenever we are isolating some unusual organism and unusual site of infection, or an unusual presentation, either there may be like a persistent infection or a recurrent infection going on, we need to think of this immunodeficiencies, a family history. That is, if there's a family history of PID, definitely yes. And of course, some of the immunodeficiencies may come up with, will be combined with autoimmune disorders. So in such case, and if there is a low response to, we need to, we have deep-seated infections and prolonged infections, we need to think of immunodeficiency.
Absolutely, absolutely.
Sir, other than that, other than the recurrent infection, uncommon infection at unusual sites, we also have to think of any severe infections or a child with failure to thrive with recurrent oral ulcers or some chronic problems like chronic diarrhea. Even then we can think of PID.
Failure to thrive from the beginning, deep-seated infection, unusual infection, unusual sites, organ infections, all these things, and need for IV antibiotics, need for, in addition to repeated infections, and need for recurrent courses of antibiotic and no response, and failure to thrive from the beginning, in addition to the points that already you people have highlighted. So here, Dr. Deepa told that we will go for immunoglobulin. Let us see what has happened to the immunoglobulins. So immunoglobulin profile was done. Hemoglobin E was low, less. It is 8.3, and A was low. It was 26, whereas the range was 29 to 270. G was 342. Range was 700 to 1650, and M was less than 20. So that means there is a decrease in all G, A, and M. So this is the thing. So now, how will you go ahead, Dr. Vijay? Do you get such cases, and in case you get, how will you go ahead?
We do see these kind of kids who actually come with overlapping inflammatory manifestations, and which is where the detailed history comes into picture. This is a male with already a male in the family getting afflicted and recurrent infections, and now this child has come with arthritis as a manifestation under the history of a lot of infections, and the immunoglobulins are all pointing towards the low immunoglobulin levels. So if I connect all of them, this is a male with hypogammaglobulinemia with inflammatory manifestations, and he's so the straightforward thinking is he some form of a X-linked agammaglobulinemia or X-linked hypogammaglobulinemia? I would probably follow this up with a flow cytometry, document absent CD19 in this child. If possible, get a genetic workup for a Bruton tyrosine kinase gene mutation and confirm the diagnosis of Bruton's hypogammaglobulinemia.
Very nicely, Dr. Vijay has given the flow. How should we go ahead? Simplified approach. So after that, immunoglobulins, as he told, we have done the CD19, which is 0, and absolute counts, it was 0. There was absolutely no B cells in the thing by flow cytometry. And as you have rightly pointed out, the approach to this case, he is a male, X-linked inheritance, immunoglobulins are absent, B cells are absent. So it is X-linked agammaglobulinemia. In other words, it was Bruton's agammaglobulinemia. So other tests were done. And as you rightly told, we did a clinical exome study also, and the BTK gene was found, and absent, and that pointed towards the diagnosis of X-linked agammaglobulinemia. But we did even the CME test, and the CME qualitative was positive. And then we asked for quantitative, and it was about 32,000 copies per ml. How do you tackle such cases? Do you think treatment is necessary here or not? Any one of you?
I think CMV infection in an immunocompetent child, in that cases you should see for the viral load and treat. But in an immunocompromised child, like this is a gammaglobulinemia. So in this case, I think whatever is the DNA copies, we should treat. And not only treatment is essential, but these patients can have recurrent infection. So we should also give a viral prophylaxis. And that's my view.
Yeah. So the treatment, Dr. Deepa?
Yes, we can go for Ganciclovir or IVIG is recommended in view of this to prevent the repeated recurrent episodes. And cotrimoxazole prophylaxis has been given 5 milligram per kg per day.
How often you want to give IVIG?
IVIG can be repeated every month or 3 to 4 weeks, depending on the severity.
Okay, thank you. So as we know, the primary immunodeficiencies all these days, we were not given much importance or never we thought of it. So now that we are doing more workup and trying to understand and trying to diagnose more such cases. So what are the 4 clinical important categories for the help of a general pediatrician, how they can stratify the immunodeficiency?
Sir, usually we can have a predominant immunoglobulin producing disorders, or we can have a combined T and B cell disorders. Then we can have disorders in phagocytic function and complement deficiencies.
So, as you rightly told, for the practical purpose, we can divide into 4 types: T cell, combined, complement, and phagocytic defect. X-linked agamoglobulinemia, combined variable immunodeficiency, IgA, IgM, hyper IgM syndrome, they come under B cell. SCID, Wirscott-Aldrich, D. George, they come in combined. Complement deficiencies, especially they are more prone for serial infections, lupus, and phagocytic defects, they can manifest with chronic granulomatous disease or leukocyte adhesion deficiency or congenital neutropenia. And Kaya, do you think the age of presentation is useful in classifying a child with the PID? You get a child of particular age. Does it help in pointing towards certain clinical condition?
Yes, sir. If it is present very early in the course, like within 2 months, we usually think there is a associated T cell defect. Whereas in case of B cell defect, which is a much more common cause of PID, here the maternal immunoglobulins will protect for 5 to 6 months. So if you are getting a case where the infection starts from around 5 to 6 months, we will more think of a B cell defect. In complement defect, you can see at any age. And obviously granulocyte defect, because it's a defect of the phagocytosis, it will have an early onset. So,
we need to wind up, sir.
Yes, sir.
Yeah, please. I think Dr. Bhaskar, you sum it up now.
Yeah. So age, family history, examination, and the high index of suspicion, these are very important. Yeah. Then you look at the hemogram, cultures to rule out other infections, immunoglobulin profile you do, and then as Dr. Deepa has told, severe, persistent, unusual, recurrent infections. Family history is very important. One important thing I want to stress is the neutrophil and absolute lymphocyte count, which is going to help you in making a diagnosis. So carry-home points are whenever the fever or the infection-like condition looks like infection, but it is not infection. When it comes beyond the neonatal period, when there are no inflammation, you think of certain rare conditions like hypothalamic causes, thyrotoxicosis, familial dysautonomy, etc. But when there are inflammation, signs of inflammation are present, you think of rheumatological conditions, hematological conditions, oncology, or drug related. So to conclude, fever is not equivalent to infection. That is the basic thing we have to remember. Non-infectious causes also should be kept in mind. Whenever you don't the fever doesn't respond to the antibiotics or takes a different path, eyes see only what minds know. That means unless you suspect, you cannot think of any other clinical condition. So suspicion and thinking of the possibility is the most important thing. Kawasaki disease is a great mimicker, as we have seen in our cases. It can mimic UTI, it can mimic viral, it can mimic drug rashes. Don't miss the forest for trees. Look for warning signs of the clinical judgment is more important. Think of complication when typical case behaves atypically, like what Jayant has told in the dengue case, which has turned out to be HLH. Think out of the box when the patient doesn't behave in a classical way, and think of PAD in SPUR, severe, persistent, unusual, and recurrent infections. So thank you very much. It was a wonderful experience. Thank you, organizers, for giving us an opportunity. My colleague, Dr. Jayant, has done a wonderful job. And all the panelists, you have done so wonderfully. Thank you very much, Vijay, Keya, and Deepa. Thank you very much.
Thank you, Dr. Sanjay, and the time moderators for giving us a little extension of time. The discussion was getting interesting, so we could not really stop at that. Thanks a lot, Pune IAP, for the opportunity. And it has always been a pleasure to be with Dr. Bhaskar. All the panelists were very good and contributory. Thanks, Dr. Vijay, Dr. K, and Dr. Deepa for your contribution. Thank you very much. Bye.
Thank you.
Thank you all the panelists and moderators for this session. It was a wonderful session with interesting cases going on. Since we are running short of time, presently we'll just cut off the lunch break. I hope everybody can have their individual lunch at their home, sitting in front of the screen. So now we proceed for the next session. Next session would be a vaccine safety monitoring. For this session, we have Dr. Gagandeep Kang as a faculty, and as the chairpersons, we have Dr. Jayant Upadhyay and Dr. Deepak Mule. Let me introduce them. Yeah, Dr. Gagandeep Kang, she is Professor of Microbiology, Division of Gastrointestinal Science in CMC, Vellore. Her areas of interest is enteric infections, nutrition and vaccines, and public health issues. Special achievements for her is she has conducted and ran surveillance networks for vaccine preventable diseases. She's also an Infosys Prize in Life Sciences she has received, and a few other awards, and more than publications, 400 publications on her name. Next is Dr. Deepak Mule. He is a practicing pediatrician at Sihangarh Road and consultant at Shaishav Hospital, Shatayu Hospital, and Pulse Hospital. Presently a joint secretary IAP Pune for the year 2021. And lastly, the chairperson, Dr. Jayant Upadhyay, sir. He is a consultant pediatrician and neonatologist, director of Colors Children's Hospital and Upadhyay Children's Hospital in Nagpur. His areas of interest are enteric infections, nutrition, vaccines, and public health issues. Special achievements, he was a National Vice President, Central IAP for the year 2021, West Zone. Executive Board Member for CIP in the year 2012, 13, 16. He was a Chief Organizing Secretary at Pedicon in 2018 and 18 in Nagpur. He was a faculty for National, State, and IAP chapter conferences for last several years. So we start with the session. Over to you, Dr. Upadhyay sir and Dr. Kang madam.
Thank you, Dr. Sandesh. Stop here. Today, for the session on vaccine safety monitoring, we have none other than a celebrity faculty in the form of respected Dr. Gagandeep Kang. We have seen her deliberating on national television, social media, and she is a highly respected faculty in the field of immunology and vaccinology. As we know, a huge pandemic, biggest ever in last 100 years, is going on in India in the form of COVID-19 disease. So many vaccines have suddenly rushed up to the platform. Many multiple vaccine platforms are available there. So many trials have been done. We are hearing about stage 1, stage 2, stage 3 trials, emergency use has been issued for several vaccines. Since last 70 years, vaccines are being used routinely for various infectious diseases also. Almost every vaccine available is upgraded and updated since its inception, depending on the changes in organism and method and preparation of the vaccine. Changing nature of epidemiology of diseases and thereby change in structure, component, and manufacturing processes of vaccine, comes the responsibility of maintaining and monitoring the safety of vaccine we are using. We are here in this session to hear on vaccine safety monitoring from none other than Professor Dr. Gagandeep Kang. So I request Professor Gagandeep Kang, Madam, to start her deliberation.
Thank you very much, Dr. Jayant, for the introduction, and many thanks to the IAP Pune. It's been an absolutely fascinating morning, learning so much about pediatric infectious diseases. I think understanding vaccine safety and monitoring is so important for all doctors, but especially for pediatricians and pediatricians who focus on infectious diseases. As Dr. Jayant said, it is very, very topical just now with SARS-CoV-2. We are just getting reports about mRNA vaccines and their association with myocarditis. We are hearing about the adenovirus vaccines and the thrombosis with thrombocytopenia syndrome that has been associated with these vaccines and had led to their restrictions in use in younger individuals. There are reports from Kerala on an atypical presentation of Guillain-Barré syndrome with bilateral facial paresis. We also know from early vaccine trials that there has been a lot of reports of Bell's palsy that have not played out once the vaccines have started to be used in real life. So I think it's very important to emphasize that many things can be identified in clinical trials of vaccines. When vaccines are being tested, we can identify what are common side effects. But for uncommon side effects and for assessing their causality, the ability to identify events and relate them to vaccines is extremely important, because we start with all of these conditions being unknown. So what really is causality, and how do we do a causality assessment? The causality is the relationship between the cause and the effect, where the effect is caused by the cause. So causality assessment determines whether a relationship exists, and if it does exist, to what extent. Now, what do we mean when we want to look at causes of an adverse event? And basically, we look to see whether vaccination increases the occurrence of a particular event in the community. And then we look to see whether the vaccine was the factor that resulted in the individual development of that event. So a disease that I work with, rotavirus, is not by itself. Rotavirus infection is not associated with intussusception, but in some populations and with some vaccines, we have seen that you can see an increase in the occurrence of intussusception in the first week following immunization with the vaccine. So our ability to do a causality assessment at the population and the individual level is extremely important. And we now have WHO guidance that has been developed for how to do a causality assessment. So post-licensure, which is when you detect most rare adverse events, you need to determine safety, and that safety can be determined through individual case reviews. This happens most often when it is a vaccine product related event. It can happen through passive surveillance, through active surveillance, and through epidemiological studies that allow you to assess the relationship between vaccination and changes in incidence of a condition in a population. So my slides seem to be stuck for some reason. I'm sorry, but I don't know why my slides have stopped moving. Okay, better now. Okay, now in order to be able to do evaluations, if we have passive surveillance, the way that it is done is if you have an event, it needs to be notified, reported, investigated, analyzed, a causality assessment done, and that provides feedback so that we can improve the performance of the surveillance system. So we can see here all the steps that are followed. In India, we have a 3-tiered system for doing this. The AEFI detection and notification happens at the immunization site. That is then reported to the district, and the state coordinate the initial investigation and analysis. And the causality assessment is done at the state and the national level, and that results in feedback to the immunization program. There are terms that have been defined that are used, and these are the terms for vaccine pharmacovigilance, which have been agreed upon by CME and the World Health Organization Working Group on Vaccine Pharmacovigilance. So we won't go into the terms specifically, but just to go into what a definition of an AEFI is, it is an untoward medical occurrence following immunization, and at the point of identification of that event, it does not need to have a causal relationship to the usage of the vaccine. It can be a sign, it can be a symptom, it can be an abnormal laboratory finding. So symptoms, signs, laboratory findings, disease, all of these can constitute an AEFI, and each of them will warrant an investigation. Now, if we look at the types of AEFI, they can be product-related reactions, they can be defects that are related to the vaccine manufacture, there can be immunization errors, and there can be immunization anxiety-related events, and there can be coincidental events that happen at the same time as vaccination, but are not necessarily related to the vaccine or to the vaccination. Now, if we look at a vaccine product-related reaction, that can be the kind of erythema and swelling that is seen at the site of vaccination. We can have vaccine quality defect-related reactions. An example of this is the Cutter event, about which a book was written. This was essentially when IPV was first being made, a company that had previously made only animal vaccines was asked to make vaccines for children, and they were not able to inactivate the virus completely. And one batch of vaccines resulted not only in children who received the vaccine developing polio, but also some of their contacts developing polio. We also have immunization error-related reactions, and you can see an abscess that has formed there. And this can be inappropriate vaccine handling, prescribing, or inflammation. We have immunization anxiety-related reactions. These are frequently seen when there are group immunization programs, particularly in school programs. If one child has a problem with the vaccine, then you see this spread very quickly to other children. You can also have coincidental events that can happen where an illness that is not related to the vaccination can occur at the same time and is treated as being causal when it actually is not. So if we take these 5 classes of events, then how do we do a classification of our analysis? Well, we can look at an association with the immunization, and we see that for vaccine product related reactions, for quality related reactions. We see that for immunization error related reactions and for anxiety related reactions. And when we have a consistent relationship, it can belong to these 4 categories. And if there is an inconsistent association, that's more likely to be a coincidental event. But in between these two, we can also have conditions where we cannot make a determination whether it is consistent or inconsistent, where there is a relationship in time, but there is not enough evidence to tell us whether this is truly related or not. And this may be something like we saw with the thrombosis with thrombocytopenia syndrome, where it was something that had not been previously described, but for the first few cases, we were not clear whether there was an association or not. Similarly, for myocarditis, this is something that began to be reported very early on from Israel, when they were not clear whether there was an association with the mRNA vaccines or not. But as numbers have accumulated, we are beginning to see that it has moved from B to A. You can also have situations where you wind up with unclassifiable associations, and there it's very important that the investigation specifies what are the additional information required for classification. So if we look at, an example, if we look at the risk of anaphylaxis after vaccination in children and adults, in the US, there have been studies that have used the vaccine safety data link. They also use passive reporting systems such as the vaccine associated adverse event reporting system, which allows for the public and people who have been vaccinated to report. But the vaccine safety data link is a more actively managed program that is in partnership with healthcare providing communities, health management organizations in the US. So in this particular case, they looked at all patients within a defined time period that had a vaccination record, and they used a definition that has been developed by the Brighton collaboration and tried to calculate the incidence of anaphylaxis after all vaccines combined and for selected individual vaccines. So for this, they studied over 25 million vaccine doses and were able to find 33 confirmed vaccine-triggered anaphylaxis. So this is why you need a large database to be able to detect events that are very, very rare. And as you can see here, there is a great difference between the type of vaccine and the rate per million doses with different kinds of vaccines. So MMR containing vaccines have a much higher rate of anaphylaxis than any vaccines that contain hepatitis B. So in addition to that, these kinds of analyses can give us much more information, as in when are cases more likely to occur, what ages are they more likely to occur, is there gender distribution in terms of the number of cases as well. We can also look at vaccine quality defect related reactions, and there are multiple examples of that. With rabies vaccines made by Louis Pasteur, we know that 1 in almost 200 people who received those vaccines, which were actually done in the spinal cords of animals that were dried over time, that there was a risk of seizures, paralysis, and coma. TB using the Lubeck strain, we found that people who were vaccinated with a particular type of BCG had developed disseminated disease and people died. With yellow fever and with hepatitis B vaccines, also there have been similar events that have been reported that have resulted in deaths. And I mentioned the Qatar incident related to the inadequate inactivation of vaccines previously. We also have immunization error-related reactions, and these are the news reports that we frequently see. Measles vaccines that are contaminated, inappropriate diluent being used, reuse of needles, dirty needles being used, and you see children suffering because of these errors in the immunization program. If we look at anxiety-related reactions, these have been seen with a range of different vaccines. Most recently, we've seen this with human papillomavirus vaccines, and there's a new name for it. It used to be called hysteria. Now it's called mass psychogenic response. So these are examples of what has been done. It's the new classification that WHO is trying to promote. Instead of calling it even a mass psychogenic illness, is to now call it an immunization stress-related response or immunization anxiety-related reaction, and this is now classified as an AEFI. Then, of course, we have the very large bucket of coincidental illnesses, and we also have people that use these kinds of coincidental findings to promote disinformation about vaccines. A key example of this is what happened with MMR vaccines and autism. We know that autism is detected at the same time that children usually get the MMR vaccines. And Andrew Wakefield was able to use this coincidental finding and some very badly done laboratory experiments to push the hypothesis that MMR, when all three antigens are given together, that results in autism, and there is a causal relationship. This did incalculable damage to the immunization program, resulted in outbreaks of measles in the UK, the US, many other parts of the world, also resulted in the transmission of measles to children who were too young to be vaccinated, and these children have actually died because of this disinformation. So this just speaks to the reasons why understanding causality and being able to do causality assessments is so important. Now, there are a number of methods that are available for determining causality of individual AEFIs. These have been developed over time. The second edition of the WHO's causality assessment for AEFI is a very comprehensive document. It is also easy to use, and I know that many pediatricians in India have been trained using the methods that are available in this document. But in addition to this, there is a website which the Global Vaccine Safety Initiative has developed and laid out tools that can be used at state, at national level to be able to do causality assessments. Essentially, in the WHO method, the steps are to determine eligibility, to use the checklist to follow the algorithm, and then classify AEFIs according to the 5 classifications that we discussed earlier. There is a form that is required to be filled, and the form captures all of the information that is required for causality assessment. Unfortunately, what we are seeing with the SARS-CoV-2 reporting, that a lot of the forms have such little information that is completed that it has been very difficult for the AEFI committees at state and national level to be able to make determinations between events and the vaccines that have been used. And this is with just 2 vaccines being widely used in India. And there are concerns about what will happen when we have even more vaccines that are available within the system. So the colors on the forms that are supported by WHO support the different steps of the evaluation, and sometimes committees develop their own ability to create causality questions. So basically the question is, what is the relationship between this specific vaccine and the finding that we have had? So examples of that: has the SARS-CoV-2 vaccine caused thrombocytopenia? Has the vaccine caused Guillain-Barré syndrome? So this can be in the form of symptoms, it can be in the form of laboratory findings, it can be in the form of a disease. So as I mentioned, there are lots of these tools available, but the most important thing is to be able to take the information that we have, be able to say whether there is a consistent association with immunization, whether it is inconsistent, whether it is indeterminate, or what is the information that is missing that did not allow us to classify this particular case. The most important is to ensure that in the future, we make sure that we have adequate information available and don't continue to report cases that do not provide the information for this kind of classification. So I will end there. I've had the privilege of being on the WHO committee for vaccine safety for many years. I'm currently on the SARS-CoV-2 vaccine safety committee, and I can speak to the value of safety systems from other parts of the country, other parts of the world. It really worries me that India does not have these established well. If we look back at what happened with SARS-CoV-2, you will remember that the newspapers in January were full of reports of AEFIs. Those reports have disappeared. And if we look now, we cannot even come up with an association with symptoms that have been described in other parts of the world for thrombosis with thrombocytopenia. So just to encourage everyone, if you have an opportunity, please report, and please encourage your colleagues to report. Thank you very much for your attention.
Thank you, ma'am. Thank you very much. Very nice presentation, very nice lecture given by you. With this lecture, it helps us to know the safety of all the vaccines, particularly in COVID period. This is both COVID vaccines also. And the take-home message is we should have the data regarding everything about this. So which will help us to promote the vaccines for the vaccine hesitancy people. We can give this data and we can promote this. And with all this data, we know the safety of this. So very nice presentation. Thank you very much, ma'am. Thank you. Over to you, Sandesh.
Thank you, Dr. Deepak and Dr. Upadhyay, sir, as well as thank you, madam, for the elaborate talk on this vaccine safety monitoring and all those things, which gives really a good insight. Now, moving on to the next session, we have a talk on pneumococcal vaccine by Dr. Upendra Kinzavdekar. Let me introduce. 1 second. I'll share my screen. Anyway, as we all know, Dr. Upendra, so he's a practicing pediatrician from Navi Mumbai. His own hospital, that is Kamlesh Mother and Child Hospital at Nerul and Apollo Hospital, Navi Mumbai. His areas of interest are infectious disease, nutrition, vaccinology, pulmonology, general pediatrics. Special achievements: he was an honorary treasurer at IAP in the year 2018 and 19. He has 17 publications in textbooks and journals, and 10 author and co-author for IAP modules. So for the pneumococcal vaccine, over to you, Dr. Upendra.
Yeah, good afternoon. And at the outset, let me thank Dr. Sandesh for a kind introduction, as well as IAP Pune for the kind invitation to share the thoughts. Okay, all audible and visible, I'm sure.
Yes, sir.
Yeah.
Yes, sir. Yes, sir.
So, friends, though this talk is sponsored, as you can see, by GSK, it is written over there, but I'll try to have a unbiased opinion about the different PCVs which are currently there in the market. And I would start from where Madam just now left, that a thought she started off with. In January, we had the newspapers full of talking about adverse effects following immunization. And January, we also got up with a wonderful news that the new own PCV, Indian manufactured PCV, was available in the market. Precisely on 30th of December at the hands of Honorable Health Minister, this was launched, and soon it will be there in the immunization schedule of Government of India. We already had two established players in the form of Synflorix and Prevnar, all of us know, and more than a decade of experience over there. And this COVID pandemic has taught the governments of importance of preventive healthcare, having in place instead of getting it as a shock surprise as what happened when we were struck with this pandemic. And people at large have also understood the importance of prevention of a disease in the form of taking vaccination, that too in time. So I think everybody, this is a right time to sensitize general public as well as government officials to speed up and expedite the importance and the immunization practices, so that importance is understood very well. So guys, yeah, so I have no conflict of interest to declare. So as of all of us know that pneumococcal disease is the #1 cause of vaccine preventable deaths. Though there are a number of vaccines, we talk about polio, but it is not mentioned because probably, hopefully, that we do not have important, polio as a major threat as of now, though we are all always cautious about reappearance of it. And then, of course, rotavirus, pertussis, hip, measles, tetanus are all equally important. But as you can see, the maximum chunk of worldwide distribution of vaccine preventable deaths, if I concentrate on children less than 5 years of age, it is nothing but a pneumococcal disease. Unfortunately, when India aims to become a developed nation, we rank #1 in the pneumococcal disease deaths. So that's not really a great fact to be proud of. So we want to have protection against pneumococcal disease, that is of utmost importance. And we all of us know that it is the conjugate vaccine which is going to help us to prevent this vaccine preventable deaths. So spectrum of pneumococcal disease, everybody is aware of that, this typical pyramid, that the prevalence start reducing as we go down from go up from otitis media to pneumonia, and then finally the invasive pneumococcal diseases, which usually comprise of meningitis, the bacteremia sepsis, bacteremic pneumonia, endocarditis, so on and so forth. But fortunately, the severity reduces. So that's why it is important to understand the base of the pyramid where the maximum cause is there. It is not an invasive disease, but otitis media and pneumonia. But aim of my pneumococcal conjugate vaccine, I would have liked to have the best vaccine, which not only prevents the invasive pneumococcal disease, but also pneumonia, also otitis media, also gives me herd effect, also reduces my nasopharyngeal carriage, and that is last but not the least, also reduces my indiscriminate antibiotic practices. So if a vaccine which fulfills all these criteria would be the best vaccine that you and I can use in practice. So we all know that the disease coverage, if I talk only about India and meningitis, because all of us know, even if we talk about pneumonia being caused by Streptococcus pneumonia, the culture positivity is in the range of 10 to 15%. We hardly get it. We only recommend it when the child is really serious or admitted in the ICU or not responding, immunodeficient. There sometimes it will have some value. A routine community acquired pneumonia, we really don't get culture, and then we get it meningitis. But here also one has to be really careful that sending the sample early in the lab, because the chances of retrieving Streptococcus pneumonia go down as the time is spent only if the sample is kept in the on the table. So ICMR has showed that Streptococcus pneumonia is the most important cause to the tune of 83%. And let me be honest that in my 30 years of practice, I have one single case of hip grown and Neisseria meningitis grown in CSF is zero experience. So that is how actually it's a representative criteria, which you can see that it is the Streptococcus pneumonia if I'm talking about meningitis, and the highest prevalence being in 1 to 11 months. So we want to prevent under any circumstances. So S pneumonia is an important etiologic agent and we want to prevent it. Now coming straight away to the PCVs that we have in our basket right now, we had started off with PCV7 in the year 2000, and then the 6 more valent serotypes were added and it became PCV13 by the same manufacturing company. Then we had also PCV10, and then the new kid on the block, which is just 6 months old, but then talked about so much everywhere, and being an Indian product, we are proud of it. So it is also having a 10 serotype containing vaccine, but then there are certain serotypes missing here and there. So does it make any sense while using these vaccines in practice? And are there any more differences apart from only the serotypes? So let's go to that fact. So it is not only the difference in the serotypes, as you can see, the antigenic concentration also differs. More or less, you can see that PCV13 has the highest antigenic concentration of almost all. The older PCV10 is lesser as compared to PCV13, and newer PCV10 in between, or in fact, it is also less as compared to older PCV in most of the strains. So it is said that they studied a comparative style, a study was done in Gambia, and which showed that probably the higher antigenic content gave a little bit of more immunological edge over the others, and that was proved in the Gambian study. This was an advantage given to the PCV13 vaccine. Now, how about the protein carrier? Yes, CRM 197 remains same for the new PCV10 as well as PCV13. But is the conjugation chemistry, the technology the same? Not at all. So though it is a reductive amination for PCV13, it is synylation with CDAP. This is the wonderful technology. It is a new CDAP technology which is found to be much superior than rest of the technologies. So this new PCV10 has this technology which is used for conjugation, which naturally gives an advantage. And of course, the old PCV10 also had the similar advantage with the synylation technology. And the carrier proteins also, so though always Synflux will claim that the protein D of non-typable H influenza will give an advantage, because out of 10, 8 are conjugated with protein D of non-typable, the rest 2 are TT and DT, but they never claim that, because it's just a single serotype which is taken over by this carrier protein. You do not get protection against tetanus or diphtheria just because of that. So this is the point of difference. So they look alike, sound alike, but then they are different. So what is important is 3 additional serotypes in PCV13. Older as well as new PCV10, they lack serotype 3. The antigenic concentration of each individual serotype is PCV13 is higher, and antigenic concentration of majority of serotypes of PCV13 is more than PCV10, older PCV10. And I talked to you about conjugation technology. It is very important to understand at this stage that there are more than 90 serotypes of the pneumococci which are responsible there, but out of which only 20 are responsible for most of the disease. So what is important? Does it mean that you just go on adding serotypes and so that you will get about 100% coverage? No, it doesn't happen, because we already have a PCV15, a PCV20, which is almost ready to be marketed soon, but that does not does not give advantage over PCV13 to a great extent. It will just add on 4 or 5 or 6 or 7% at the most. So this is a very important fact, because adding serotypes also comes at some cost of probably efficacy of that antigen when it is actually given in vitro. So that is very important. So though all available pneumococcal conjugate vaccines are different, though they look alike. So what is more important for you and me as clinician is is it only the serotype coverage, that what are the serotype contents or constituents of that vaccine, or do we want a protection? So as a matter of fact, everybody would come out with an answer. Yes, whatever vaccine you may tell us, the patient in front of me who has taken this vaccine should not suffer from pneumococcal disease. And that's perfectly justified answer. And let's see whether that happens or not. So protection is basically when we achieve reduction in overall disease burden, and that is what is more important. So we can see that there is a misbelief that equating serotype coverage with protection. So when I say that there is a serotype protection given to the tune of 78%, 62%, and there is a difference of 8 to 10% between the PCV13 and the rest of the, or in fact the new PCV10 and the old PCV10, it is nothing but the mathematical sum of percentage of disease contributed by all serotypes. So the moment you will have more serotypes in the vaccine, you will have the mathematical sum going up and giving the advantage. But then there is a misbelief that every vaccine serotype constituent is 100% protective. No, all of us know serotype 3. What happens? Why is it different? Because it is a capsular polysaccharide which gives the pneumococci an advantage. The virulence of the pneumococci is because of that capsule. This serotype 3, there is a phenotypic characteristic difference between all these different serotypes. And this particular capsule of serotype 3 is not very greatly covalently bound to the cell wall. It gets easily shed off. And that's why even if you create antibodies against this serotype 3, they're actually not, the attachment is actually not taking place. So even if you constitute the serotype 3 is there, that does not mean it will relate into the protection against serotype 3. And the second misbelief is the cross protection does not happen. Now, very fact we understood that the original PCV7-6B also gave protection against 6A. And in fact, it was realized by Pfizer before they launched PCV13 that actually 6B was giving them protection. How much? To the tune of almost 70%. In fact, that 6B also gave protection against 6C. Not great, maybe 22%. But then if the vaccine had 6A, now it is a new fact which is known, and the emerging strain is 6C, it is considered that 6A constituent vaccine can cross-protect against 6C to the tune of 96%. That's huge. The point is, whatever you may say, there is a definite evidence that there is some degree of cross protection. And the second fact is serotype 19A, which is talked about because highly microbial resistant. The 19F constituent also gives protection. So whenever a 19A serotype containing vaccine is administered, obviously your IgG and OPA titers are going to be much better than the indirect protection. That's understood. But if the protection is equal enough or enough to give you a clinical protection, a real world difference, what is the difference does it make? So that is how we have understood that there is something called as cross protection. In fact, the very first vaccine that was invented, which was a smallpox vaccine, had cowpox, which gave us cross protection against smallpox. Tuberculosis, what we are giving, BCG, has Mycobacterium bovis, and we are protecting not only against tuberculosis, but lepre also. And then HPV also, we only have 16, 18. But then we know that there are many other serotypes which are also cancer causing, but we are considering that it is protection, giving some protection. And finally, Rota, everybody knows, even if it is a monocomponent, it is giving us a broad protection. So it is not it's a fact that immune response against non-vaccine serotypes also happens even if the serotype is not a constituent of that vaccine. And this was shown in the study which was done in Sweden, Canada, New Zealand, Morocco. These are 4 different countries. One belongs to Europe, one in American continent, one Far East, and one African. And you can see the difference. And exactly same thing happens in India. The difference could be 17 to 20 or 21%. But in real world overall protection is IPD. So basically all these PCV vaccines are good enough to give you real world protection. Now talking about serotype 3, which is an advantage only to PCV13. Mind you, only Pfizer has it, nobody else. And we always thought, I also told you that it is not covalently bound to the cell wall, so actually not a great response. But now this is a new study which has come up, which is a meta-analysis case control studies with high quality methodological study. And what does it show? Look at the studies done in England, USA, Germany, and Spain. The overall serotype 3 IPD vaccine effectiveness, if the vaccine has serotype 3 in it, it's 63.5. Not bad, isn't it? So that's why we should know that the science is evolving, it's dynamic, and we must take into cognizance the newer evidence which comes. So this definitely is an advantage. So if a country or a situation is there where the serotype 3 is more prevalent, you must have it. If it is not, probably it is not justified to have it. And this is a WHO commentary, and Sage also said that evidence does not conclude that current PCVs have a consistent or substantial impact, because this was based on the 7 country studies, which was basically almost all were US or American countries. And they felt that because of the some typical characteristic, which I mentioned before, serotype 3 does not have much response. And as we say in India, we do not have much of serotype 3 prevalence. So it is fine that the vaccine, which is over here, does not have serotype 3. But what are the other things? Now let's concentrate only on the upper 5 serotypes. 3 I already talked about. Remember, if it is there, it causes necrotizing pneumonia empyema. So if there is a prevalence, so point is you should continuously have serosurveillance. So even if the vaccine is introduced in the market, you should have surveillance and you should keep changing your policies. New Zealand is a wonderful example. So they started off with PCV 7, then started off 10, they went to 13, and they understood that 13 was not giving great advantage to them. They switched back to PCV 10. So this is because the serosurveillance continues to happen. Now let's come to 4 and 18C. These two are important to understand at outbreak serotypes. And 6A and 19A are important apart from the routine diseases, resistance to antibiotics. So it is important to have them in the vaccine, these two serotypes, 6A and 19A, if the prevalence of 6A and 19A is important. Because as I said, there is some cross protection from 6B to 6A, and there is some cross protection from 19B to 19F to 19A. So serotype 4, as I said, the outbreak serotypes are infrequently isolated. It becomes the problem of serotype 4 is it is a very brief duration of colonization. That's the problem. And it survives better outside in the environment. And that's why these outbreaks. So if we do not want to have any outbreaks, we better have serotype 4. And if we do not have such worries, we need not have serotype 4. So it's an outbreak serotype which is responsible for serious pneumococcal disease in a closed setting in most of the post-antibiotic era. So that is what is the importance of 4. And 18C also comes in the same, I would talk about it in the same breath, that this is responsible for epidemic cycles. So if you have prevalence, then high case fatality, responsible for prolonged hospitalization, all these problems. And mind you, the new vaccines which are coming up in pipeline, the PCV 15, the PCV 20, they all have these serotypes. We are just deliberating theoretically whether everything boils down to this 4, 18C, 6A, 19A, 3, whether should be there, this vaccine has it, this vaccine does not have, cross protection, direct protection, indirect protection. It's actually, we are talking theoretically. In practice, real world data does not say that every time it is important, because most of these newer vaccines will have all these vaccines. But remember, the more the constituents of serotype, probably it will have some disadvantages in the immunogenicity. And this is, I think, the most important slide of my presentation. I would say this is an invasive pneumococcal disease serotype surveillance, which was done in CMC Vellore. Dr. Balaji has done this study, and 12 years, that's a huge period which was followed up. And let us see what happens in our country. So apart from all these 14, 19, 14 is the commonest, 19A, 6B, 5. Look at this, 6A is significant, 19A, significant, 18C, significant, but 4 is not there, and 3 I do not see. I've just put the top 13 out of it. There, the list goes on more, but I just wanted to concentrate and draw your attention to the first 13. So you can see the vaccine that needs to be there in India should have a 16A, so should have protection against 19A, should have protection against 18C, and should have protection against 4 also. So importance of broad serotype coverage, because developing country, epidemiology is also different. We have 1 and 5, which is a more problem. Age-wise, it is pediatric 1, 5, 7F. Older children, different serotypes. Invasive disease, again 1, 3, 4, 5, 7F. For pneumonia, it is 1 and 3. For carriage, other serotypes. And for meningitis, invasive lung disease in India, 1 has to be there. So this is the importance when you are formulating a final configuration of the vaccine which is to be introduced. So now the last part is about otitis media coverage. This is also claimed by Synflorix manufacturing GSK, and it was basically based on initially the 11-valent vaccine which they had introduced, and the POET trial which was done in Czech Republic, of course, gave a all-cause otitis media coverage of 35%. But then when the PCV10 came into market, they did a study, and which was a COMPASS trial, which reduced it to almost 16%, and they never talked about it. But later on, what has happened is Sweden is one country where they could study the comparison of Synflorix and PCV13 because it has 21 counties and 11 of them took one, the 10 of them took other. So they could compare. Otherwise, there is no head-to-head comparison. And the counties which were using Synflorix, there was a 25% reduction in otitis media. But actually, this is just based on the carrier protein. And my aim of that pneumococcal vaccine should be the reduction of streptococcal pneumonia. And this is also, they have substantiated. Brazil was significant, 43%. Chile, Ireland, New Zealand, Peru, everywhere to the tune of 25 to 43%, there was some reduction. And now finally, let's also, these are the advantages of, I talked about Prevnar, I talked about Synflorix, and finally Pneumosil, excellent vaccine, extensively evaluated 5 RCTs, comparable safety and immunogenicity against licensed pneumococcal vaccine across diverse population in India and Africa, given to adults, toddlers, infants using different vaccination schedules. And they have compared with old PCV10, of course, with PCV13, both primary as well as booster. And now whenever you want to launch a vaccine, you not just need to show non-inferiority. You did not show superiority of your vaccine. You should be non-inferior. The shared serotype, when it happened with comparison with PCV10, it was higher for 5 serotypes, and 19A was higher with Synflorix. But however, 6A, 19A, though I said that cross protection comes from Synflorix, obviously the serotype titers were more because it was a direct constituent of new PCV10. So finally, what is this OPA and IgG? A little bit of theory. What is important to understand, IgG titers are, there is no correlate of protection for pneumococcal disease, but they consider that if it is more than 0.35 microgram per ml for all serotypes constituents, then it is given a permission to launch this vaccine. It will just give you memory cells and associated protection, and OPA titers, which is actually a functional protection. It gives you a direct protection. So this is a functional humoral protection. So both these titers are measured. Though OPA titers do not give that advantage of being marketed, but then otherwise it is also important to have it. But finally, if you can see comparison, if I do IgG and OPA comparison of Pneumosil versus Prevnar, the new PCV serotypes, 4 serotypes it was missing, and then OPA 3 serotypes was missing in comparison to PCV13. But finally, when the OPA titers and IgG are matched, the difference gets narrower. So what is important is it qualifies. So that's why WHO has made it a pre-qualified vaccine. So because it qualifies the criteria passing mark, but that does not mean that certain high IgG titers will give you a better and longer protection, and a lower IgG titer does not give you a longer or better protection. So ongoing, this is most interesting. The last third one, the post-licensure assessment, because otherwise exciting vaccine which is there, but I want to know about this carriage. If it is going to affect it is going to reduce the nasopharyngeal carriage of pneumococci, nothing like it. So this is a proposed study which is going to be done in India, Indonesia, and Vietnam. And we should wait for these results to come out, because then it will have definitely a herd effect. So which will be great advantage even to our older population. So
last few minutes, sir.
Recommendation, DCGI has approved, WHO has said till 2 years, ACVIP follows WHO recommendations, so 3+1 schedule, and then no studies in 2 to 5. So product switching, all of us know, actually theoretically not recommended, so one should not. In fact, this new PCV10 also does not have these studies done. Recommended schedules, all of us know, 3+0, 2+1, 3+1, each has its advantage, disadvantage, but 3+1 is for your private practice for individual protection, and 3+0, 2+1 is basically should be in the government schedules. But real world, this is another advantage of Synflorix with the Kenyan study which showed that vaccinated children under 5 years, those who are given vaccine will always have an advantage. But look at this unvaccinated older children, 53, 51, 69% reduction. That's a huge advantage. So this is a wonderfully, both these Synflorix and Prevnar are well studied, and we must give some time to Pneumosil to establish itself. Immunogenicity, safety, excellent, but let it also come out with more studies. Obviously, we have to wait for that. And finally, I would just, before ending, talk about this indirect effect, which I talked about. And this is important. And when does this indirect effect start? This Kenyan study also showed it takes 10 years, friends. So for a vaccine to establish and successfully run in a government program for 10 years, you will have reduction to the tune of 90%. So these indirect effects are important. Second, this paper I just read yesterday, which was published 2 days ago, immunogenicity of alternate schedule. Look at this, what they did in Vietnam. Last D, do 2 and 6. So only 2 doses were given and followed up for 2 years. And they found that 2-dose primary series was not inferior to 3-dose primary vaccination. So that's very important whenever a government makes a policy. Imagine 2 doses can also give a wonderful result instead of 2+1. And finally, look at this. This is the last slide I want to talk to you and leave you with a wonderful thought. What happens when a national program is successful? Let's not deliberate much about the serotypes and this and that, direct cross protection. Look at this. For babies born in UK after 1st January 2020, the PCV is given only 2 doses, one at 12 weeks followed by booster at 12 to 13 months. Isn't it huge cost saving? This change is because of successful pneumococcal vaccination program. High uptake of PCV has resulted in very low level of disease caused by pneumococcal bacteria, and their own ACVIP suggested 1 dose of vaccine plus the booster should continue to provide good protection for children. So rather than getting into the theoretical discussions about protection, let's start using it in the national program, recommend and encourage each of our patients, if they can afford in our practice, they should take whatever is affordable. We always counsel to patients depending on their socioeconomic condition. And if not, they better take it in the government programs, because even from tomorrow it is getting launched in Orissa. So I think state by state, everywhere this vaccine will be launched. And I'm sure within a couple of years, we'll have great success stories. And we may also have only 1 or 2 doses of pneumococcal conjugate vaccine given in our vaccination program. Thank you. Thank you very much.
Thank you, Dr. Upendra, for a wonderful talk as usual. For the next sessions, I'll ask Dr. Sushruta to continue for the next session. Dr. Sushruta.
Sushruta, you're not audible. No, we are not able to hear you.
I think I'll start off. There's a guest lecture for the next session. That is Advances in Vaccine Development. The faculty for this lecture is Dr. Raju Shah, and the chairperson is Dr. Kirit Sisodia. Let me introduce them. Just share my screen. Yeah. So about Dr. Raju Shah, he's a medical director at Ankur Institute of Child Health, Ahmedabad. As a former professor and head Department of Pediatrics at GS Medical College, Ahmedabad. He was the national president of IAP in the year 2005, president for Pediatric Association of SARC in 2005 to 2008, chairman Committee on Immunization IAP for 2005 and 6, and chairman of Infectious Disease Chapter IAP for year 2003 and 4. Areas of interest for Dr. Shah is infectious disease and vaccinology. Special achievement, he has received Dr. Shantilal Seth Oration Award in the year 2015. Honorary FRCPH member. He is editor-in-chief for IAP textbook of Tropical Pediatrics, and more than 50 publications in his name. Chairperson for us in this session is Dr. Sisodia, who is the president of Surat Pediatrics Association in the present year 2021. He is a co-opted member for IAP ID chapter and HOD and for the Department of Pediatrics at BAPS PS Hospital in Surat. His areas of interest is infectious disease, vaccinology, and adolescent medicine. He is also an organizing secretary. He was organizing secretary for West Zone Pedicon in 2019, organizing secretary for GIP Con in 2016 and 2011. Faculty at Pedicon and state conferences. So to proceed for the session, I request Dr. Sisodia to take over.
Hello, I'm audible now, right?
Yeah.
Thank
you, Dr. Sandesh, for a kind introduction. So we already got the introduction of Dr. Raju Shah, sir. So our next topic is advances in vaccine development. So discovery of vaccine had led to near eradication of several important diseases and has a tremendous impact on the health and economy of the society. That obviously we had seen in last 1.5 years. So this is the one of the fastest vaccine which has developed in the current era, or any vaccine since the development of any vaccine. So for the development of vaccine, wide range of technology has been used in developing a successful vaccine. And to elaborate this topic, we have with us none other than our one of the past IAP president and Dr. Raju Shisa sir. So it's over to you, Dr. Raju Shisa sir.
Hello. Good afternoon, friends. Am I audible?
Yes,
Yes, sir. Yes, sir.
Yeah, good afternoon, friends. Dr. Natu, Dr. Sandesh, Dr. Kirit, and Dr. Samir. It's indeed a great pleasure sharing my views on a very important topic of newer advances into the vaccines. Well, friends, we all sorry. Well, friends, as very rightly mentioned, that last I don't know what is happening. Am I audible?
Yes, sir.
Yeah. So last few months, if you have seen, the things have changed. That when we were talking about some new epidemic or a disease, and we were always looking for a vaccine, and it was taking such a long time. Fortunately, for the pandemic that we have faced, within a short time of 10 or 11 months after getting the genome of a organism, we got multiple vaccines. Now, this is something which has come a totally new. And that is why, long back, when Dr. Gregory Poland observed about the different inventions, he remarked that we are now entering a second golden age of vaccinology with the enhanced understanding of common diseases, vaccine development against chronic non-infectious diseases, and in better integration advances in biology, genomics, immunology, molecular biology, and virology. And with this, we entered a new generation. And what was the things that were happening during the previous pandemic in 2009, that people were waiting for the vaccine for a long time, and such a cartoons were appearing everywhere that, people became elderly waiting for the vaccine. No doubt in India, we are again almost like that because we are not getting the vaccine. But world over, there is a change and people got the vaccine. And in a country like USA, almost 70% of the population has received the vaccines. So why we need the advancement in vaccines? What are the reasons? We all know that till now, the conventional vaccines which are available, they were mainly developed by attenuating or inactivating the pathogens, or some of them we had protein-based vaccine also. So with that, we could reduce the burden of infectious disease, but they are not always suitable for the outbreak situations and also for many other chronic infections. Not only that, certain live attenuated vaccines are also bearing the risk of reversion, like polio vaccine. And, because of that, if there is a very highly pathogenic organisms, we are all worried and we probably may not rely on such processes. Similarly, we also know that inactivation may not induce protective responses. As in the research, they found that Ebola tried to use inactivation technology and they failed. And sometimes the inactivation may lead to some undesired effects, like what happened in the RSV vaccine, that it induced exacerbated disease upon wild type RSV infection in clinical trial. So there were so many limitations, and that is why we needed the advancement so as we can have a better vaccines. And when we face the pandemics like swine flu and COVID-19, we realize that there is a urgent need of vaccines for the outbreak situations. We also know by now that there is not enough effective vaccines available or getting turned out for diseases like malaria, TB, AIDS. We also need, even for the existing diseases and vaccines, more effective, more potent, more stable and low cost vaccines. There are almost all the vaccines leading to some adverse reactions or effects. Just now we heard Dr. Kang telling us that we need to do monitoring for that. So we need certain vaccines which are minimal or almost no adverse reactions. So we don't need such surveillance. The compliance is always an issue with almost all the vaccines. So we need a vaccine which has a good compliance. And for that, new delivery techniques can help us. And we want to protect ourselves against more diseases and sustain protection that we need so as it could be a lifelong protection. We heard Dr. Abhay Shah telling us about the emerging and re-emerging diseases, and we need to protect ourselves against those. And not only that, newer technology is helping us in the vaccines against non-infectious like cancers and lifestyle diseases. So these are the reasons why we need the newer techniques. Outbreak scenarios needs a special mentions because these are the areas where the conventional vaccine development doesn't help. We need very highly versatile approaches for this, and because the time period is the most important and a major hurdle when we are facing such outbreaks. So here, not only it is the requirement of a vaccine, but such pathogens, we need a very high biosafety level also. And so specialized labs for cultivation will be needed if we are going with the conventional types of vaccines. And the production capacities of the conventional vaccines are so low that probably if we go with these type of methods in outbreak scenarios, we cannot match and the world cannot get, or the population of the world cannot get the vaccines. Fortunately, this COVID-19 has given a real push to the newer research related to vaccines because of the urgent need. And whatever inventions during last 10 years for different type of newer technologies, all the different research labs and companies started using, and with the help of this amazing toolbox, they came out with various different type of the vaccines. Not only that, a pan-virus vaccine like a brass ring in vaccine development has been, which was elusive for many infectious diseases, has also come out, and probably that can help us in certain diseases like influenza and HIV, which is we are waiting for almost 2 decades or so. So what is this new technology that has been applied in SARS-CoV vaccine? The old technology like recombinant protein vaccine in a new form has been used, and newer technology, that is the genetic vaccines or nucleoprotein vaccines like DNA and RNA vaccines, virus-like nanoparticle vaccines, viral vector vaccines, and also age-old whole virus or inactivated virus vaccines are also been approached for this SARS vaccine. If you look at the history, in the last decade, almost more than 500 newer vaccines or technologies are tried, and Big Pharma's pipeline has newer vaccines for many different conditions. This I am talking before the COVID era in 2016 and 17. But the available technology that we have now are in the whole inactivated or live attenuated vaccine, synthetic peptide, recombinant subunit, recombinant viral vector, recombinant bacterial vectors, and recently added is a DNA. So this is all advancement has happened because of there is advancement in genomics, immunology, and molecular biology in the last decade. So what are these newer technologies? They are the vaccines will be based on nucleic acid, viral vector based, peptide or protein based, reverse vaccinology, transgenic plant vaccines, sugar glass vaccines, skin patch vaccines, and immunomodulation delivery. So these are the new 8 different types of vaccine technologies that has been developed recently. Nucleic acid vaccines are both RNA and DNA. They are very important because they trigger an immune response, and our cells protein factories make the antigen that will trigger an immune response in turn when we are using this technology. There are, in a DNA vaccine, what happens that with the process of electroporation, we bring out the DNA, and then that DNA, naked DNA, or with some other material, we are introducing it to the cell, and these cells then convert it into mRNA, and then we have the antigens which are entering into the immune system and giving the antibodies. As against that, in RNA, the RNA along with some other lipid coat or something, nanoparticles, lipid nanoparticles are injected into the body. They get out from that lipid coat and remain as mRNA, change themselves as like what viral proteins genome they have, and then it stimulates the immune system and we have antibodies. So the DNA vaccines, they are consisting of plasmids. These plasmids are taken out from certain bacteria like E. coli, and then the foreign genes of a antigen is introduced into that genome, and then it is introduced into the body. So what is the advantage of DNA vaccines? They are safe and very low risk. There is a broad range of immune response like T cell and B cell both. Antigen confirmation becomes normal and identifiable. There are no injection site reactions. There is a long duration of immunity, simple, cheap to produce. There are multiple vaccines can be administered simultaneously with DNA vaccines. Even neonatal immunization can be done because maternal antibodies cannot destroy this DNA, and we can use various delivery methods for vaccinating with the DNA vaccine. By now, about 40 DNA vaccines against 30 different conditions are under progress. Out of that, 6 vaccines like against COVID-19, hepatitis B, herpes simplex, HIV, influenza, and malaria are in the human trials. And many other viruses, bacteria, fungi, and parasites, they are under animal model trials, that is phase 1 trial going on. For this delivery system, a special delivery is also tried, that is a gene gun delivery, where plasmid DNA is introduced into good particles, and they are, from a distance, they shoot this gun and you get the DNA vaccine. As against that, RNA vaccines are, they are containing RNA part only, which when introduced into the tissue acts as a messenger RNA. There are 2 types of RNA vaccines which are been tried. One is a non-replicating mRNA, and second is the self-amplifying mRNA vaccines. Non-replicating mRNA vaccines are obtained by in vitro transcription of the cell DNA template, typically plasmid DNA produced in E. coli, while self-amplifying RNA vaccines are commonly based on the alpha virus genome from which the genes encoding the structural protein have been replaced. Any genetic information encoded by will be amplified many times, resulting in a high levels of antigen expression from relatively low doses of the vaccine. And that is how this is a very important part, and which appeals the most because there is a very high level of antibody production because of this method. The self-amplifying RNA vaccines are usually delivered with the synthetic delivery particles. They are either lipid or polymer-based nanoparticles. They are very small. Or sometimes, alternatively, they are also delivered with virus-like replication particles, which we abbreviate as VRPs, and that is how we introduce this vaccine into the body. The advantages of RNA vaccine is that it can again induce both humoral and cellular immune responses. Production process is very short and does not require amplification in bacteria or cell cultures, and it offers a flexible one for all large scale, rapid and cost effective manufacturing process with fast turnaround time. The pathogens which are targeted are, again, we all know that we have already available mRNA vaccine for the COVID-19, that is from Pfizer and Moderna both. Similarly, there are already the phase 2 or 3 trials going on for the Zika virus, Ebola virus, influenza virus, chikungunya, Lassa virus, and HIV-1 also. So these vaccines induce the functional antibody titers at levels associated with protection with acceptable tolerability profiles, and that is why they are very much useful. So that is the nucleoprotein vaccines. There is another group is a viral vector vaccines. Here the viral vectors can be replicating vector or non-replicating viral vector. Both can be used. The viral vector vaccines work by giving cells genetic instruction to produce the antigens. It uses a harmless virus. Most commonly used viruses as a vector are adenoviruses, measles viruses, and the vesicular stomatitis virus. These are the 3 common, but there are many more also tried at present. The adenovirus is the most commonly employed viral vector. There are both types of viruses are there. Replication deficient virus is the AD5 virus. This is the most commonly used adenovirus vector. But this virus is a already virus infecting the human beings. So there is a pre-existing immunity in the human beings. And that is why there is a possibility that the when we introduce this as a vaccine, they are getting inactivated. And so newer alternative is that we have started using the chimpanzee virus derived vector, which is a ChAd63 virus. Alternatively, a low prevalence type of human adenovirus like AD26 and AD35 are used. And we all know these are used in different type of COVID vaccines at present. Other viral vectors are measles, which is can give T-cell mediated response, as the measles is a very fast replicating virus, and that is why it is used. And another is the vesicular stomatitis virus, because there is a low risk of pre-existing immunity, and it induces a robust antigen-specific neutralizing antibody, and that is why these are also tried for different other things. The advantages of viral vector vaccines are they are very valuable and highly versatile platform. They give a very strong antigen-specific cellular and humoral immune responses against the target antigens. And we all know about these COVID-19 vaccines, that is the AstraZeneca or the Covishield that we are already using. Johnson & Johnson developed AD26-2S vaccine, as well as the from Russia, we have a Sputnik V, which is GAM COVID vaccine. So all 3 are based on adenovirus. Even dengue virus, that Dengvaxia, which is licensed, is also based on this vector virus. And there are already phase 3 trials going on for the Ebola and HIV, which are also vector-based vaccines. Another one is peptide or protein-based vaccines. They are made only from the target amino acid proteins. They are the fragments of the target amino acid proteins. They take advantage of the ability of computer algorithms to screen protein amino acid sequences for peptide epitopes. And these, they are delivered with virus vectors in combination with immune stimulating molecules like adjuvants to the body. And that is why we have excellent amount of antibodies produced against that. They use the range of vehicle deliveries mainly inducing the recombinant bacterial and viral vectors. They also use virus-like particles, and they also work like same. So what we call is the VLPs, and we have used the vaccine like HPV vaccines with the use of these viral-like particles. Another method that has been tried is the reverse vaccinology. So here, yeah, it is a genes most likely corresponding to the conserved antigens, and classical example of this reverse vaccinology is group B meningococcal vaccines. Then another very important and very interesting method is a transgenic plant vaccines. Here there is a concept of expressing the viral epitopes and subunits of bacterial toxins in transgenic plants. The plants initially tried were tobacco and petnuia, and now edible parts of plants are used. And some of the foods which are under study for transgenic plant vaccines are bananas, potatoes, tomatoes, as well as rice, lettuce, wheat, and soybeans. This is a very convenient and efficient way to obtain HIV vaccine also. So nowadays there is a lots of interest, and almost phase 1 trials are going on. And with this, the day is not far off when children will be, munching the foods instead of taking the vaccine shots, and they will get protection against these diseases. The another newer technology is sugar glass, the vaccines, where what they are using is saturated solution of trehalose. When on cooling, they become like a sugar glass, and here the they put the vaccines into it, and when a child takes it into the mouth, there is a this trehalose gets dissolved and the vaccine gets entry into the body, and that is how it can be used. There is no need of storing it into the deep freezer, etc., and they can be used. And so many vaccines, agents like pertussis, measles, influenza are used for that. Then newer delivery for vaccines like skin patch. They are the superficial layers of skin which are used for that. This technology appears to target highly accessible antigen potential cells in the skin, that is dendritic cells. They are the needle-free administration. They can be also given orally also. There are transcutaneous liquid jet injections and epidermal powder immunization, microneedle-based injection system also. So these are the newer delivery system where you may not need the real jabs or the injections. Then there is a immunomodulation of the delivery also. With the cytokines and new adjuvants, this method can be used. They use immunomodulators for developing this vaccine, and for chronic infections like hepatitis B, this technology are used for developing therapeutic vaccines. There are newer methods which are tried for the combination of different viruses, that is metapan virus vaccines, like for influenza and coronaviruses, where all different types of viruses can be combined into one, and pan influenza or pan coronavirus vaccines can be prepared. Even there are methods to develop the needle-free type of next generation vaccines, and 7 non-injectable vaccines are in development for that. And there is also Swiss and swallow type of oral pill-based vaccines are also under development, especially for the COVID. So there are certain targeted areas of vaccine development, and they are trying in all different areas, not only the infections, but even for the non-infectious diseases. There are 124 infectious diseases, including MDR infection organisms are tried for that. There are 105 vaccines for cancers, 13 for allergies, 8 for neurological diseases, and 7 for other conditions are under trial for this. These are the different type of the infectious diseases where no vaccines are available. There are already phase 2 trials are going on. These are the names of different viruses or the organism under which phase 3 trials are going on. There are also vaccines development against the multi-drug resistant type of organisms like Candida, Clostridium difficile, E. coli, Group B Streptococcus, Pseudomonas, like that, and probably that will be a very, very useful vaccines if they are come out. Not only the protective vaccines, there are also advancement in therapeutic range also, and certain therapeutic vaccines for cancers, infectious diseases, as well as chronic and other conditions like Alzheimer's disease, allergy, diabetes, and other different diseases are also under phase 2 and trials or so, and they will be really a new approach and real helpful to the society at large. So to summarize, technological advances in vaccinology is giving results. We have seen the classical example in COVID-19. The developmental process for vaccines is unique. It is long, highly the capacity intensive and risky. There are more than 120 vaccine candidates in the pipeline. that can improve the global health and reduce infectious and the neglected tropical disease burden. It will add new technologies in the categories with existing vaccines, prevent diseases that were previously not vaccine preventable. It reduces the drug-resistant infections and slow the growth of resistance. We all know that it's a long process and less than 1 agent out of 10 vaccine agents achieve the licensures. Fortunately, more than 11 vaccines for different infectious diseases are in phase 3 trial or they are already applied for the licensures, and more than 48 vaccines are in phase 2. And it is because of this COVID, there is a prolongation. Otherwise, within 2 or 3 years, we'll have vaccines for all these. So with so many newer technologies, vaccinology has a very, very bright future, and probably the human being as facing so many newer targets or newer diseases with these newer technology probably will be much better off, and next generation or next era could be just a vaccination era rather than what we had as an antibiotic era, our previous era. Thank you, friends, for the patient hearing. If any questions, it will be my pleasure to answer them. Thank you so much.
Thank you, sir, for such a nice and elaborating lecture. As in the current COVID era, we had seen the problems with the current available vaccines like injections by trained nurses, vaccine transportation and storage, and poor intake in the fear of side effect, cost of the vaccine, and slower production, which might be overcome with the newer development of vaccine with the newer technology as sir described. And there are lots of vaccines in the pipeline which might come up or land us soon with us. So thank you, sir. Thank you, organizer, also, so providing us the platform.
Thank you, Dr. Shah, for a wonderful talk. I hope I'm audible now. Yes?
Yeah, ma'am.
Okay. Moving ahead to the next session, we have a symposium on diagnostic updates in pediatric infectious disease. Actually, we were supposed to have 3 such symposia, but because of some technical reasons, Dr. Chandani will not be able to join us. So, Dr. Prabhu and Dr. Sonali Sangvi will have 5 extra minutes. So, today's panelists, the lead discussants would be Dr. Neeli Ramchandran and Dr. Shirish Kankaria. We have 2 symposia today, one on molecular diagnostics by Dr. Sonali Sangvi and the other one on TB diagnosis by Dr. Suhas Prabhu. I'll just share the screen. Hello. Yes, I guess I have some technical problem. It's not possible to share. Sheetal, can you help out? I'll just read out the series. Dr. Neeli Ramchandran is a consultant pediatrician at Kavita Children's Hospital.
Hello.
Yes, Malak, I can see the
sharing.
Yeah, will you please share the slides? Thank you. Dr. Neeli Ramchandran is a consultant pediatrician at Telangana. His areas of interest being infectious diseases, adolescent medicine, and vaccinology. He was the National Vice President of Central IAP in 2014, Founder President of Telangana Pediatric Body 2016, and as recipient of Gold Medal from Governors of Andhra Pradesh and Telangana several times for Red Cross services. Next one, please. Dr. Shirish Kankaria is a senior practicing pediatrician at Shishu Moha Clinic, Pune, Inamdar Hospital, Pune, and at present is the treasurer of IAP Pune. Next one. Dr. Sonali Sangvi, which is the MD Microbiology and PhD from USA, and Associate Consultant Microbiologist at KM Hospital, Pune. Areas of interest are clinical microbiology, molecular biology, translational research. She has 13 international and 5 national publications to her credit and a book chapter in ASM Press. Last but not the least, Dr. Suhas B. Prabhu is a consultant pediatrician at PD Hinduja Hospitals, Mahim, Mumbai. His areas of interest being general pediatrics, infectious diseases, immunization, and medical records and audit. He is a member of IAP COI in 2011 and 12. He is a co-editor of textbook on rational antibiotic practices and written chapters in several books in the antibiotic section. He is chairperson, Government of Maharashtra Task Force for tackling third wave of COVID in children. So handing over to Dr. Neeli Ramchandra, we will proceed to the first symposium on molecular diagnosis by Dr. Sonali Sanghvi.
Thank you, madam. Thanks for a nice introduction. I have got a lot of affinity for Pune. Last time I was there for the midterm conference of ID chapter Pune. Very nice city. Molecular diagnostics are transforming medicine with more than 3 billion market with a 20% increment every year. And to face the near future, the practitioners must understand the molecular biology first, and they should be ready to embrace this technology to go ahead with the future generations. Dr. Sonali Sanghvi, please proceed further.
Okay. Okay, so am I audible and are the slides visible?
Yes, Dr. Sonali, you are audible with very clarity.
Right, thank you. So my focus of today's talk is recent advances in molecular diagnostics. So as we all know, the molecular methodologies give faster results. They are highly sensitive and highly specific in correct hands. So what are the recent advances in molecular diagnostics? They're mostly in two areas. One is we have moved on from manual processing to simplified automated processes, which requires very minimal hands-on sample preparation time. And the other area of advancement is the single plex. We have broadened our range of detection and moved on from single target detection to multiple target detections, and now in fact to universal pathogen detection, irrespective of the type of microorganisms. So as we know, the genetic information in a cell moves from DNA to RNA to protein. The molecular assays that target DNA and RNA come under genomics, and those that target proteins come under proteomics. And these are the few assays that we are going to be talking about today. So coming to the first real-time PCR, commonly known as RT-PCR, it's so called because we can monitor the amplification in real time. It uses fluorescent label probes, because of which we get enhanced specificity in the assay. It's commonly used to detect difficult to grow organisms or pathogens such as viruses. The assays are available are either qualitative, which give positive or negative results, or quantitative, which is done mostly in blood samples to monitor viral loads over time. Examples are, as we all know, is HIV, HBV, HCV, CMV, EBV. So the increasing or decreasing trend of viral loads is used to guide treatment protocols. One such example of quantitative PCR is a study that we had done almost 15 years back. Here we had looked at we had done a longitudinal study of CME viral load over time in solid organ transplant recipients and compared it with CMV PP65 antigen levels and other hematological parameters. So as these graphs show that the CMV viral load and the antigen level move almost together. The viral loads are much higher than compared to the antigen levels. And in new patients, we had seen that the CME PCR was positive at least a week earlier. The PP65 antigen level became positive and persisted for a longer time. But what are the gaps of these assays? Since these are single target detections, it requires strong clinical suspicion of that specific infection. It does not differentiate between active infection and latent or persisting nucleic acid from past infection. And standardization of quantitative assays between laboratories is difficult, but this is now being streamlined by laboratories using WHO standards. So now multiplex syndromic panels, these are becoming very popular recently. And multiplex panels are available for almost every system, such as the gastrointestinal system, the respiratory system, CNS, blood. Again, there are automated walkaway platforms such as the film array BioFire syndromic panels, the Gene Expert, which offers MTB-RIF detection, as well as there is an upcoming XDR panel. And there are certain RT-PCR multiplex kits which are also available. To give an example of the range of organisms that are included in these panels, this is the pneumonia panel. It includes bacteria, gram-positive, gram-negative bacteria, atypical bacteria, viruses, and the antimicrobial resistance genes. So this is the pneumonia panel. Similarly, bloodstream infection panels includes gram-negative bacteria, gram-positive bacteria, yeast, and antimicrobial resistance genes. Meningoencephalitis panel, gastrointestinal panel, and the bone and joint infection panel. So because of this wide range of organisms that can be detected, faster turnaround time, there is no prior clinical suspicion of a specified pathogen is not required for this, as a vast range of organisms can be detected in a single test. So a positive result will enable target-specific treatment to be started earlier. So hence the decrease in empirical therapy. Simplified and automated platforms are available. So technical expertise is not a requirement. So what are the drawbacks of these assays? Multiplex PCRs, usually multiple organisms can be positive in a single test, which can lead to confusion in the diagnosis. And the cost of each of these panels is extremely high. In addition, there is also a question about false positive results. And there is one such report from a Stanford group where they have highlighted a false positive report by the film array syndromic PCR assay. Here in this, there was a 75-year-old Vietnamese patient with gradual onset confusion and speech difficulties, known case of follicular carcinoma, MRI, no significant findings, CSF showed neutrophilic predominant, glucose 67 and high protein. CSF fluid was positive by the film array for HSV1. Acyclovir was started, patient continued to deteriorate, and then repeat CSF PCR for HSV1 vis-a-vis CMV all negative. However, TB PCR came out to be positive, as well as the culture for TB was also positive. So these people highlight the low positive predictive value of some of the organisms in this panel. So as you can see, Streptococcus pneumoniae, E. coli, HSV1, these have a very low positive predictive value of almost between 50 to 60%. So that is something that has to be kept in mind, and any doubt in the report, it's always better to repeat the test. So can molecular techniques be applied to blood culture for bloodstream infection, for detection of bloodstream infection? The traditional blood culture, as we all know, the blood culture bottle, when it flags positive, we do a gram stain, and based on the gram stain, a preliminary report is given. And after that, it takes about 24 to 48 hours for the final report with the identification and sensitivity to be ready. So if molecular techniques are to be applied, it can be applied in two ways. One is directly to the positive blood culture bottle sample. So the sample from blood culture, positive culture, is taken in, is amplified. If the smear shows gram-positive cocci, then you can use a Gene Expert Staphylococcus cartridge. or if you want a wide range of organisms to be detected, then you can always go for a film array biofire panel, bacteremia panel, that offers gram-positive, gram-negative candida as well as antibiotic resistance genes. So if you see if blood culture, if this amplification tests are added to positive blood culture bottles, the identification time is shortened 2 hours after the blood culture bottle comes positive. The other way is direct sampling of whole blood for PCR. So there is only one system that is FDA and CE approved for direct from blood testing for bloodstream infections, and that is the T2 biosystems. In this, the whole blood, about 4 ml of whole blood is collected, loaded onto the instrument, and you get a report within 3 to 5 hours. Which organisms are covered here? Here they have included the escape group of organisms, which is Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, and E. coli, along with Candida albicans panel. Recently, they have added the Candida auris, which is still under research use only, and as well as in development is the antibiotic resistance gene markers. So if this we were to use this, you'll get results within hours after collecting the samples. So it's definitely very faster results. However, the limitations of this test are there is questionable sensitivity in detection of a pathogen in blood culture versus direct whole blood sample. Also, there can be specificity issues, such as depending on how the sample is collected, amplification of skin contaminants can give false positive results. Missing are the Salmonella, Streptococcus pneumoniae, or other community-acquired infections in this panel. And the cost of each of this panel is very high. And lastly, it's still not available in India. Coming to next generation sequencing, this allows for millions of sequence data output. It can be divided into 3 parts. One is the whole genome sequencing, where you can use an isolate, and this is usually used for epidemiological studies or identifying the antimicrobial resistance genes in an organism. Or it can be targeted PCR product, such as the 16S ribosomal RNA for bacterial identification. And more recently is the metagenomic next generation sequencing, where sequencing is done directly from the clinical sample. And universal pathogen detection can potentially be done by this method. So this workflow shows the differences in time of detection between traditional workflow and the metagenomics workflow. The chart, the traditional workflow shows that identification of either parasites, bacteria, viruses, and some fungi may take about maybe in days, depending on the type of method used, or it could be in weeks for fungi and mycobacteria. Whereas the metagenomic workflow, any clinical sample can be used, and after going through the processes of nucleic acid extraction and NGS sequencing and data analysis, it takes about 3 to 5 days for analysis. So it allows for universal pathogen detection regardless of the type of the microorganism. It also has a potential for novel organism discovery. And this has been used for genetic characterization of the SARS-CoV-2 virus. And it has also been applied in most commonly in meningoencephalitis cases, orbital infections, and bone infections. So how does it work? In a clinical sample, there is a mixture of genomes, DNA or RNA of the host, of the contaminating organisms, and of potential pathogens. So here everything is sequenced. And if we are to look for potential pathogens, the host genome is removed. Genome is removed during data analysis, and potential pathogen is can be identified. So this last type of data analysis is extremely crucial, and careful analysis is required. Expertise in bioinformatics is a must for this. However, again, limitation of this assay, there is a study, there was a study on chronic meningitis, and these, they had included an extensive negative controls of about 24 water samples and 94 CSF from uninfected patients, and subjected to metagenomic next NGS sequencing. They found 4,400 genera of organisms, including bacteria, virus, fungi, in negative controls. So again, this is not a foolproof method as yet. The technology is still evolving. Standardization is still under process. High cost is an issue. Requires skilled manpower, particularly bioinformatics expertise is a requirement. And the turnaround time is on an average 3 to 5 days, which is not extremely rapid. There are other assays, if the clinical, with using clinical diagnosis, there can be other methods which can shorten the time. So 5 days is not extremely rapid. So ramping up speed is a requirement for this test. And this can be possible through by applying the CRISPR-Cas biology to the next generation sequencing. It can really make the assay faster. Briefly about microarray. This is a potential, it has the potential to screen thousands of target genes in a sample, extremely high throughput. It has a chip which is to which the target regions are stuck, and clinical sample RNA after RNA extraction and undergoing various processes is analyzed, is hybridized, and then data analysis is done. However, again, it has not found too much place in molecular diagnostics as yet. It is extremely labor intensive, expertise is a requirement, cost is high, and there are reports of low sensitivity and specificity.
Ma'am, last 2 minutes, please.
Yeah, done. So lastly to proteomics, MALDI-TOF, as we commonly know, it's the matrix-assisted laser desorption ionization time of flight. This is available now in many laboratories, clinical microbiology labs. It's a culture-based identification of bacteria, including anaerobes and fungi. So culture-based, it just requires a single colony. Pick up the colony, which is smeared on a target slide, and matrix is added to the slide, and the slide is loaded on the machine. The matrix makes the proteins in the sample in the culture available for ionization, and the positively charged ions proteins are then enter the time of flight mass analyzer, where species specific protein profile can be done. Based on the protein database, species identification is done. So the advantages of MALDI-TOF is that it is the running cost is very low. It has a very rapid turnaround time. It takes about minutes, and automated for minimal hands-on time, single colony requirement, and broad applicability, especially the anaerobes, which is still a challenge in clinical microbiology. And the limitation is that it cannot be done directly on clinical samples. There's no antibiotic susceptibility information, and there is a high capital investment for the instrument. To summarize, molecular methods are now offered in many laboratories, mostly due to simplification of process and user-friendly protocols. There is a potential for universal pathogen detection. Cost, as more and more tests are used, cost will definitely come down. And as newer technologies are added, these tests can be upgraded soon to point of care or bedside tests. Thank you.
Wonderful, wonderful presentation, Dr. Sonali. In a short time, very crispy presentation. Yes, as you said, this molecular biology equipment needs initial high investment, but in the long run, it should be very economical and very quick for the clinicians and for the patients to initiate the treatment, to follow up the cases, to assess the prognosis, etc. Thank you. Thank you.
With this, we move on to the next lecture. We do come across cases of TB in our practice. At times, the diagnosis is really simple, but most of the times coming to a conclusive proof about diagnosis of TB is really difficult. So to enlighten us about this, I would ask Dr. Suhas Prabhu sir to take over. Sir, please.
Thank you. I would like to start with some gratitude, of course, and also an apology. Gratitude for calling me to speak at this midterm ID CME. My thanks to the organizers for thinking of me to speak on this topic. But I must say that while it is nice to see all of you here on the Zoom, I still long for the days when we can meet physically. So maybe the organizers can think whether the next meeting, since now we are hopefully coming out of the corona pandemic, can be had physically. I did enjoy the Pedicon, which was partially physical and partially on digital media. The apology is on these grounds that while I'm going to speak on diagnosis of childhood TB, I will be speaking entirely from the clinician standpoint. And I will not be talking anything technical at all. I thought since there was a previous speaker who was talking on molecular diagnostic, a microbiologist, I thought somewhere that would be covered. And although it was covered indirectly, but not directly for tuberculosis, so you will have to excuse me for not covering that. I will be talking entirely from the clinician's point of view of how to diagnose tuberculosis. We know that diagnosis of an infection is best made by identifying the pathogen in the patient. Sounds very simple. You find the Mycobacterium tuberculosis in the patient and you have your diagnosis. Now, why is pediatric TB so difficult to diagnose? That's because the gold standard of diagnosis, which I just mentioned to you, is identification of the organism, is difficult in children because two reasons. One is tuberculosis in children is paucibacillary. That number of tubercle bacilli itself is very low, so difficult to get them to identify in the laboratory. Secondly, collection of the sample is difficult. And we know that we normally look at tuberculosis from 2 points of view. One is depending on the site of the infection. One is pulmonary tuberculosis, which is the most common TB that you see, especially in adults. And we rely on expectoration of the sputum to identify the AFB, but children don't do that. And extrapulmonary tuberculosis is more common in pediatrics than children, and we don't have a simple method like expectoration to get the organism. So often an invasive method is required. So if you look overall, smear positivity is about 80% in adults and only about 10% in children. So we can't rely on smear alone. So let me talk in two parts now. First, I will talk about the diagnosis of pulmonary tuberculosis and then finally about extrapulmonary tuberculosis. Now for pulmonary tuberculosis, as I mentioned, direct evidence of AFB smear positivity is absent. We have to rely on indirect evidence. And indirect evidence will include symptomatology, contact history, tuberculin skin testing, and radiology. Now, when you do rely on indirect evidence, you might lead to an indirect conclusion. Also, the issue is we have so many things to consider. How do we consider them, in what sequence, and how to narrow down to a definite diagnosis? So what we actually need is a diagnostic algorithm. And I'm going to show you the diagnostic algorithm, and I'm going to run through it because I'm sure you have seen this somewhere before in the past. This is now part of the National Tuberculosis Control Program as well as the IAP program. And while this may sound like a repetition to you, I think it was done with a lot of thought. If Dr. Yevle is listening to me now, he will remember 5-6 years ago how many days we struggled on this algorithm under the tutelage of Dr. Varinder Singh in Delhi. This was, I think, 5-6 years ago, 2015, before we finally came up with this. So I don't think I can improve on that. But instead of looking at it like this, let's go through it in sequence, and that will give us a better idea of what we actually have to do. The first important point I want to make is that the entry criteria are very important before you apply this algorithm. You cannot simply apply it to any patient just because he has a little bit of fever. If you do that, you will end up with a wrong conclusion. So the entry criteria are fever of more than 3 weeks, unremitting cough for more than 3 weeks, and weight loss of 5% or more over 3 months, or in an infant where we would normally expect weight gain, if there is no weight gain in the past 3 months, and if the child is nutritionally compromised, then we would say that first give him adequate nutrition first. And in spite of that, if he doesn't gain weight, that's a clue to think that this patient deserves to start in the algorithm. We have dispensed now with the fact that you need a contact with pulmonary TB. It's helpful to have that, but it is not essential. What's the first step? The first step now is a chest X-ray. And if the chest X-ray shows pathology, then we look at whether it's a highly suggestive X-ray or not. What do you mean by highly suggestive X-ray? Only 3 patterns: cavitary lesions, hilar lymphadenopathy, and miliary mottling. These are the 3 patterns which we consider highly suggestive of tuberculosis. You'll see in the algorithm where it is important to find out whether the lesions are highly suggestive or simply non-specific. But remember that these patterns are more specific of tuberculosis only when the starting symptoms are like tuberculosis. Otherwise, you might mistake something else for tuberculosis. All other patterns are considered as not non-specific, not specific or highly suggestive of tuberculosis. They include anything like this: consolidation, non-homogeneous opacities, ground glassing, and thin-walled cavities. What is the role of other imaging modalities? We have 2 or 3 of them to discuss here: the lateral X-ray chest, the ultrasonography of the chest, and a CT of the chest. The lateral X-ray of the chest helps to evaluate hilar shadows, and we see here clearly what is called as a donut sign, what looks like a, what is the Hindi word for it? Meduvada, which is very suggestive of hilar gland circling the end-on bronchus. It's also very useful for detecting retrocardiac lesions. You don't see them here, but this is the area where you would see haziness, which is easy to miss on a PA view of the chest. The sonography is useful for diagnosis of pleural effusion and guiding your tap. It is useful for detection of caseation in lymph nodes and for directing your FNAC there. We know that the other common cause, not as common as tuberculosis, of course, is non-specific lymph node enlargement or malignancies like Hodgkin's or lymphomas. But here, of course, there is no central caseation. The sonography, or even better actually the CT, can clearly distinguish the central hypodensity, and this helps to tell you that it is tuberculosis. It can also help in evaluation of a superior mediastinal mass if you are confused whether it's actually a lymph node or a thymus. But please remember that most of the lymph nodes in the mediastinum that you see in tuberculosis are actually in the middle mediastinum, not in the anterior mediastinum. So even a lateral view of the X-ray can help. The CT of the chest should be relegated to only for difficult cases. It can show you retrocardiac and carinal lymph nodes. Again, difficult to spot on a chest X-ray. It's also better at picking up miliary shadows and can differentiate specific parenchymal shadows like consolidation versus atelectasis and bronchiectasis, which can help you to possibly identify the cause. And these are some pictures that you might see in a CT. Here you see necrotic subcarinal lymph nodes behind the heart. Would be very difficult to see on a PA view of the chest because it's overshadowed by the heart. And this is the miliary mottling, which is so clearly evident on a CT, but might be missed if your X-ray is not well taken. So that's your chest X-ray evaluation. The next step, if you see a highly suggestive chest X-ray, is to look for tuberculosis. And as we saw with the previous speaker, we are not going to only look at smear. We're going to look for molecular testing by doing nucleic acid testing. I again won't go into the technical details of how an NAT is done, but if it's positive, and we know that the standard NAT that is available, the gene expert, not only confirms or rules out tuberculosis, but also tells you whether there's rifampicin resistance or not. So here you have clearly a molecular diagnosis straight off: tuberculosis, molecular diagnosis, rifampicin resistance or not resistant. But if the chest X-ray is showing non-specific shadows, then the recommendation is to give a course of appropriate antibiotics, avoiding those that will have anti-tubercular effect, like an aminoglycoside or linezolid or a fluoroquinolone. The recommendation is probably an oral cephalosporin or even better, amoxiclav. And if the shadows persist even after a proper week-long course of antibiotics, then one would repeat this test to see whether, or go for this test to see whether we can microbiologically confirm tuberculosis. If the NAT is negative, and remember this test you get a result within a few hours, within a day. If the NAT is negative, you need to consider a repeat second test from a better quality specimen or from an alternative site. If it's a pulmonary tuberculosis, you can look for maybe a gastric lavage now if the child's sputum was not okay, or maybe a bronchoalveolar lavage if you have the facilities, or also look for another site. If the child has associated lymph nodes in the neck, which are peripherally enlarged, appear soft and matted, you can try and do a test from there. And if you have it positive, you have a definitive diagnosis. But even if the second test is negative, then what do you do? Then you might consider alternative diagnosis, take another opinion. But if these are not possible and you have reviewed and found no other possible cause, and there's a strong history of contact and possibly other evidence that suggests that this is tuberculosis, you might consider treating this patient as a what is clearly labeled as a clinically diagnosed TB case, but always start only first-line drugs, never start second-line drugs in this kind of patient. If on the other hand, your chest X-ray is normal, you should evaluate for the presence of extrapulmonary TB. And you might consider referral to a higher center for detailed investigations. We know that extrapulmonary TB can be anywhere. It can be in the bones, it can be in the joints, it can be in the abdomen, it can be in the lymph nodes or even in the CNS. And we need a complete evaluation. So if you don't have the facilities for that, your child can be considered for referral to a higher center. But you should also consider whether these symptoms that you see here are due to something else, and it is not tuberculosis at all, even though you have this history. We know that this kind of history can be seen in several other conditions, although tuberculosis should be our first suspicion. Now coming to extrapulmonary tuberculosis. How do you make a diagnosis of extrapulmonary tuberculosis? Again, you start with a compatible history and history of contact. And again, the correct diagnosis, the best method of diagnosis, as I said, the gold standard, as I said right in the beginning, is microbiology. So you must attempt to show the Mycobacterium tuberculosis from the extrapulmonary disease site. The only thing is, this might need an invasive sampling, whereas in a pulmonary TB, you don't generally need invasive if the child is able to expectorate. Otherwise, you need minimal invasion, like doing an induced sputum or a gastric aspirate or a gastric lavage, where from you can get the sample. But generally, if it's extrapulmonary tuberculosis, you will generally need to do an invasive sampling. So as I mentioned, there are various sites where you can get extrapulmonary tuberculosis. If you have identified lymph node enlargement, which is suspicious of tuberculosis, or granulomas in solid organs, an FNAC or an excision biopsy is the way to go. Excision biopsy is always better, but it also gives you the histopathology and the architecture of the tissue, which can help you to identify tuberculosis. I'll come to that little shortly. But FNAC is sometimes quick, easy, possible at the periphery, and is minimally invasive, so can be considered. If it's a diseased tissue like a thickened pleura, omentum, or an ulcer in the skin or elsewhere, you can do a punch biopsy. You can use a simple Wim-Silverman needle. We have done that for thickened pleura or omentum, and you can get good tissues. and almost a 25% plus positivity on AFB smear culture or gene expert. Otherwise, also any surgically excised specimen. If you have a patient who's got maybe a stricture in the intestine, which is called subacute obstruction, has been excised, it's got some kind of a lump that has been excised, anything that has been surgically excised where you think it is tuberculosis, remember to send for microbiology. We always remember to send for histopathology, but you need to remember to send for microbiology, and you need to remember in advance, because when you want to send for microbiology, it cannot be put in formalin, it has to be sent in saline. And our surgical colleagues are only too happy to immediately put it in formalin the minute they have removed the tissue, so they need to be told in advance. For cold abscesses, you can simply aspirate the liquid and send it for microbiology. So this is your microbiology for extrapulmonary tuberculosis. But do we have anything besides microbiology? But before I go to that, don't forget to look for pulmonary tuberculosis for the diagnosis of extrapulmonary tuberculosis. Even in, for example, in CNS tuberculosis, where getting a sample is more difficult, we know that up to 30 or 35% of CNS tuberculosis patients will have an associated pulmonary tubercular lesion. And therefore, if you do a gastric lavage in this patient and try to identify the tubercle bacilli, you might find it there, and that gives you an answer. So don't forget to look for pulmonary TB when you are thinking of extrapulmonary tuberculosis, although there may be no obvious clinical signs. The child may not be coughing, and therefore you may not think of it first time. Okay, so what are the other methods we use to diagnose extrapulmonary tuberculosis? Imaging, analysis of exudates, and histopathology. I will take this one by one in turn. For imaging, we know that USG and a CT are the first choice because they are easier, cheaper, more freely available, and quicker to perform. And MRI is more expensive, takes longer to perform, might need sedation in a child because it takes sometimes half an hour or more. But it is the preferred modality for CNS and osteoarticular TB because it gives you definite more information than these two modalities. Analysis of exudates. Where do we get the exudates from? It may be pleural, ascitic fluid, cerebrospinal fluid, sometimes a joint aspirate, sometimes an aspirate from a bone, sometimes a discharge from a sinus. I've even done ear discharge and identified a chronic tubercular otitis media. So any exudate can be looked for to look for tuberculosis. And finally, histopathology. So let's see where we can use this. In CNS tuberculosis for imaging, what are the features? Basal exudate, hydrocephalus, influx of the territories of the basal arteries, and presence of granulomas which are suggestive of tuberculosis. And MR, as I said, is superior. An MR spectroscopy can help you to distinguish cysticercosis from TB granuloma because of the presence of the lipid peak. For abdominal tuberculosis, a USG or a contrast enhanced CT of the abdomen is usually adequate. What are the findings? Enlarged necrotic lymph nodes, thickened peritoneum or omentum, thickened narrowed ileum or features suggestive of subacute obstruction, and granulomas in the solid organs like the liver, the spleen, or even the adrenal glands, and sometimes in the kidneys. So these can all be detected by imaging by doing a USG or a contrast enhanced CT. For osteoarticular TB, the CT or the radiology is better for bony lesions and erosions. But if you want to look for soft tissue involvement, which is particularly important in port spine, because you want to look for the erosion in the disc or nerve root compression, and MRI will be much more useful. Then we come to examination of the exudate, and I'm going to consider them all together, whichever is your source from where you're going to get your exudate. First of all, the appearance. It looks yellowish, hazy, non-transparent, and if you leave it stand, you will see a cobweb. And this simply is a reflection of the high protein content of these exudates. The biochemistry, of course, we always do for all this. We find increased protein, sometimes in several grams. The sugars will be low like in any infection. That doesn't help you to distinguish it from a bacterial infection or a non-tubercular bacterium. And a word of caution, don't do ADA. ADA levels do not distinguish this from pyogenic infections. If you look at under the microscope for the cellular exudate, the number of cells vary from few to hundreds, usually not thick pus like you would see in a purulent exudate from, say, an empyema following streptococcal pneumonia. And usually the cells are lymphocytic. The cells may be usually a few hundred or so, and the majority are lymphocytes. Now coming to the histopathology, if you are done a full thickness biopsy or you've done an excision biopsy, then as I said earlier, you have the advantage of looking at the entire histopathology and not just the cytology. And there are various levels of confidence on the histopathology which can tell you that you're looking at tuberculosis. The minimum that you would expect is to see lymphocytes. The next step of confidence would be the presence of granulomas. We know that tubercular infection typically causes granulomas. At the same time, we know that granulomas are the feature of other infections too, including fungal infections. And of course, there are certain autoimmune diseases that also present like granulomas. But if you see a granuloma with epithelioid cells or with Langerhans type of giant cells like you see here, that's very, very typical of a tubercular disease. And if you see caseation, like you see this central eosinophilic material here, which is homogeneous without any characteristics, that's caseation. That's even more suggestive of tuberculosis. If you see AFB on the smear, you can do a Ziehl-Neelsen staining on this tissue. And if you see AFB there, that's even more suggestive. And as I said earlier, never forget to send it for culture. If you see AFB grown from this tissue, then that's definitely tuberculosis. So as you go down this list, you have an increasing certainty of your diagnosis being tuberculosis. Now, a word about the Mantoux test, which did not appear anywhere so far. Are we saying that the TST has no role to play? We know there are a lot of drawbacks of the TST or the Mantoux test. Requiring skill to administer, it needs, of course, the patient to come back on the third day. The tests vary. The results of the test vary depending on what strength of tuberculin you use. There are issues about the manufacture, storage conditions that can affect the potency of the liquid that you're using. We know it is affected by previous BCG vaccination or previous immune status of the patient, whether is immunocompromised. We also worry by atypical mycobacteria. But most importantly, we know that a TST positive only tells you exposure to tuberculosis. It does not tell you disease. It does not distinguish between latent or past infection versus active disease. So therefore, it is only a corollary. It should not be used only as diagnosis. It's a supporting evidence, a crutch that you will use when you don't have direct evidence. And one more point really is the fact that the tubercular protein that is available, the standardized tubercular protein, is running out. Of course, there are people are trying to find some substitutes, but they are not yet in the market. I will not go into that. I would like to conclude by telling you what are I think are the good practices in diagnosis of tuberculosis in children. The first step is always aim for a microbiological diagnosis in any and every child in whom you suspect TB. And you can do it by a smear examination, you can do it by molecular methods, but best of all is to do it by culture. And we know that you can use a combination of culture and molecular methods or smear and molecular methods, like Dr. Sangvi just told us. You can do a culture and then do a molecular method on that, like your line probe assay or other methods that we have, which can quickly identify that it is truly M. tuberculosis and also the drug sensitivity. When you want to make a microbiological diagnosis, use every possible method to obtain a sample for microbiological diagnosis. If the child is not bringing up sputum, do a gastric lavage, do otherwise an induced sputum, do every possible method. If it is extrapulmonary tuberculosis, I think an invasive method is justified. And even for pulmonary tuberculosis, even a BAL may be resorted to if you want to be sure of getting a sample that can identify the M. tuberculosis. Putting in a needle and FNAC is not such a difficult proposition now. It is available at most peripheral centers too. Does not really require anesthesia. There are trained, and it's not very risky if it's done by a trained ultrasonographer or a good CT radiologist, where he can actually see in which direction his needle is going, so that danger to adjacent structures is avoided. So try even invasive methods. 2 samples is the norm wherever you're doing it from. Of course, for an invasive method, you might opt for only 1, but otherwise always try for 2 samples. If the bacteriological or microbiological diagnosis is negative, rule out other possible causes. And then only based on the symptomatology, the radiology, the histology, and possibly the support of the tuberculin skin test, label the patient as clinical TB and start treatment. But remember, you have not proved your diagnosis. So if this patient fails to respond within the standard 4 weeks or up to 8 weeks, do not think that this is a drug-resistant tuberculosis. You must then either revise your diagnosis, make further efforts to find out some other cause, or try to prove that it is tuberculosis and it is drug-resistant before you move to second-line therapy. And lastly, there is no role for empirical anti-tubercular therapy. Thank you.
Thank you, sir. That was, as usual, a crisp and to the point lecture. We would have enjoyed furthermore molecular diagnostic tests as well. I think we'll keep it for the next lecture whenever we have. Thank you, sir. Sushruta, please take over.
Thank you, sir, for a wonderful talk and giving us a lot of practical inputs on how to go about for tuberculosis, which we could see in our practice. Moving ahead to the next much awaited session, we have a panel discussion on vaccine dialogue. The main panelists are Dr. Kasi, Dr. Bakul Parikh, Dr. Balasubramaniam. Dr. Vijay Evle cannot join us because of some technical issues, and instead we will have Dr. Victor with us. Today's moderators for the session are Dr. Sanjay Lalwani and Dr. Ganesh Kulkarni. Sheetal, can you please share the screen?
Good evening to all of you. This session, I think we have 4 experts. None of them require introduction. Dr. Bala has been the ACVIP chairman in the past. Dr. Kasi, who is the present ACVIP chairman. Dr. Bakul Parikh, who was the IAP central president. And of course, we have Dr. Rajendra Vaidya, who probably attends maximum CMEs I have seen in this digital time. And with me, the co-moderator is young, dynamic Dr. Ganesh Kulkarni from Aurangabad. Ganesh, I think you can start.
Yeah. Very good afternoon, sir. Before I take off, I must admit, I have one of the finest principal investigator of clinical trials of vaccines in this country, and probably the passionate vaccinologist, able administrator, Dr. Sanjay Lalwani sir is here with me. I have this privilege to be with him. And on board, as sir has said, I do have the galaxy of, I call them gods of academics, and they all are there here today to teach us something. Coming to Dr. Bala sir, as I feel always that making of a vaccine is a process, and in this process, safety is to be seen first, then comes efficacy, and then comes effectiveness. Now look at this man who says, I would rather wear a mask the rest of my life than get vaccinated. And I believe this is not his only, he is not the only person who's saying this. I have seen a lot of professionals, I have seen a lot of educated people, I have seen a lot of qualified people saying the same words. And the reason is this word EUA, Emergency Use Authorization. What has happened during this EUA is this hierarchy, safety, efficacy, and effectiveness has been disturbed. We have talked a lot about efficacy of vaccines first. we were comparing vaccines. This one has 95, this one has 70, this one has 80. And we were talking a lot about efficacy. And now we are coming to know that, oh, there was minor side effects. There were Bell's palsy. Now they're coming up with saying that there are pericarditis, there are myocarditis, there is TTP, and a lot of things. So is this pattern of safety, efficacy, and effectiveness has probably changed? And that is the reason why, all the qualified researchers and in fact educated people are worried about taking a vaccine. So, sir, what do you really mean by a safe vaccine? Marasan. Yes, sir.
Hello?
Yes, sir.
Am I audible?
Yes, sir, you are audible.
Yeah. A safe vaccine is one which does not produce any adverse effects at all. Serious adverse effects are zero. Nothing untoward happens to the host who receives the vaccine. When you say safe, most importantly, it doesn't kill anybody, it doesn't maim anybody, it doesn't damage anybody's system, and it doesn't make the individual a handicapped one. That is what is meant by the term safe, and that holds good for any vaccine, which should not affect the individual adversely when you administer the product to the human host.
So in this situation, probably, are we not really being justified getting these vaccines and getting these vaccines EUA, all these COVID vaccines?
Yeah, when you give a vaccine to a human being, you become a judge who weighs the pros and cons, the risks and benefits to the host. When you are dealing with a disease which is likely to kill a significant number of human hosts, definitely you would consider giving the vaccine. And after all, I don't know any vaccine in literature which doesn't have any adverse effects at all. It is like medication. Even vitamins given in high doses can produce side effects. All drugs starting from paracetamol can have adverse effects. So when it is necessary, you weigh the risks and benefit ratio and do administer the vaccine to the host to prevent a deadly disease.
Very rightly said, sir, because no vaccine is 100% safe. And in fact, perhaps everyday scores also have hidden dangers in our life. So risk versus benefit ratio has to be always judged. Now, there is a tradition that we don't take consent for vaccines. Whenever patients come, parents come to our clinics, we don't take consent. We think that it is an implied say from them. So is written consent necessary now? Because as we encounter with EUA and we encounter with a lot of, unforeseen complications are seeing. Now, is written consent becoming necessary before giving a vaccine?
You look at the COVID-19 vaccination program rolled out in India. There is no written consent obtained from anybody. So when the government has allowed that to happen, I don't think there is a need for any pediatrician to obtain a written consent, because after all, the vaccines are being given without any written consent. So the moment the patient comes to you, do we take written consent before prescribing an antibiotic? Do we take written consent before asking for a CT scan? So the very fact that the patient has agreed means implied consent. As of now, with the government having rolled out the vaccine without the written consent, I think we are all safe in not obtaining written consent before giving vaccination. Coming to the explanation of the side effects, yes, it is our duty to explain to the family and to the person who is taking the vaccine about the side effects of the vaccine. Certainly, it is our duty to tell them that there can be side effects. If possible, we can give a leaflet on the vaccine. But what I do in my practice, whenever I do a vaccination to a child, I hand them over the manufacturer's instructions, which contain everything about the vaccine. And they wait for the vaccine these days, in the COVID-19 days. The moment I examine a child, I ask them to wait outside. I give them the instructions given by the manufacturer, ask them to read and come before I load the syringe and keep it ready and administer to the vaccine. It is our duty to explain all the side effects, at least briefly, or through a leaflet, ask them to read, understand before we give the vaccine.
Very true, sir. That there should be complete transparency as far as we let them know the side effects. Now, Kasi sir, this was the story in India today on 24th of June, this coming June, very recent. Measles vaccine may protect children against COVID-19, fine study by a Pune researcher. This was done in BJ Medical College itself. And in fact, they claimed that measles vaccine had an effectiveness of 87.5% against COVID virus 2. No, this is again the old story, In fact, perhaps we have discussed a lot on this particular aspect before we had these COVID vaccines. But right now we do have COVID vaccines, very specific COVID vaccines. And these COVID specific vaccines, in fact, have a wonderful efficacy reaching up to 95%. But I feel efficacy just provides us prevention against illness. It does not give us prevention against infection or a transmissibility. And we do not have vaccines against, COVID in pediatric age group. So can we really consider, because one of my medical friend kept on asking me to give MMR shot to his kid and started insisting more on after this Pune news. This new round of discussion on the old topic perhaps, but I feel innate immunity is something which is, playing a role here. What is your say on this?
Well, before the COVID vaccines received EUA, there was a lot of enthusiasm and talk about the non-specific effects of many vaccines. In fact, the most prominent vaccine was the BCG. And in fact, since its introduction, its positive benefits, apart from prevention of tuberculosis, has come from both developed and developing countries. In fact, in the late 20s and early 30s, even a country like Denmark reported reduced respiratory tract infections after giving COVID vaccines. Numerous studies have come from Africa, which showed the non-specific effects of BCG in reducing both neonatal mortality, as well as reducing the incidence of respiratory. Subsequently, studies have come, with similar effects of vaccines like rotavirus, oral polio, many of the live vaccines. Now, the entire thing, the basis of this is stimulation of the innate immunity, which is called as trained innate immunity. See, because we always feel that innate immunity has no memory. But here, these vaccines make certain genetic changes, or rather, I would say epigenetic changes, whereby following the vaccination and re-exposure to a non-related pathogen, there is a which confers additional protection against these non-related pathogens. That is the basis for innate immunity. And this innate immunity involves mainly the myeloid and some of the lymphoid precursors as well. And studies have shown that this genetic reprogramming occurs at the level of the bone marrow myeloid cells. So that is the reason why, though the lifespan of the myeloid cells may be about a couple of months, we see this non-specific immunity lasting for many years. That is because right from the progenitor cells, these changes in the epigenetic changes occur. Now with the advent of COVID vaccines itself, I think this enthusiasm for these vaccines have been relegated to the background, though in children who are still not eligible to receive the COVID vaccines, receipt of these vaccines in their usual schedule may confer some additional protection. Now, from my own personal feeling is, will these vaccines have some additive effect to the COVID vaccines also is something that we need to look into. So I don't think we should dismiss it off, nor should we be too enthusiastic about giving these vaccines. I think in recent times, there's been a flood for flu vaccines in the clinics. Everyone wants to take a flu vaccine. And in fact, I have been forced to put up a notice in my waiting room stating that flu vaccine protects only against flu and not COVID-19. So I think we have to take it in the proper perspective.
And then on top of it, what I have gone through is I have seen that COVID infection has definitely, it has the genome itself has NSP1 suppression. It suppresses, the NSP1 suppresses interferon, and it in turn suppresses the innate immunity. So might as well, if these other vaccines are giving us a good innate immunity, which probably we are not getting it through COVID infection and against COVID infection, will that work in some better way?
Now, I think basically, see, most of the studies have been observational studies, and you can't make recommendations on observational studies. But there is one study where they took 2 adult cohorts, gave BCG to one group, and the other group was not given BCG. They were then exposed to a modified yellow fever virus. And they found that those who received the BCG vaccination had a much lower level of viremia following this modified yellow fever. I mean, in fact, this is the only experimental proof, about this trained innate immunity. Yes, you're right. We should emphasize routine immunizations with these vaccines for the eligible children. But I don't think at this stage we can recommend BCG for an 80-year-old person or oral polio vaccine at this particular age. I think it's too premature.
So I would like to just add, when this BCG vaccine trial took place for COVID, the BCG, which was the recombinant one, was quite reactogenic. In fact, 1/3 of the patients who got BCG vaccine before they took the COVID vaccine was out. There were a lot of local adverse events which were recorded. Now, I think our discussion is kindly going to focus on COVID vaccine because it's the talk. And I think we as pediatricians have to encounter a lot of queries from the parents about COVID vaccines. So Rajendra Vaidya, I will take few questions and I would request you to answer those. I think this is a situation where a father has recovered from COVID-19 illness a month back and now asking me for his second dose. He took first dose, he got COVID. Now he has come to have. So I have 4 questions. You can take one by one. Should he need the second dose? Because he's got a natural infection already. How long do we wait ideally for the second dose? Third, during when he had COVID, he had hospitalization and he had got plasma therapy, whether right or wrong, he got plasma therapy. And he remembered and he told doctor that he got plasma therapy. And last, is he insisting on doing his antibody titer before taking the second dose? So your take on each these questions, Rajendra.
Yes, sir. Thanks a lot. First of all, organizer, getting me as a night watchman. So I definitely with this, in fact, I'm honored to be with all these stalwarts. But if I'm getting bold in first or please forgive me. Thanks, Sanjay. Definitely, the vaccinology is a dynamic process and the recommendations are changing. Absolutely, you can say daily, weekly. So initially when they came told that if there is infection, you can take after 1 month a vaccine. But now the government has changed it to 3 months. And many scientists or experts had advised not to give vaccine those who have suffered. So, but at present, the simple answer is after 3 months, he can take the vaccine after the recovery. From ideal second dose, ideally, if you are taking for Covishield, on the app, you have to wait for 84 days, like 12 weeks. If you are getting Covaxin, then you'll have to wait for 1 month. But this is routine. If it is getting infection, then definitely after 3 months only, we have to take second dose. Then again, he has received convalescent plasma or any monoclonal antibodies. All guidelines say that after 3 months, you have to take the vaccine. But you have to take the vaccine. There is, at present, the guidelines are there is no need. Even you have suffered, don't take vaccines. The guideline has not yet come. So even you have suffered and you have taken convalescent plasma, then 90 days is the cutoff point. And last is insisting antibody titer. Definitely, this is common with the medicos only. They're getting antibodies and getting panic and then a lot of phones to Kasi sir, Bala sir, what to do? My antibodies are 0. But I think majority they are not doing specific neutralizing antibodies. There is little research tool which is little costly and there is no need. Even though they come negative, they are protected from the T cells and nobody is doing T cell functionality. So clear-cut answer, you don't do any antibody titer after taking any vaccine, except few like immunocompromised or anything. Otherwise, there's no need to do. Thank
I
you.
think Rajendra has clarified it that you need to wait for 3 months. Before I go to the next question and Ganesh tells, Kasi, what's your opinion to take the AstraZeneca vaccine or Covaxin? A lot of them are preferring. So what's your take on which brand of vaccine if you are given a choice to take it?
Well, if I am given a choice, I will take whichever I get. I won't have any particular choice. But if a woman comes to me in the reproductive age group, especially below 50 years, I will then advise her to take the Covaxin rather than the Covishield because of the very minuscule risk of vaccine-induced thrombotic thrombocytopenia. And in fact, this is a recommendation which has also come into vogue even in the UK and many of the other European countries as well. This is the only preference that I make.
And next question.
Sir, is there something which is called as polyclonal vaccines? No, they have this antibodies targeted against all the different parts of spike proteins, and that is why probably Covaxin scores over Covishield. Is there some sense in saying that?
It is something like whole cell versus acellular pertussis vaccines. Simple. Okay, you have multiple antigens of the entire organism in Covaxin, whereas in Covishield, you have just the S protein or the receptor binding domain in some of the other specific vaccines. So that's the reason why the response will be towards almost all the antigens in the organisms with Covaxin. Whether they are really helpful, not helpful, we really do not know.
Before Ganesh takes the next question, Bala, the government recommendation of giving 3 months gap is just because of shortage of vaccine or there's a scientific base for it?
The answer is both. One is that, see, if you look at the studies which have come out from Europe, the immunological response is better and the protective efficacy is certainly better if the individual takes the second dose, preferably after 60 to 90 days. In fact, I took the first dose. When I was to decide the second dose, Adam Finn, who has worked with Andrew Pollard in UK, told me there is enough data, you take it at 90 days, and that's what I did. There is enough data to support the use technically and scientifically at 90 days, but the government has also conveniently used it to give to more people with the first dose. It's also, I thought, ethically correct to give the first dose vaccine to more number of people, delay the second dose, and thereby increasing the immune response. Both technically and logistically, this decision is absolutely correct.
Ganesh.
Coming to the next.
Sanjay, I want to add, those who have taken Covishield, initially stages like we took with the 4-week gap, we were initially feeling little guilty, but when the US study came that even with the 4-week gap, it is around 76 to 70%, then we are little relieved. So I think there should be a technical problem. Yeah.
Sir, errors keep on happening when we vaccinate such a large population at one go. My doctor friend received first dose of Covishield and second Covaxin in a great confusion or error. Now he is really worried because he is worried about his immune status against COVID. He wants to know whether he needs to take another shot of Covishield now, and what should be the dosage interval. That's what he's asking me again and again. So what is your say, Bala sir?
First thing is, there is no data on interchangeability, but studies are going on where they are mixing these vaccines, messenger RNA with Covishield and Covishield with the messenger RNA. Until data comes from it, we don't have any definite recommendation. Coming to the question whether he should take the second dose of Covishield, I would say if he has taken the first dose, it is prudent to take the second dose at 3 months. And hopefully his Covishield would work. And currently, if somebody asks you, I have taken Covishield, should I start taking Covaxin? You should be honest in telling them that there is no data as yet, and until we get data on it, I wouldn't advise you to take the other vaccine. That's what we should say.
And sir, what about this interchangeability? If whatever the studies they are trying to conduct, the interchangeability between the same platform and different platform, is it not really unethical to compare or mix two different vaccines coming from two different platforms as such?
Yeah, that's a brilliant question. See, you currently the vaccine efficacy, the protection offered by the vaccines is not fully known. We will have to wait for some time. It may so happen if you use two different vaccines, the overall efficacy might be higher or lower. We do not know. I won't say it is unethical, but if somebody wants to take it on his own, it's not scientifically correct. If with all the ethical precautions and all the guidelines given for vaccine trials, if somebody conducts a trial, is not wrong at all. After all of us know there's a huge debate in India whether to take Covaxin or Covishield, and the answers are not known. So the answers will be known. Maybe saying that you can take one vaccine now and one vaccine later, and I don't know, I'm not too sure whether this thing is going to happen or not. What is it? Next year onwards, we may be taking annual COVID-19 vaccines like the flu shot, and still be debating whether it is working or not. I hope such a situation does not arise.
No. I think there are errors which occur in COVID, and I think the talk is on COVID vaccine. So,
Kashi sir wants to add something.
Yeah, sure.
Yeah, I think regarding this previous goof up which happened, I don't think we should be too pessimistic about it. Now, even with two mRNA vaccines available, the US CDC has very clearly said no interchangeability. But in case the dose of the first vaccine is not known, which was given, you can give the second dose. You need not restart the series with two doses again. A study in Spain, which was done recently, which has been in preprint, one cohort received two doses of AstraZeneca, another cohort received first AstraZeneca followed by a Pfizer vaccine, mRNA vaccine. They found that those who received the second dose of the mRNA vaccine had much, much higher antibody titers. It is also believed that if you give two different vaccines, it acts like a prime boost principle, where you're giving different vaccines for the priming and boosting. And we know this always elicits a better immunogenic response. So I think the last word has not been written. Now, in this previous case, we should really reassure the patient that the vaccines are going to work, although they are two different vaccines, and we should unnecessarily not create confusion. I mean, we should consider him as a completely immunized person.
Ganesh, what you are told, whether it is unethical, I will say that it is not unethical. It is the need of hour, because this problem is going to happen all over.
Yes.
Because of the shortage and because of the mixed vaccines are not available in the countries. So it is going to happen. So a study has to be done, and then we can come out after once we get the studies.
In fact, there was a lot of talk about the study of interchangeability of AstraZeneca and the Pfizer vaccine in UK, but I have not seen any published data at all, or any data. Dr. Bala, are you aware of anything?
Yeah, the trial is nearing completion. The data will be out hopefully next month. That's what Adam Finn told me. Last after 2
and
weeks.
with Sputnik also, sir. They are having with the Sputnik also. One AstraZeneca and another Sputnik vaccine. This study is also going on.
Yeah, you will see more. Already you have seen that the Chinese vaccine has failed miserably in many countries. Yeah. These countries have now started using other vaccines. So we will soon have a lot of data on this in another 3 months.
In fact, in Dubai, they had taken Chinese vaccine, and now they have started giving mRNA vaccine, Pfizer vaccine. And probably the data over there, one of my friends told me that it is very, very stimulating and supposed to be a very good combo after that. Because of the Sino vaccine, the timing was done. And with mRNA, they have really got a real robust boosting.
Yeah, I think the next slide, we have a lot of errors which occur, and Bakul Bhai, just a short answers. Since this COVID vaccine is given in the mass vaccination program at number of centers in government and private setups, there are administrative errors like vaccine given in gluteal region. Do we repeat just yes, no? You can say there are few conditions. So you can just look at the screen and let us know what is your thoughts on them.
Yeah, if it is given in gluteal region, I will definitely like to give again. If there is a subcutaneous route, again, we don't have the data exactly. By giving this, what happens? Then below the age of 12 years anyway is not indicated, but if it is given, it is not going to cause any harm, though we don't have any data. High dose volume, low dose volume, I don't think it will matter much, because again, we don't have much data, but low dose, of course, will have less effect. So maybe there we may consider giving it again. Out of cold chain, naturally we have to repeat. because it is not going to be very effective. Expiry dose, again, we have to repeat if it is expired. And recently the case is also going on where the expired doses were used by certain group and they are in soup. Given before 90 days, after giving plasma or monoclonal antibody, see, after plasma and monoclonal, definitely we have to keep a gap of 90 days. Otherwise, they will not be very effective. And that's why we have to repeat. And second dose before the 4th day grace period, how many days before? If it is just a day, maybe we can consider continuing. But if it is too early, then we have to repeat.
The easiest error to correct is fake vaccination. Give one more dose.
Yeah.
CDC doesn't recommend if you are given subcutaneous, particularly mRNA vaccine. They don't ask to repeat. They can continue the substitute.
Yeah, for our Indian vaccine, we have to repeat.
Yeah, Ganesh.
Now, again, going back to Dr. Bakul sir, we would want to be with you there where you are right now. My close dear friends, all of whom have received 2 doses of COVID vaccines, and now they are insisting, sir, ek chota sa get together arrange kari do abhi, because it has been long days we have met you physically. And in fact, CDC in USA has approved that all of them who have received 2 dosages of vaccines and 14 days have passed, they all can meet together physically, they can stop wearing masks. I feel, can we really do that for our country?
So here my straight answer will be that if you have taken 2 doses, you are just protected against serious disease, but not against COVID-19 illness itself. And so you should follow the government ruling as per the unlocking or locking level 1, 2, and 3, what has come. If they allow you to gather in 20 numbers, you have to stick to that because there are certain science behind it. And of course, you have to continue maintaining SMS. There is no doubt about it because we are facing many variants which are coming up. So we don't know which are the variants which are going to escape from the vaccine. And we have to take SMS very seriously, at least for next 6 months, definitely. And gathering, I understand that everybody is bored and wants to meet their friends and relatives, but ultimately safe distancing is very important and we have to stick to the government rules rather than flouting the rules because it will ultimately create problems.
So as of now, there is no escape.
So unless there is dire need, I think we should not meet.
Yeah, I think
Ganesh, what it is, the Israel was the first country to give maximum vaccination and to take out all these. But now recently last week with this,
again they have come back.
They are again coming to the same way. SMS is a must.
Okay. I think the next question for Kasi, I think the child's parents probably had a drop in the serotonin post-COVID-19. And when they read about the history of pandemics in the past, started asking a pediatrician asking him to book a tour to Charidham. Now, we have had 5 pandemics of flu in the past and the phase 3 wave now, and we are awaiting for many. Are we awaiting for many more spillovers? What's your take on the COVID future? And are there any watchdogs to prevent or take early notice of such events?
Okay, now the COVID-19 pandemic is not the first pandemic in history. There have been several pandemics right from the Black Plague or Black Death in the 1930s and 40s. And in the more recent times, we had the H1N1 pandemic, then we had the SARS-1, we had the MERS. And of course, we have been having these influenza pandemics, the Spanish flu and all these pandemics. Every pandemic almost goes through multiple phases, whereby the first couple of phases are the most severe, subsequently they start reducing. And like influenza, which is more closely related to COVID-19, after some time, it becomes endemic and becomes almost a part of our daily life. So what happens to a pandemic? There are 2 ways a pandemic can end, basically. One is called a medical end and the second is called a social end. A medical end is when herd immunity is achieved, the vast majority of the population is protected, and then you get this low level incidence, as I just said, as it has happened with influenza. The second is social. People get fed up of all these restrictive measures and they say, let's live with the vaccines. They give up everything. The disease persists at maybe a little higher level, but things go on. These are the 2 ways in which pandemics end. Now, as far as the SARS COVID pandemic, or in general, many of these respiratory viral pandemics, we should remember that the pandemic is sustained because of mutations. The initial two mutations generally makes the virus more transmissible and more pathogenic, so that more of the population gets infected. Subsequently, mutations occur which mute down the pathogenicity and transmissibility, because humans are the host. If the host is lost, the virus cannot survive. So it is against their own interest to be more and more and more transmissible. So everything comes down, and then it persists as a seasonal disease for a long, long time. I mean, most of these, some have really disappeared. Now, SARS-1 has disappeared, MERS has disappeared, many of these things. But of course, there's always a potential for revival. Plague can reoccur. After the Middle Ages, again, we had an outbreak in Surat about 12 or 14 years back. So it can always recur again, because the pathogen is there in the community. So coming to SARS-CoV-2, I think the talk about the third pandemic is relevant, but whether it's going to be more severe or something is a guesswork. No one can really predict it. Then maybe a smaller fourth or fifth wave, and then it will become endemic. That is what most of the experts believe about this particular virus.
Okay, thank you.
So again, Dr. Ramakant has received 2 doses of COVID vaccines with advised interval, but still his anti-spike antibody titer is 0. Is he non-responder? Bala sir, I would want to ask you, is he non-responder, and should he go for 2 more shots? Is he still protected? How long the protection lasts after COVID vaccination?
First of all, I'll ask my friend Dr. Ramkant, why did you do antibodies? That's my first question. In fact, I have also taken vaccine. I have also suffered from natural COVID-19, but I have never done an antibody test on me, or for that matter, on any patient I have seen. In fact, there are many hospitals who include a package for COVID, which includes an antibody test 2 weeks after the natural infection. I don't know what purpose it's going to serve. It's only going to increase the anxiety of the man, right? Now you look at the antibodies after vaccination and after natural disease. It can take 2 different trajectories. After all, what we use depends on the vaccine we use. If it's a whole virus vaccine, we do not know what antibody it induces. If it is a spike protein vaccine, we do not know what it induces. Messenger RNA, so everything is different. Until now, we don't know the exact correlates of protection against COVID-19 in terms of antibody titers. This is one of the reasons the CDC has come down heavily and said that people who have suffered from COVID-19 vaccine, or those who have taken COVID-19 disease, or people who have had vaccination, should not routinely undergo antibody titers at all. And even if the antibody titers are 0, we do not know whether the vaccine has done the trick or not. We do not know what type of T cell response, B cell response has occurred. And even if the antibodies are good, we don't know. The antibody kits that are available, I'm afraid each one uses one technology. We don't know which one is right, which one is wrong. So currently, we should not be testing. And you asked Dr. Ramkant to keep quiet, wait until more data is available. Maybe we will come up with correlates of protection very soon. That comes up maybe if it is available, if there is a good test available and the recommendations agree on doing it, he can perform it.
That's a good take.
The next question, I think before we go to the flu, I think any of the experts, when would be a pediatric vaccination against COVID become a reality in India? That's number 1. Number 2, of the licensed vaccine in India, which would hit the pediatric population. And the third part of it is, are any vaccine trials for pediatrics on in India? Bala, Kasi.
Okay, now regarding the picture for COVID vaccines in children, both the mRNA vaccines have completed trials in the 12 to 15 years age group and are licensed for use in the United States and Europe, Canada, and many other countries. Both the Pfizer and the Moderna vaccines are undergoing trials in the younger age group, right from 6 months to 15 years in different age strata. In the lower age groups, there are going to be dosing studies, whereas in the higher age group, they're going to directly a immunobridging study. There's going to be no efficacy studies as far as children are concerned. According to the predictions, probably the Pfizer vaccine may receive EUA for children by about September of this year. Okay, now that is as far as the international scenario is concerned. Now, as far as the two existing vaccines in our country, we all know that Covaxin has already commenced its trial in children between 2 years and 17 years. As far as Covishield is concerned, they had a small study going on, not from India, internationally, of just around 300 subjects, where they were comparing it with a meningococcal conjugate vaccine. But with the reported adverse effect of the thrombocytopenia, that particular study has been kept on hold. Now, if Covaxin comes through in its childhood study, I mean, they are still just recruiting. I think we may not see a COVID vaccine in children not earlier than 2022. But if the mRNA vaccine comes into EUA for children abroad, and the same vaccine is available in our country, then probably children may receive a COVID vaccine earlier. This is my take.
So today itself, Zydus has declared that they have completed pediatric trial, and if they are permitted, they can in fact start it from this month onwards.
Yeah, so
this is the news that I have.
Yeah, what is the take is that Zydus trials are completed phase 3 above 12 years, and they would be available in the market in mid-July, licensed above the age of 12 years. Whether government will permit or not, that's a different story. But the biggest challenge is it's intradermal with a specific device, and you need to give 3 shots. So compliance is going to be an issue. Second, AstraZeneca, I think they have a bridging study from the UK, and on the same base, they are going to look at licensure of the vaccine in India. And last, I think the Serum Institute is having a fast track clearance from DCGI for the Novavax, which is the US based called Covax, when 920 subjects have to be recruited from July 15th to August 15th. And they are looking at licensure from 2 years because we are a part of all these trials. So all these trials would get licensure, but as Assis sir told, the licensure will come, but the priority would be to vaccinate about 18 years, and that's still a large volume. So even if the licensure comes, it will be available to an pediatric population and pediatricians who are listening. It would be a reality to happen from Jan 2022, not before that. That's the reality of COVID vaccine availability in the pediatric population. I think that's the scenario which is there as our first COVID vaccine in India.
The one good news is
can I give a comment here, please?
Sure, sir. Most welcome.
Yeah. Now, in a country where less than 10% of the population have received 1 or more doses, I think we should concentrate more on vaccinating above 18 years before we get into pediatric vaccination. I think if you are able to protect people above 18, I think that is as good as vaccination for children. So our priority right now is to concentrate on vaccination above 18 years and not waste on children currently. If the threshold, I don't know, the public health experts have to decide, if a particular threshold is reached in terms of the percentage of people above 18 years of vaccines who have been given the vaccine, is a particular threshold is reached, I think that is a time we should start pediatric vaccination and consider pediatric vaccination. Currently, if you ask me, pediatric vaccination is not a great priority in a country like India. Of course, this may be an unorthodox view, but this is what most public health experts abroad also are thinking.
That's fair. I think Bakul wants to add and Kasi wants to add a few comments.
Yeah, I think I agree with what Dr. Bala said. Even in USA, they have opened up, schools and all are functioning, but they have vaccinated about 65 to 70% of their adult population. And moreover, studies have shown that in general, one, the disease is milder in children. The second thing is children are not the drivers of transmission in the community like influenza virus. So by vaccinating children, you may not reduce the incidence of the illness in the community. And thirdly, we know that COVID causes MISC. What is going to be the effect of the vaccine? Will it also cause MISC? All these things have to be investigated before the vaccine is approved for use in children.
Rajendra, you want to add?
Kasi, already a messenger RNA vaccine has caused a problem in the US with myocarditis.
Yes. So we are seeing, so I think we have to be careful. It's better to be a little careful rather than trying to be, too much of a proponent of childcare by saying no, children also should get it right away. I think Dr. Bala has presented a very, very balanced view of things.
Bakulba, you want to add?
I just wanted to say that the seroconversion has occurred to almost 55 to 60% in children also without vaccination. And in adults is around 65 to 70%. So I don't know what is the importance of that if I want to ask Dr. Kasi or Dr. Bala.
Well, seroconversion has occurred. What will be the longevity? We even do not know whether naturally induced immunity is going to last longer or vaccine-induced immunity is going to last longer. All these things are gray areas. I have an answer to your questions.
No, but children without taking even vaccine, they have been seroconverted. Is it like something like herd immunity?
It should. See, I can tell you something. But in our own institution, when we did the seroprevalence study last year, it was around 20%. And I'm told the National Institute of Epidemiology in Chennai is doing a sero survey. They are telling us nearly 55%, even amongst children, are now showing antibodies in Chennai, particularly in North Madras, very crowded areas. But I am sure the percentage of seropositive people is going to go up and up. But we don't know whether the seropositivity is going to protect against new mutants or not. Nobody knows.
That is the issue.
So we have to wait for some more time to know. But it is very likely that those who are seropositive might have had asymptomatic infection and might have recovered. And it is very unlikely that they will again develop serious COVID-19. Of course, they may develop MIS-C.
I think so. I think the first 40 minutes have gone on COVID vaccine. I hope most of the queries and concerns of pediatricians at large are cleared. The next question, I think, will be to Bakul Bhai, the task force recommendation, not recommendation. There's a huge surge of parents coming to pediatric OPD, and the only vaccine every mother wants to get their child is the flu shots. So what is your take? What should be our stand? Can flu and COVID vaccine, of course, they cannot be given to a pediatric population. And is there any off-target effects of flu against COVID-19? I think they have just heard and just rushing to pediatricians OPD to take the flu shot. So what's your take, Bakul, on that? And if other experts want to really opine on that.
Yeah. So first of all, the task force, since you referred to, it was the sentence was taken out of context by the companies who are producing this flu vaccine. And they use that particular sentence to sell their product. That is one. Secondly, flu vaccine, we have been advising since years, till the age of 5 years, as per our SCVIP guideline, to be taken 2 doses at the interval of 1 month, and then between March to maybe April to July, we give one more dose every year, whichever is the latest vaccine we use. So there is no question of confusing between the two. But then the task force has discussed that flu vaccine or flu disease itself can mimic COVID-19 disease. And so to avoid that confusion, it's better that those who have not taken flu vaccine may take this. It was suggested by one of the persons in the task force, and that was taken out of context. So I don't say the flu vaccine will protect you against COVID vaccine, but yes, if you are ready, you can take this vaccine till the age of 5 years during that particular period, and that's all. And both the vaccines can be given together because there is no harm in giving both the vaccines the same day.
Absolutely right, sir. And I feel there are certain indirect, helps what we could get by vaccinating against influenza, because as this chart tells us that they both present with the similar kind of symptomatology. They have, there are in fact cases of co-infections. In fact, they have a similar risk factors which provide both of these diseases. So there is a point in actually, and below 5 years, anyway, we are at, Bakul sir has rightly said that below 5 years, anyway, we are advocating all of them. Only question remains is, above 5 years, these parents are coming to you and asking you a vaccine. Now, what should we do? Should we really deny it or should we give it? I do not know. Means how to counsel them, in fact, negatively also. That's a problem.
So why give negative counseling?
I mean, anyway, we are suggesting it has been told that you can give it only for high risk kids.
No, we can say that to avoid that concept of in flu vaccine protecting against COVID-19, we should make it very clear.
That should be clear.
Yeah, but otherwise, if parents are coming on themselves and they want to take flu vaccine, why we should deny?
Yeah.
COVID-19 itself is a special situation.
Yeah, that's a comorbid.
That
You can
itself
take.
is a special situation. Yeah, Vaidya, you want to add something?
There was a beautiful study from Brazil, and I think published in June 2020. More than 90,000 subjects which are given trivalent flu vaccine, and it showed significant reduction, almost 8% lower bound in intensive care, 18% lower bound in respiratory support, and almost 17% lower bound in the death. So Brazil study has given that they are definitely having, not directly avoiding COVID, but they are having some additional benefit with the flu vaccine.
I think that was an observational study, and observational studies are quite low in the hierarchy of evidence.
Yeah,
Not
but
enough
Almost
to
level
be
3 evidence.
But subject was more than 90,000, so that was a little plus point of that.
Yeah,
So
I think,
this
Ganesh,
universal dosing regime, as you know, we have shifted to 0.5 ml, but still we are getting 0.25 ml available in the market, and it is coming to us. I do not really understand what to do with this. No, should we keep on giving 0.25 ml, or should we really switch over to 0.5 ml?
I think we had discussed in ACVIP, Dr. Kasi can clarify further, but 0.25 has been passed. The manufacturers, they have done some studies and they are giving those doses, and also DCGI has given approval. So in fact, we have said that all those vaccines which have been getting the DCGI approval and they are recommending 0.5 ml as universal dose, we advise. But the one brand which is available in both the strength, there the manufacturer has done some studies and has given has been given the approval by DCGI. So we continue till it is available. We cannot say no. But I think Dr. Kasi can throw more light on that.
Yeah, I think that's it. I mean, basically, the concept of differential dosing was based on the old wholesale influenza vaccines, which were very reactogenic in the younger age group. There was a much higher incidence of fever and febrile convulsions, thus the differential dosing. But now with the use of purified vaccines, split virion, subunit vaccines, the reactogenicity has almost disappeared. It has always been noticed that the immunogenicity of influenza vaccine in those below 1 year has always been suboptimal compared to the older age group. So the concept, why not give the same dose? First, it was found that there is no increased reactogenicity. And subsequently, when they did the immunogenicity studies, some studies have shown statistically significant superiority of the 0.5 ml over 0.25 ml, specifically for the B strains and the H3N2, whereas some studies have uniformly shown, Varsha Jain study has shown that, I mean, it has statistical superiority for all the 4 strains in the influenza virus. So taking this into consideration, the ACVIP, in keeping with recommendations in other countries also, has now advised a uniform dosing. Now, the reason why 0.25 ml has not been thrown into the dustbin has been mainly made with consideration of the people, manufacturers who still have a DCGI recommendation for 0.25 ml. But I think we have to be very clear that 0.5 ml is better than 0.25 ml.
The next question, I think COVID vaccine has really opened a huge Pandora's box on vaccination at all the ages. The man with his kid due for vaccination bowled out asking, "Doc, I have got all my childhood vaccine. Do I need to take few more vaccines? And what are the take on the various adult vaccinations which we would suggest in practice?" Dr. Bala?
Yeah, I think unlike pediatricians, adult physicians don't concentrate much on vaccinations, probably because vaccinations are not their breadwinners. We do give a lot of importance to vaccinations. You know, even in pediatric practice, the moment the child reaches around 5 years of age or 4 years of age or 3 years of age, parents forget vaccination. So it is not surprising to find a lot of adults not receiving vaccinations based on the necessity. For example, I know senior citizens above 65 should have, above 50, it's 50, should have taken pneumococcal vaccine. Many doctors, when I ask in some meetings, most doctors have not taken. Most doctors don't take influenza vaccine annually. Doctors who go abroad, they only then they will think of Tdap vaccine. When they are in India, they won't think of Tdap vaccine. Many doctors would have never taken a typhoid vaccine. So if this is a situation amongst doctors, you know, adults are all as much prone to many vaccine preventable disease, notoriously pertussis. In fact, I believe even in US and Europe, there is a resurgence of pertussis even among adults. So Tdap vaccination, and they only end up taking tetanus toxoid, useless vaccine when they get an injury. They should take Tdap when there is an injury rather than TT. And varicella, they think of varicella only when there is an outbreak in an IT company, they come running for vaccination for varicella. And they think of MMR vaccination or they think of meningococcal vaccination only when their son is going to US university or to UK. And they think of hepatitis B only when there is somebody who's diagnosed with chronic renal disease about to undergo dialysis when the nephrologist talks about hepatitis B vaccine. So immunizations are as important for adults as for children. This is a concept which should spread across. You know, in Chennai, there is one ID consultant, Dr. Ram Surani, who runs a clinic called Booster Clinic. He is the only adult physician who runs a vaccination clinic as far as I know in Chennai. So that should be top priority as much as pediatric vaccination is a priority for pediatricians.
But the question is, sir, who should be the stakeholders? Can pediatrician give a vaccine to adults? Because physicians are not really interested in giving vaccines.
Yeah, I can tell you what I am doing in my clinic these days. Whenever they bring a child for illness or wellness or for vaccination, I immediately ask them, have you all taken COVID-19 vaccines? And I ask the mother, have you taken HPV vaccine? I tell them that please go consult your gynecologist or your physician, take appropriate vaccination advice. And I ask, particularly with regard to COVID-19, I tell them whoever is an adult in your house, please go and take COVID-19 vaccine to protect your child. And I have received any number of phone calls from lactating mothers asking for advice on COVID-19, and I have categorically said, please go and take immediately. Of course, the only question that is difficult to answer when they ask for a preference of Covishield or Covaxin. But otherwise, most of the answers are straightforward. If they want to vaccinate, I do give vaccines in my clinic.
Going back to Vaidya sir, an ectic full-term normal child needed exchange transfusion done on because of RH incompatibility in day 2 of life. Can BCG, zero OPV, hepatitis B given to this baby? And what about the other live vaccines?
Yeah, definitely, because BCG is T-cell immunity-driven vaccine. OPV, even though it's a live, it's oral vaccine, it's not going to hamper anything. And hepatitis B is skilled vaccine. So there is no contraindication after giving any transfusion or any immunoglobulins. Definitely, is a live vaccine, particularly injectable, are contraindicated when you are giving some blood products. But anyhow, these are hardly 2 days of the life. These live vaccines we are anyhow going to do after 9 months, particularly. So depending on the contents of the immunoglobulins, we can use it. If you're using a fresh blood, then you can use every 6 months. We are given immunoglobulin high doses, then maximum is 11 months. So live vaccine you can give after 9 months, there's no problem. And at birth, you give all vaccines. Even at 6 weeks, you can give DPT, Penta, Hexa, what you want. Even Rota is over live, which is still oral, you can do that also.
Sorry to interrupt, but last 5 minutes, we would love this to go on. But
We'll just wrap up. We'll just wrap up fast.
Last 2 or 3 slides. A 5-year-old male chronically ill defaulted most of the vaccines, diagnosed to have CKD. Of course, sometime it comes in practice. Now comes for hepatitis B vaccination before starting dialysis. Kasi, in short, what would be the strategy? One-liner.
Fine, he does need hepatitis B. Unfortunately, he has come too late because the efficacy, the immunogenicity of hepatitis B vaccine depends upon the GFR of that patient. And we know if he needs dialysis, GFR is very low. The vaccine is not going to work too well. Well, if it was an adult, we could easily have advised 40 microgram in a 0-1-2-6 schedule, which has been found to be immunogenic. But such a recommendation is not there for children. So we would still go with a regular dose of 0-1-6, check the antibody titers, repeat another schedule of 0-1-6 if the response is not there. Double dosing is being used off-label by many pediatricians in special situations.
Next slide. Yeah, I think.
Bakul sir, last 5 months, this child was taking inhalers and now he's due for chickenpox. Just because he's on inhaler steroid therapy, should we wait or should we go ahead and give it?
please go ahead and give the vaccine. It doesn't cause any problem.
Yeah.
It doesn't cause any immunosuppression.
Then I think with the newer additions of a lot of pneumococcal vaccine coming, how to choose an ideal PCV vaccine? Kasi sir, you can take it. Does serotype means a better coverage? Do method of conjugation and the conjugate protein makes the difference? And serotype coverage is a very dynamic process. So how we can ensure that we are hitting the target wall? This is reference to an Indian licensed vaccine, 10 valent, the old one, the 13 valent, the old one, and the 10 valent new one. Your take on the new pneumococcal vaccine?
Okay, now first, ideal PCV vaccine should have the maximum serotype coverage. It should have very high overall protection, direct protection of infants and children up to 5 years, not just the vaccinated cohort. It should reduce the nasopharyngeal coverage because that translates to heart protection. It should also elicit high antibody titers because that translates into better mucosal protection and protection against mucosal disease, specifically pneumonia. And remember, in our country, it is for pneumonia that we are giving the pneumococcal vaccine, not essentially for IPD. I mean, the vaccine scheduling should be compatible with our existing schedule. And the WHO, product profile says that it should be capable of being administered with the first dose at 6 weeks or even earlier. So these are the choice of an ideal. Now, does more serotype mean better coverage? Generally, I would say yes, because if you're having lesser number of serotypes, you are depending upon indirect protection or cross protection, which is definitely inferior to direct protection. Now, there is some data to show that the method of conjugation definitely makes a difference. Now, regarding the PCV10, that is the Synflorix and PCV13, now PCV10, the linkage of the polysaccharide with the carrier protein, you see that method is called deamination for PCV13. Now, in that process, what happens, the polysaccharide, the closed polysaccharide structure opens up. So it changes the epitope configuration, and thus the immunogenicity may be lower. Whereas with the PCV10, they're using what is known as a cyanylation method. In cyanylation method, the structure remains intact. And so the native protein configuration is maintained, so immunogenicity is better. And that we know, especially with 19F, the immunogenicity of PCV10 is definitely better to the 19F, which was there in PCV7. Now, serotype coverage is definitely dynamic. It just means we got to go on adding more and more serotypes as we have more and more serotypes discovered in our surveillance. I mean, there's a limit to how much you can increase. Now we are almost come to 20 valent. I think the answer is going to be having a protein polysaccharide, protein vaccine, which will depend more upon the conserved epitopes and which will have a much longer and more broad-based protection.
Okay.
Now, just one quick comment, Sanjay.
Sure,
now, 20-valent vaccine has been approved by FDA for use above 18 years.
Yes.
And the 20-valent vaccine is said to protect, is said to cover strains which cause 40% of disease and deaths in the United States. So I am very sure it will soon be approved for pediatric use, and that will give better coverage. The best pneumococcal vaccine is yet to arrive.
And last question for the day. The pneumococcal vaccine used in the NIP in few of the states is 2+1 schedule at 6 weeks, 14 weeks, and 9 months. If the same vaccine, of course, the government is going to roll out the program maybe next year. It's been delayed because of COVID. Should a pediatrician practice the government schedule, or should he follow the recommendation scheduled by the IAP? Is the take, and that's the last question. Kasi, Bala, and we close the day.
Okay, I think ideally he should follow the IAP schedule, because that is a schedule which confers the best protection without any compromise on the efficacy. At the same time, I would say that even one dose is better than no dose. So in this situation where the question of affordability is really very, very true, I mean, after due explanation, I will offer even a abbreviated schedule like the government schedule in my private practice also. But that is provided I have given adequate information for the patient and telling him that the choice is being done by him.
Okay, I think that's for the day. I must thank all the panelists for giving their crisp, and I hope the audience at large have actually, our focus was mainly on the COVID vaccine and the surge of the flu vaccine in day-to-day OPD in last 2 weeks. I hope all your queries for COVID vaccines are sorted out. And I think my request to all of you, when you are into practice, see that every parents of every child who comes to your OPD gets vaccine and motivate them to take COVID vaccine. There is still a vaccine hesitancy in a large number of population, and we should do our job to see that each one of the parents or grandparents which visit to our OPD gets the COVID vaccination. I think final comments from Ganesh, and I think we close the day.
No, in fact, it was great learning. This has always been a great learning, and that's the reason why I want to be associated with all these stalwarts. Every time there is something new to learn, and that sets up a passion to read much more again. Thank you so much. Bakul Bhai was, in fact, he was on his travel. Despite that, he logged in, and I was so happy to see him. Vaidya sir at 11th hour, in fact, few minutes before I called him and asked him, can you really join? And he agreed. Kasi sir and Bala sir, as usual, wonderful, wonderful. We think that we keep on listening to you all years and our rest of our life together. Still, the life wouldn't end. And that's all. Thank you so much for being there. And thank you, Sanjay sir. Thank you, organizers, for giving us this opportunity.
Thank you.
Thank you very much. Thank you very much.
Thank you.
Thank you all the panelists for a wonderful talk and a great discussion as expected. All of you all being stalwarts, and it gives us immense pleasure to keep listening to you always. And I have a quick thank you for Dr. Rajendra Vaidya for just pitching in quickly at the last moment. Thank you so much, sir.
Thank you. Thank you. It's my pleasure. It's my pleasure to be with all stalwarts.
Not at all limbu timbu. It was really very good inputs.
ये नींबू में पानी बहुत है.
अच्छा है सर, येडे नींबू नहीं बोले.
IAP, I thank all the panelists, the moderators, as well as the delegates for attending in such huge numbers. It has actually been an academic feast over the 2 days, and it will be difficult to forget what we learned in these 2 days. So really thank you so much, and we'll move ahead to the valedictory function, and I would call on board Dr. Sanjay Nathu to take over the proceedings.
Thank you, Sushruta, and as rightly pointed out, an excellent session. This vaccine dialogue was for the last hour or so. We were just enthralled listening to so many important points which parents keep on asking to us. So thank you all the faculty. So in this short valedictory function, I would like to begin by thanking all the faculty, the esteemed speakers who made this conference what it was by sparing their time and coming online in spite of all the problems, the technical issues, and then deliberating and giving us so much knowledge over this 1.5 days. So thank you all the faculties, the moderators, the chairpersons for making it worthwhile. I would also like to thank the office bearers of the infectious disease chapter, Yagnesh Popat sir, Dr. Kea ma'am. So they were the pillars who helped us make this conference successful, the CME successful. So thank you ma'am and thank you sir. Dr. Pramod Kulkarni, the secretary of IAP Pune, was the most instrumental person in drafting the program for this CME. So special thanks to Dr. Pramod Kulkarni. Of course, my whole team, Dr. Deepak Moye, Dr. Parag Gaikwad, Dr. Shirish Kankriya, Dr. Sandesh Runwal, Dr. Sushruta, Dr. Dhokha, Dr. Manisha. Dr. Sushruta, Dr. Manisha and Dr. Sandesh also did a comparing duty, so special thanks to them. Our back office, Sheetal, the IAP Pune office secretary, has been a pillar in helping us in so many ways. And the DigiShield platform, which was made available to us for this 1.5 days, we troubled them a lot as far as the registration and the technical issues were concerned. But they were up to it and they kept on supporting us without losing their patience. So thank you to DigiShield. I think that is it from my side. Dr. Kea, ma'am, would you like to comment?
Good evening. Thank you. I enjoyed every moment of this conference, though, as I said in my inauguration lecture, we missed the hospitality of the IAP Pune, but it was an excellent, meticulous conference, very well planned, very meticulously implemented. Thank you and congratulations.
Thank you, and I cannot miss mentioning Dr. Anand Deshpande, the EB member from Pune to Central IAP. He was supportive throughout the drafting the scientific program as well as the selection of the faculties and throughout the program as well.
Thank you. Thank you.
Dr. Popat has just joined us. He's
Dr.
traveling.
Deshpande, it was wonderful to have the neonatal sepsis session also yesterday.
Thank you.
Yeah. Dr. Popat, sir. Yes, sir.
Yeah. It was a wonderful experience all throughout 1.5 days. All faculties, I thank them for their wonderful presentation, crisp messages delivered in a stipulated time. So I thank all the faculties, chairpersons, moderators for sparing their valuable time and the efforts in organization of this event. I also thank the Pune branch, the Dr. Sanjay Natu and Dr. Pramod Kulkarni in particular, who have arranged everything in such a particularly excellent way that the conference was definitely a success. To organize a webinar for a 1 or 2 hour is not is a simple job. Anybody can do it. For organize it for a 1.5 day, involving so many stalwarts in the field who are spread across the length and breadth of the India is not an easy job. So I congratulate Dr. Pramod Kulkarni, Dr. Sanjay Nacho, and whole team of Pune IAP who delivered their best and organized their conference in the excellent way. As I said in the morning also, I missed meeting you physically, but maybe next time. It was miss on our part rather than their part. We miss the hospitality of Pune. Thank you, sir, for an excellent presentations and organization. I thank the scientific committee also, including Dr. Abhay Shah, who had designed the program in such a way that everybody was interested. Nobody wanted to leave the digital platform. And the communication and digital platforms were also excellent. I thank all. It was wonderful experience. Thank you all. Thank you.
Thank you so much, sir. It was a team effort, sir. Not to point a single
Definitely,
person.
it has to be a team effort, but it was excellently led by both of you. The leaders definitely make a difference in the team.
It is always
Thank
a
you,
team
sir.
effort, but it is a great team.
Yeah. Thank you so much, Bakul bhai.
Great team. Thank you.
Hello, Ganesh.
I totally agree.
Yes, Bakul bhai. But the leader makes a leading from front is definitely.
Yeah. So leader is important, but leader without a proper team is also not important. So I think ultimately it's a team.
team with a.
So,
That's why.
sir, both
That's why
team
you are
and leaders, both are important, sir, equally.
So that's why it's written behind
Let's
you, sir.
end the debate
Together we
with
can.
saying both are important.
Yes. Sir, our captain and vice captain is too good. So it's very easier for us to play the match and win it with it properly.
Because your captain and vice captain both are match
Bigger
leaders.
team of IAP IDC. That bigger team is there. That's why we are here. Thank you so much.
Yes, but the leader is as good as his team. So
Absolutely.
leader and team both are very important, and it was an excellent conference
I enjoyed
organized
meeting
by ID
by
chapter and Pune IAP.
That is why I did it. So that was
Thank
also,
you,
I
Jain
think
bhai.
that
Thank
should
you.
be done.
Thank you, Pramod bhai, Sanjay.
Yes,
And
sir. Thank you, sir.
Team IAP Pune and Team IAP Infectious Disease chapter. Thank you.
Team
Thank
IAP
you,
Pune.
thank you, Dr. Jayant.
Team IAP Pune is infectious in developing more and more friends.
Thank you, sir. Thank you, sir.
Thank you.
Bye.
Okay, sir.
Thank
On this
you.
note, I think we'll
For
call it a
physical
day.
meeting at next conference in Pune. Everybody of you. We are eager to welcome you all and offer our hospitality for you.
And we are also eager to come there.
Definitely, we will wait for the
We are
opportunity.
looking for it. Pramod, we are looking for it.
Okay.
So this conference was like a bonus. We are going to have a physical one next year.
Yeah, the full course is awaited.
The hospitality is still due on Pune IAP.
Exactly.
ये खाली breakfast था, lunch और dinner बाकी है, ये खाली breakfast था.
And Jayant, in that case, what we will do is we will have only hospitality next time. No scientific program.
Yeah, one day hospitality holding.
It will be our pleasure, sir. Anytime. You all are most welcome.
Thank you very much.
यज्ञेश भाई, एक सजेशन ऐसा है कि कुछ टीए डीए इशू करवा दीजिए जिन्होंने अटेंड किया है, घर पे बैठ के बुला के खा लो बोलना, हो गई हॉस्पिटल।
मैं हमेशा बोलता हूँ ना, जोमेटो का कूपन भेज दो 1000 रुपये।
चलो, nice.
Bye.
Nice.
Thank you. On this note, sir, I think we'll call it a day.
Yes. Good day.
Request
Good day,
Piyush,
everybody.
you can just end the session.
Bye.
Bye.
Thank you. मस्त झाला रे.